Tissue integrity diminishes over time, largely as a result of calcification. Tissue valves are exposed to a variety of calcification sources. Free aldehydes are one of these sources of calcification. They accumulate in the tissue during the glutaraldehyde fixation process and throughout valve storage. Collagen is a structural protein material that makes up 75% of bovine pericardial tissue. Bovine pericardium collagen is multi-layered and multidirectional, helping to give the tissue material strength and flexibility. Resilia tissue is bovine pericardium that has been transformed by a novel integrity preservation technology that virtually eliminates free aldehydes through the combination of two proprietary features. The first feature is stable capping, which permanently blocks free aldehydes in the tissue, preventing calcium from binding in vivo. A sheep study demonstrated 72% less calcium content after 8 months in valves with Resilia tissue. In addition, the COMMENCE surgical aortic trial showed that surgical valves with Resilia tissue demonstrated strong clinical outcomes and excellent durability at 7 years. The second feature is glycerolization, where water is displaced with glycerol, removing the need for preservation in liquid solutions like glutaraldehyde. This prevents further exposure to free aldehyde groups, thus protecting and preserving the tissue's integrity and enabling storage in dry conditions. Tissue integrity diminishes over time, largely as a result of calcification. Tissue valves are exposed to a variety of calcification sources. Free aldehydes are one of these sources of calcification. They accumulate in the tissue during the glutaraldehyde fixation process and throughout valve storage. Collagen is a structural protein material that makes up 75% of bovine pericardial tissue. Bovine pericardium collagen is multi-layered and multidirectional, helping to give the tissue material strength and flexibility. Resilia tissue is bovine pericardium that has been transformed by a novel integrity preservation technology that virtually eliminates free aldehydes through the combination of two proprietary features. The first feature is stable capping, which permanently blocks free aldehydes in the tissue, preventing calcium from binding in vivo. A sheep study demonstrated 72% less calcium content after 8 months in valves with Resilia tissue. In addition, the COMMENCE surgical aortic trial showed that surgical valves with Resilia tissue demonstrated strong clinical outcomes and excellent durability at 7 years. The second feature is glycerolization, where water is displaced with glycerol, removing the need for preservation in liquid solutions like glutaraldehyde. This prevents further exposure to free aldehyde groups, thus protecting and preserving the tissue's integrity and enabling storage in dry conditions.
Good morning, everyone. Today I have the privilege to have the kickoff session of this fantastic meeting, which is been going on for lots of years. And now it's been a tradition for the whole the southeast of Europe, and is on everything new on transcatheter heart valves. We have a fantastic panel with moderators, with Dr. Mavrogianni from Salonika, Dr. Karabinos, a well-known expert in echo, and Dr. Koutousis. And we will start immediately with the first talk from Dr. Karamassis, who is going to say everything that he is going on TAVIs in cardiogenic shock. George, please have the floor. Thank you very much.
Thank you very much, Professor. It's Grigoris, of course. I would like to thank Dr. Sparias, Mr. Patakos, and the organizing committee for the invitation to participate in this very interesting session. I will talk about TAVI in cardiogenic shock. Aortic stenosis is not uncommon in patients presenting with acute heart failure, as we see from this large European registry. What is more important, though, is that aortic stenosis is a factor that predisposes for adverse clinical outcomes, as you can see on the right hand of the screen. From our data in Atiko University Hospital, from the data that the cardiogenic shock team that we have developed has accumulated, we see that severe aortic stenosis is the cause of cardiogenic shock in around 7% of the cases. It is a small number, but still important, since we can do something for this patient and improve their outcomes. I will take a step back and go to the pathophysiology of cardiogenic shock, just to remind you that cardiogenic shock is not just a dysfunction of the left ventricle. It involves mechanism of ischemia, vasoconstriction, congestion, and inflammation. And through this mechanism, a vicious cycle is created, a spiral, that at the end, if there is no intervention, it will lead to the death of the patient. And as you can see here, we try to intervene in this spiral, for example, with revascularization in the case of acute myocardial infarction-related cardiogenic shock. It is similar with aortic stenosis. A similar thing happened. Aortic stenosis causes subendocardial ischemia. It decreases the preload, it increases the afterload, and then it leads to acute decompensated and at the end death. So it is important to intervene in order to break this cycle and improve the outcomes of the patient. As cardiac surgery is extremely high risk in these patients, historically, balloon valvuloplasty has been proposed for this patient. But as you can see in this table, which accumulates all the registries that have been published on the BAV in cardiogenic shock, 30-day mortality remains very high. As you can see, and I will look at the bottom of the table where the more recent trials are, mortality is 40, 50% or even more. So BAV is, although it may offer something, is not the best treatment for this patient. Having this in mind, the last 10 years, TAVI has been proposed as an alternative, and you can see in this table the registries that have been published up to now. I will highlight three things. One is the small number of this registry, with the exception of the one from STS that I will talk about it later. The other is that, yes, the mortality, the 30-day mortality is much reduced if we compare it with the mortality from BAV, but still it is quite high. Nevertheless, most of these publications come from an early era of TAVI. So recently we have this important publication in European Heart Journal. It was published a few months ago in 2023, and it comes from the US, presented data from the STS ACC registry. These data are quite contemporary, as the study runs from 2015 to 2022. As you can see, this registry is a huge registry with hundreds of thousands of patients. 1.6% of them, it's a bit difficult to solve, so I cannot do it. 1.6% of them had cardiogenic shock. Cardiogenic shock was defined in this study as coding of cardiogenic shock, pre-procedural use of inotropes or mechanical circulatory support or cardiac arrest within 24 hours prior to TAVI. I will also highlight some baseline characteristics, which is important in order to understand this study, and maybe it will be helpful for the discussion later. The mean age was 75, so these patients were quite young. The ejection fraction was around 40, so it wasn't that low, and less than 10% of them had a prior BAV. What the researchers did is that they did a propensity score analysis. So they had almost 5,000 of patients with cardiogenic shock and compare them with similar patients that did not have shock. And you see the 1-year results. Mortality in patients with cardiogenic shock is obviously worse. But what I find more interesting, and actually it's more important in this study, is the 30-day landmark analysis that you can see on the right hand of the screen. You can see that in 30 days, mortality in patients who underwent TAVI and had cardiogenic shock was 13%. But after the 30 days, for the patients that survived, mortality was not different between the two groups. This 13% is much lower than the percentages that we saw in the previous studies. Nevertheless, we have to consider that this is a retrospective study, and obviously there is a selection bias, as these patients were selected, they were deemed eligible to have TAVI. Another important conclusion of this study was the predictors of mortality, and I will only mention renal dysfunction, end-stage renal dysfunction dialysis, which was the most important predictor of mortality for these patients, both in 30 days and in 1 year. So based on this unmet need, the unmet need on treat patients with severe aortic stenosis and cardiogenic shock, and the data that I just presented, the international scientific communities proposed TAVI as a solution for them. And here you see a consensus document from the European Heart Failure Association, EAPCI, and Acute Cardiovascular Care Society. And as you can see, if there is cardiogenic shock in a patient with severe aortic stenosis, the patient can undergo emergent TAVI or balloon valvuloplasty if TAVI is not available, or as a bridge to TAVI. Another similar consensus document that actually involves the working group of cardiovascular surgery compares the theoretical benefit of BAV and TAVI. And we all know them. Obviously, with BAV, you don't treat the stenosis. There is a risk that you have aortic regurgitation, but BAV is maybe more available, it's easier, and definitely it's cheaper. Another important conclusion from the small studies that had applied BAV in patients with aortic stenosis is what we know about cardiogenic shock. And what we know about cardiogenic shock is that it's a clinical condition that is time dependent. The later you do the intervention that is needed for the patient, the worse the outcome will be. And we can see it here that in the right hand, in the Kaplan-Meier curves on the right hand side of the screen, patients who underwent BAV in less than 42 hours from presentation did better than patients who had balloon valvuloplasty at a later time. Another study that came from Germany that I found interesting was the one that compared emergency TAVI with emergency balloon valvuloplasty followed by an elective TAVI. And what I find interesting in this study is that the 30 days mortality on the patients that had the hybrid, let's call it this way, procedure, first emergency BAV and then elective TAVI, was quite high. As you can see, it was 22%, which is higher than what I expected, higher than what I think a lot of us would expect, and actually sets questions about this strategy and whether it is the best strategy or whether we should go straight with an emergency TAVI. But what we have to consider, and what is more important when we talk about this procedure, is the balance between benefit and futility. And from the consensus document that I showed earlier, this is the factor that we have to consider for futility or benefit. First of all, age. If there are other comorbidities in the patient who presents with severe aortic stenosis and cardiogenic shock, if the gradient is low or high, as you can see here, if the gradient is low, the experts, the authors, propose that it is futile, maybe futile to perform TAVI. How long does the symptom last? The experience of the center that's going to do the procedure, and if there is possibility for transfemoral TAVI. All these are things that we have to consider when we think that when we balance utility versus futility. But what I would emphasize, and what in my opinion is more important, is time. As we know, and I will show this slide from Mayo Clinic that actually refers to all shock types. The deeper the shock stage, the worse is the outcome. And when the shock is very advanced, when the shock is at stage D or E, you can see that in-hospital mortality reaches 70%. That means that whatever we do, we have to do it early. I will close my presentation with some considerations, starting with technical considerations. First of all, what has changed actually, in my opinion, the TAVI procedure is the planning with the pre-TAVI CT. So we have to think if it is feasible, and we have to push to make it feasible to do a TAVI CT in these patients, even if they undergo an emergency procedure. There are alternatives. We can use 3D echocardiography to do the valve measurements. We can use ultrasound or classical angiography when we perform the coronary angiogram to see the peripheral vessels. Definitely, the femoral access is the way to go. Regarding valve choice, there are no data supporting one valve or the other, so each one should go with a valve which is more comfortable with. The management of the concomitant coronary artery disease, we have to be minimalistic. We have to do only the things that are absolutely necessary. Critical proximal disease in large vessels like left main stem. And the use of interprocedural mechanical circulatory support is feasible. There are cases presented with ECMO or with Impella, but it has to be applied only if it is absolutely necessary. And this is my last slide before the conclusions, and I will set some considerations regarding TAVI cardiogenic shock in Greece. We have to think what is the reality in Greece and what we can achieve in our country. First of all, we have to think about the centralized way of valve reimbursement. We know how this happens. The reimbursement comes for a specific patient. Obviously, this is not possible for an urgent procedure, so maybe in these procedures, this approval, the centralized approval for reimbursement should happen retrospectively. More important is the long waiting time list in public hospitals. So there must be parallel pathways for the patients that they need an urgent procedure. There is the National Registry on TAVI Centers outcomes, and this registry should take into account the condition of cardiogenic shock, because obviously it's very different to do, as I showed earlier, to do a TAVI in a stable patient without cardiogenic shock. Mortality would be extremely low, but in a patient with cardiogenic shock, mortality would be high. And this should not affect the evaluation of the TAVI center. And finally, this decision should be very well balanced by a multidisciplinary team, a heart team, but I would say also a shock team, clinicians that they are familiar and they treat shock cases, because we have to balance very well between benefit and futility. Benefit for futility, not only for the patient benefit, but also for ethical reasons. I think there is an ethical dilemma in Greece when a lot of people wait for TAVI for months. To do a TAVI, an emergency TAVI in a futile patient, maybe is not the way to go. In conclusion, TAVI in cardiogenic shock is feasible and an effective option. We should expect, though, worse outcomes compared to patients with non-cardiogenic shock, and we should accept these outcomes. The most important thing is the careful patient selection balancing benefit and futility. And I believe that balloon valvuloplasty remains a realistic interim solution, maybe as bridge to TAVI. Thank you very much.
Thank you very much, Ilias, for your concise and comprehensive lecture on a subject that we are not very used, especially in Greece, taking into account the problems that we've got with the way that TAVI can be approved, is approved, etc. So I would like, first of all, I would like to say good morning to Dr. Rubelakis, who is one of our commentators from, I hope, nearby, but not in the room. And I would ask Dr. Karabinos to make a few comments or questions to Ilias, and then we'll have one question from the audience and go on with the second presentation. Ilias, please.
Good morning, everybody. I'd like to thank Kostas and the organizing committee for this kind invitation. I come from Euroclinic, and it has just very recently started the program with TAVI after 5 years intermission. So we may have the opportunity to expand our experience in this field. Congratulations for this very thoughtful presentation. Just very few clarifications. You showed this TVT registry, which is really impressive. Over 15,000 patients from USA. It was with SAPIEN 3 valve.
Exactly. Yeah, only
it was not with core valve. The definition regarding the cardiogenic shock, which is a matter of interest, sometimes there is a confusion about definitions regarding, for example, inotropes, regarding blood pressure, which is not a mandatory prerequisite to define cardiogenic shock, since sometimes borderline pressures 9 to 10 or over 10 may coexist in cardiogenic shock. However, lactic acidosis is, there is always, and we have to look at that. Regarding BAV, I think it's okay. It's a solution when you don't have anything else to do, but the numbers are really very bad. 70% in some registries, the 1 year mortality. 3D echo, it may be a solution when this procedure has to be performed in an emergency condition. But we have to confess that we underestimate just 1 to 2 millimeters as compared to computed tomography. And we have seen that in a very recent meta-analysis regarding 3D echo in TAVI. So it may be just an alternative for the time being. So congratulations again. And I don't know, Chair.
Okay, thank you very much, Ilias. Are there any questions from the audience that would like to be clarified? Dimitris, Professor Alexopoulos wants to ask something.
In the meantime, can I make a remark? Thank you for your excellent talk, to start with. You had 7% of patients in your center with cardiogenic shock. How did you treat those patients? Were you able to do things?
They all died. They died, all of them.
Okay. I thought so.
Yeah. That's why I'm talking.
In a different direction in order.
That's why I'm talking about BAV. Although BAV is very suboptimal, maybe it is a way to gain some time. To gain time.
We do it all the time because you have to wait for a long period of time in order to get approval for your TAVI, and then your patients start to decompensate, and you have to do something about that, or else they die, as you said.
It's just a measure. It's just a measure to gain time, and maybe it gives you time, for example, to do the CT, which is necessary. Obviously, the 3D echo is not an alternative. It's only a suboptimal in emergency conditions. You do BAV if you cannot do emergency TAVI, and you give some time to the patients to organize all the other things. Just to make a comment, you are very right about the STS ACC registry. There are a lot of limitations. One of the limitations of the study is exactly what you mentioned. There are no data about hemodynamics. There are no data about metabolic issues like lactate acidosis. So this is a major limitation you have to take into account. So these patients that underwent TAVI in the registry, they were not in a critical condition, I would say. If you read carefully the manuscript, there were patients that they were maybe in cardiogenic shock, but not in a critical condition. Exactly. Worse.
Professor Alexopoulos, and one more, please.
Congratulations, Grigoris. I apologize, I missed most of your talk, but I looked at your conclusions, and the first one regarding the problems in Greece with the approval for the reimbursements, it's not a problem because in emergency cases like cardiogenic shock cases, we work on, let's say, hand by hand. We don't wait the 2 weeks process. It can take half of a day. So it's not a real problem. If there is an emergency case, we accept the applications and we approve it the same day.
Yeah, that's very reassuring.
Dr. Kilic wants to make a comment. Please do. We are very glad that you are here, participating in this Congress from Turkey.
Excellent presentation, thank you. I want to ask a question. Is there any comment about balloon sizes used in the study? Because we know that in the past, when they use larger balloons, this means increased risk of development of aortic regurgitation at the index procedure. So is there any comment on the study?
I don't remember, to be honest, but I think that you make a very interesting comment that to use a smaller balloon for valve still can have the effect that you expect and be safer. So I understand that this is your comment.
And also there are some important new development balloons, like V8 balloon, and this opened the valve different mechanism. So maybe in our countries, like the problems, especially in cardiogenic shock patients, these kind of balloons can be good alternatives. Thank you.
Thank you very much. Thanks, Elias. And let's move to the next presentation, who is from Dr. Lachios. I think Dr. Lachios is going to be connected virtually, and he's going to talk on something that is deep into his heart. He's speaking a lot about that, and I fully agree that TAVI is not just one procedure. TAVI is two procedures. One is the aortic valve, and the other is the access, and he's going to talk to us about the alternative access sites for TAVI. Thanks very much, George.
Good morning to everybody. My deepest apologies, my deepest thanks for inviting. Sound okay?
Now we can't see you, but I'm sure they will sort it out.
Okay, they will sort it out. As long as you see the slides. Slides okay?
Nothing is okay for the time being, except for your voice.
Start with slowly. Tell me what
Now it's fine.
It's okay?
Yeah, now it's fine. Thank you.
Okay, so thanks for the invitation. Thanks for the kind introduction, and I will take 10 minutes to tell you everything that I have in mind about alternative slides. My deepest sorry for not being there, so I'm very, very close. So let's talk about what we can do when we don't have femorals. That thing, we don't have femorals, was not an issue back 20 years now, because we tried to save unsalvageable patients. But the comment I want to make here is that with a self-expanding valve from day one, the transfemoral route operated by us, the cardiologists, and closed down by us, the cardiologists, was the default options. Other technologies needed some 5 to 10 year time to catch up, because at that time they were dealing with surgical cut down. So the surgical option was in hand, on the table from day one. Now, meaning now 5 years ago, TAVI is an everyday case in many, many experienced labs. I'm not showing you to show that the gradient went down. I'm just showing you to see the times, like in 20 minutes, skin to skin, the gradient goes from 50 to 0. And that's something that's very, very fascinating. And we've written that down. It's the same time around 2019, the people that at that time were dealing with TAVI. Data from the States, from the STS registry, that started to show what happens in the real world, say that nowadays almost 95% of cases are being done transfemoral. and only 5% of the TAVI cases are being performed by alternate sites. The guidelines that came later on, about 2021, say that you have two TAVIs. You have the transfemoral TAVI, which is the TAVI that we all talk about, and you have alternative sites, alternative access option TAVI. When you mean alternative, you have to make a much more serious and deep consideration about the alternative option that is surgery, because transfemoral TAVI does not equal to non-transfemoral TAVI. And we have data to show that all the good data being TAVI equal, non-inferior, then equal, than in across all risk profiles, from very seriously diseased patients to low risk patients, are dealing with transfemoral TAVI. When you go non-transfemoral, the numbers for us interventional cardiologists are not that good, and that's from the initial partner and from the partner trial. And you have alternative access, you lose your so-called advantage over the surgical colleagues, and I can see a lot. And that, again, from the STS registry, you see from a medium 3% mortality in transfemoral against thousands and thousands of patients. When you go to alternate sites for access, you have to accept, you have to talk to your patient that the accepted mortality rate goes up. So I close this introduction by once again stating that transfemoral TAVI is not the same as not transfemoral TAVI. So why do we have to deal with non-transfemoral TAVI? Why don't we just put everybody in? Because big seats are big seats. Initially we were 22, then they went to 18, then we get down to 14, and I think that's going to be the end of it. And when you have a very tortuous vessel or you have a very stenotic vessel, you just cannot push your stuff across that vessel. You cannot push that 5mm sheath or system across that stenosed or tortuous vessel. And that's from the editorial from Winteker last summer that says you have a spectrum of a whole gray zone, from a perfect candidate on the left to a little bit calcified or tortuous to a lot of calcified, or you have complete peripheral artery disease with occlusion, or you have a TEVR, although we put through a few TEVRs inside me and Kostas Toutsos. But then you have serious unfavorable anatomies, which for just plain anatomical reasons, you cannot push stuff across. But if you just have some stenosis, you can deal with that in order to proceed with transfemoral TAVI by doing a peripheral angioplasty. And that's a common practice. We've started with easy lesions, and now they have the whole thing about paving the way all the way up with crushing balloons and with shocking balloons and all that stuff. So you have a way to avoid non-transfemoral TAVI. When you cannot avoid transfemoral TAVI, and that's a consensus, a level of evidence C, that's expert people like you said, when they are inoperable and you cannot do transfemoral TAVI, then the non-transfemoral TAVI is the third option and not the second option. And regarding access, also from the same STS registry, you see you can have transapical and you can have subclavian, which is number one in numbers, and then you can have direct aortic, and then you have so-called, in my mind, exotic options like carotid or subclavian. The thing is, with all these options, you need anesthesia. Take along, some centers perform transubclavian access through local anesthesia, and that is an option, but it is far from widely being accepted. Okay, you need anesthesia, and we've said that, and people say that there is no problem if you have TAVI with or without anesthesia, but again, I'm sure that our fellow anesthesiologists would not, drop their hat on the air about giving anesthesia to the upper right-hand side lady, because you have the problems of anesthesia, you have the problems of feeding, and we have all those complications that come of having a tube in your mouth for 1 hour. So what are the alternative options? Subclavian options. So you do a small incision, you need the second team, you need a set-up room for operation. So you need the second team, you need the third team of anesthesiologists. You operate either directly and you patch directly the subclavian artery, the left or the right subclavian, or you put a side-by-side graft so you be easier to puncture the graft, and then you cross the valve. That does not come always without complications. And also you have a complication. Here you can see there was a dissection of the subclavian artery after a TAVI, which dissection led to the occlusion of the functioning left IMA. And then we had at the end of the procedure to perform transcorval left main PCI because we occluded with our operation the left subclavian artery and the lima. But also again, we have not another option. Here you see you can also, it was the only option at that time meaning 10 years ago, and that was the first case we sent in the first ever PCR London valves. We had to do transsubclavian in the same way that we do in the peripheral arteries angioplasty. We can do transapical. It was very widely in balloon expandable valve used, especially in the initial seats that needed to be 20 or 22 French. The surgeon with a small hole at the beating heart performs a puncture and then closes the puncture, and it is an easy option not only for the aortic valve and also for mitral valves. You have the direct aortic with a small incision. You puncture the ascending aorta more than 6 centimeters above the aortic annulus, and we were proud we were the first to describe and to present, to perform that. And it could have some theoretical proven benefits against the transapical, but it is not either the transapical or the transaortic. It is surely inferior to the extra cage to the subclavian surgery. So if you can avoid surgery, avoid it. And if you can have extra thoracic cage surgery, it's better than having intrathoracic cage surgery. What this method led to was to the manufacture by companies of sutureless surgical valves that more or less were based on the same way. There are the exotic options. You can puncture the carotid artery and be close to the heart. You can puncture through the inferior vena cava the descending, the thorax, the abdominal aorta, and then close it by means of closing a PFO on your way out. They have good results. I have not done it. I'm sure that in these cases, the surgical would not be a bad option. And cleaning and closing, I would say that the more you add surgery, the more you add problems to your patient, and the more you have to think and to discuss with the patient the alternative option. In the 95% of cases above 70 years old that you can do transfemoral TAVI, you should proceed. If you can do something to make the transfemoral option possible, you should do that. Otherwise, you have to do another discussion. It's not TAVI versus surgery, it's TAVI versus surgical TAVI versus surgery. And that's what the guidelines say. If you can do transfemoral TAVI, proceed. If it's impossible, you'd better do surgery than doing a sort of hybrid surgery TAVI. Otherwise, I've done a 96-year-old, if the surgery is always out of the option, then you can try to do alternate option. Thank you for your attention. Sorry again for not being here. I'm happy to discuss any questions you might have.
All your experience to us and to our audience, and I would like now to ask Dr. Mavrogianni if she wants to make any comment or have any questions, and then ask the audience.
No, I have no comments to make. I think, of course, your first choice is always the transfemoral access. If you don't have the transfemoral access option, then subclavian is rather good, but it's tricky and it's technically challenging if you don't have enough numbers. How many patients did you go to via subclavian, George? How many patients did you treat via subclavian route?
Overall, as a percentage.
I didn't hear you. Clear?
Overall, or as a percentage? As a percentage, about 1 out of 30. Nowadays, that the seat with some hospitals go down to 14, there are even less.
Okay, perfect. This is your second choice. You always
Yes,
you should always go transfemoral. This is the second and third option when your transfemoral is very hostile. I have no comments to make.
Dr. Bellakis wants to have a comment. Please do, Dr. Bellakis. I know that you're a bit difficult not being around, but now we've seen you. Okay, please do.
Morning to everyone. Thank you for the invitation on this fantastic meeting. I'm not there. I'm just probably 1 kilometer or 2 kilometers away, but it's unfortunate I cannot be with physical presence. Congratulations, Dr. Latsios, for his excellent presentation. I just would like to make a comment. Sometimes we consider the sutureless aortic valves to be an alternative to TAVI, which is not exactly true, because still these valves do need to put the patient on bypass and still do need some sort of incision. So more or less, these valves are made to make the surgical time less and maybe treat some more hostile aorta. So still, it's not a good, let's say, it's not something comparable to TAVI. Now, my second question is, I just try to think what happens to these patients that one of these cases was described by George, who have patent lemurs. These patients are basically, no surgeon wants to operate and do a redo operation on somebody who has a patent lemur. We prefer these patients going for TAVI if they develop aortic stenosis after bypass surgery. And I know that the subclavian access on the left side is the preferable one when we're doing transsubclavian TAVI, but then we have to deal with the lemur, and occlusion or dissection might cause unfavorable outcomes, and it was a good save what George did. But I was wondering whether these patients should be considered for a different access route straight on. I mean, when we see a patent lemur and we have no access, a transfemoral access, whether we should go transaortic or transapical or a different access. Thank you.
Okay, thank you, Dr. Beralakis. Thank you, Apostolis. First of all, the case with the occluded lemur was something that happened back in 2008. So nowadays, when we have the bad option of a patient that's been, let's say, 85, that's got a patent lemur, and that's got a severe stenosis, and that's got no peripheral access, then we have a big problem, and we have to deeply discuss all the options. So we cannot go transfemoral, we are not willing to go trans-left subclavian. We have to see what the other options are. Per se, the patent lemur is not a contraindication to transsubclavian TAVI. If you have a big subclavian, then you're not afraid that you will occlude the lemur. If you can avoid it, it should be avoided if you have an alternative option. But again, let me say that the cases nowadays, with the help of the companies that are shrinking the sheets, the cases that you cannot go, the companies shrink the sheets, and the experience of the operators of going transfemorally through TEVARs, through angioplasties, through peripheral angioplasties increases. So the cases that would need to go surgically much decrease.
Quick question.
The last one by Dr. Batakos, because we have to.
Yeah, just so in the sake of time, fantastic. Thank you, Dr. Latsios, for being with us. It was a fantastic talk. You know, I always think about a little bit these alternative access routes. Part of the issue is, I think, clearly we all know transfemoral has the best results. Part of it is a selection bias, I think, because the patients who are not candidates for transfemoral are the ones who have a lot more comorbidities, a lot more peripheral vascular disease, a lot more health problems in general. And so then it's obvious that they won't have as good outcomes because they're a sicker population overall. We have jumped late on the bandwagon for doing a transcarotid TAVR, but I think it's a very good option, especially in cases like Dr. Rubalakis and yourself are talking about patients who have a patent lemur LAD. You don't want to go subclavian. I think the transcarotid route, as scary as it sounds initially, we've had a good, limited early initial experience, no strokes. And I think that there are always other options to discuss. One of the first cases I saw when I was a young cardiothoracic surgery fellow in Houston was a trans left subclavian TAVR in a patient with a patent lemur LAD, and the patient died on table. The vessel was dissected, the flow in the lemur stopped, and the patient coded on table and died. So it's a very traumatic experience. So I would say that that's something that should definitely be avoided, especially when in this day and age of exotic things like transcaval, there's always, in transapical, there's always another option. But thank you for your excellent talk, and I'd love to hear your thoughts.
Thank you very much, Dr. Patakos. Thank you very much, George. And we have to proceed with our next speaker, who is a fantastic young operator, not as young as I remember him, but still young, Dr. Kalogeropoulos, who is going to add to our experience his views about TAVI for aortic regurgitation, a field that hasn't started in Greece, but we hope that will start soon, or possibly has started to a certain extent.
Professor, thank you very much for your kind words. I would like to thank on my behalf Dr. Sparias and Mr. Patakos for this kind invitation. So my talk will be about TAVI for severe aortic regurgitation. So first of all, so I'm pressing the arrows. Okay. Okay. Severe AR is not so uncommon as we probably think. It's something that does exist, and definitely we need to pay more attention. So we can appreciate that pure severe AR is definitely less common compared to severe aortic stenosis, but it's still there, especially in older population. So how these patients are doing, and if we don't do anything, so if we just do a conservative approach, and we can appreciate that probably is a bit more indolent course compared to severe AS, which all know that mortality rates are around 50% in 2 years. This is a 10-year course of the disease, and however, we can see that this mortality inclines steeply in patients that are decompensated. So with a functional class of 3 or 4, we can see that at 5 years the mortality rate is approximately 70%. So does intervention associate with better outcomes in these patients? Definitely does. And it seems that early intervention is much better than later one, and we can appreciate that the prognosis in patients with functional class 3 or 4 is worse compared to. So what are the guidelines say about treating severe AR cases with a transcatheter approach? Definitely are not favorable for this approach. It's a class 3 according to the American guidelines. However, is recommended that is rarely feasible and inhibitive surgical risk, subject of course to appropriate anatomy based on the annular size or some annular calcification. And why is that? So this is a big registry from the US that has shown that patients that undergo transcatheter intervention for severe AR are doing much worse compared to ACE cases. We have higher rates of device migration and embolization, higher convention rate to surgery, and a higher rate of re-intervention. In fact, the 30-day mortality rate is about 15.5%. Now, regarding the performance of the already available devices, so we can see that the early generation devices are doing much worse. We have higher mortality, higher residual paravalvular AR, and rates of device migration. The new generation devices are doing slightly better, but again, the rates are pretty high. And another thing that we should pay attention is the residual AR that in rates of at least moderate severity is associated with much worse prognosis compared to mild or no AR. So what are the challenges that we're dealing with when we consider a transcatheter approach in aortic agitation, pure aortic agitation? So essentially the main problem is insufficient anchoring, and essentially this is related to the significant lack of calcification in the annulus and the valve leaflets. Large annulus that we often see in patients with severe AR. And of course, the insufficient anchoring is associated with further repercussions, including higher risk of dislocation of the valve, higher rates of residual aortic regurgitation, and because of transcatheter heart valve oversizing, a risk of annular rupture. Another consideration is the suboptimal fluoroscopic visualization because of the lack of calcification, which is a bit challenging when we're trying to position the valve. So what are the anchoring mechanisms? So these are different based on the actual platform that we use. So for the self-expanding valves, we have two sides of anchoring. So one is the annulus, and the other one is the side where the frame outflow of the valve is reaching the wall of the root. So if the frame is in touch with the root, then this can give an additional friction that could improve the anchoring. For balloon expandable valves, the only side is the annulus. And for the dedicated devices, apart from the annulus, we also have anchoring mechanisms regarding the leaflets. So what we know so far about the performance, especially of the conventional platforms, so we can see that the 30-day mortality is almost prohibitive. So in some case series is almost 23%. We have significantly higher rates of residual aortic regurgitation, moderate or severe aortic regurgitation, almost 20%. And we have, of course, higher rates of embolization. However, the most recently published ALIGN-AR study that evaluated the efficacy and the safety of the JENA trilogy valve showed very promising results that approaching the rates of TAVI in AS cases with a 30-day mortality of only 2.2%, residual moderate AR of severe AR of only 0.6%, and rates of embolization of only 2.2%. But of course, that was the trade-off with a higher rates of new pacemaker implantation of 24%. So this is the trilogy valve. It's a nitinol frame, self-expanding platform with a porcine pericardial tissue. We can appreciate the three large cells that facilitate coronary access post-implantation, and also the three locators for the commissural alignment. The valve is delivered through a pre-shaped 18 French sheath, which allows the torquing of the device in order to achieve proper commissural alignment. So the valve is positioned and deployed in 3 stages. So first we perform the alignment based on the 3 locators. Then the locators clip onto the native leaflets. So in order to achieve a natural seal and stable securement, and finally we deploy the valves and facilitate the coronary access with the big cells. Now, I will present a case very briefly. This is my British experience, a case I performed my British colleagues at St. Thomas's Hospital. This is a 76-year-old lady, quite frail, quite symptomatic, with a functional class of 3 or 4. Many comorbidities, and the transthoracic echocardiogram showed reduced LV systolic function with moderate severe aortic agitation and also pulmonary hypertension. We can appreciate here the severity of AR. So this case was discussed in the local heart team meeting, and the consensus was for a transcatheter approach, subject, of course, to appropriateness of the underlying anatomy. So here's the CT scan. We can see there's a lack of calcification. We can appreciate the thickening of the valve leaflets. In terms of annular size, there's a perimeter of 79.1 millimeters and almost equal size LVOT. And good sizes of the sinuses of Valsalva, and also STJ diameter and height. And the coronaries were pretty good as well. Coronary heights around 15 millimeters. So we opted for 34 millimeter evolute FX and with oversizing of approximately 30% based on the annular measurements. These are the legs, so small vessels, but without any significant disease. So we went with dual transfemoral access, so right transfemoral access with insertion of the A-line sheath of the valves. Here we can appreciate the setup shots, 3-cusp view, and overcusp view. And here we start the deployment. So we perform this with a pacing around 160 BPM. So, and trying to stabilize the device as much as we can and start the deployment, and also using an Lindquist wire just to facilitate the deployment and achieve a better stability whilst we're deploying the valve. Here the depth, we're a bit deeper than we want to, so we do a bit of recapturing. Here the depth is a bit better. And finally we release the valve. And this is the LAO views. Even though at the final view you can see the bit of diving of the valve, but without migration. And this is the final echo. And we can appreciate no residual AR and good hemodynamics. So in conclusion, TAVIs were essentially designed for the treatment of degenerative calcific aortic stenosis. However, it can be used off-label in selected cases with pure AR, with prohibitive surgical risk and appropriate anatomy. The clinical results are, however, variable, slightly better outcomes with the next generation devices. In these cases, the design of the transcatheter heart valve is paramount, and there is a need for a dedicated anchoring mechanism. And the Trilogy valve introduces some unique features and is the first of its kind dedicated transcatheter heart valve for the treatment of pure AR that has received a CE mark for this condition. Thank you very much.
Thank you very much, Andreas. Fantastic talk. And I would like to ask Dr. Rubellakis if he has any comments, and then unfortunately we have to proceed with the last presentation. Dr. Rubellakis, please.
Excellent talk, and thank you very much, Dr. Kalogeropoulos. It's just going to sum up and say that we still don't have the technology for aortic regurgitation. It's a different set of patients. The peak age is between 40 and 60, and younger patients with low surgical risk. So before we reach the point where we can discuss about options with aortic regurgitation, we still have a path to follow and a mountain to climb made for these patients. Thank you very much.
Thank you very much, Andreas. Thank you very much, Dr. Rubellakis.
Can I ask you a question? Because the question is directly to you. Yeah, you're an imager, and you're one of the finest and best imagers in Greece. Do you think that aortic regurgitation is diagnosed properly, or are we under-diagnosing aortic regurgitation? And do you think echo suffices in order to make that diagnosis, or do you need to utilize extra measures in order to have the correct answer of whether it's severe or moderately severe or things like that? Because insufficiencies are much, much more common than stenosis. And we are talking about aortic stenosis, and the first slide, I think, was not correct. regurgitations are more often than stenosis?
Very shortly, a great issue. Actually, aortic regurgitation is really a challenge for echocardiography. And there is a great discrepancy between American guidelines and the European guidelines. The American guidelines have put it, this issue just to discriminate between severe or not severe. They put some semi-quantitative parameters we all know, vena contracta, convergence flow, and if there are 4 of them, very common, you have severe and you do not quantify. But if you don't, you have to quantify. Europeans say quantification in any case. Even in the ALIGN trial, there was some overlap between, I think, almost 30%, some echocardiographers considered that it was moderate. I mean, almost 60 patients out of the 180. So it's matter of variability. You cannot quantify and you cannot be sure. I think that echocardiography may proceed by saying if it is severe or not, and sometimes CMR as a second, as an alternative, may help, sometimes may help.
Dr. Padakos, but we have...
Thank you very much. So we're very honored to have our good friend Mike Reardon here from Houston, Texas, just landed this morning. So I just wanted to get his insights, as he has extensive experience in performing these cases for patients with AI. Dr. Reardon, thanks for being here today.
Well, first of all, you're entirely correct that we underdiagnose AI, and the US guidelines are at least 15 years behind where we need to be. So we do a lot of CMR on these people when there's any question, and we're finding a lot of these people are coming to us already with extracellular expansion and mid-wall fibrosis because they've been ignored too long. We just finished the ALIGN trial for Jenna in the US, and we just finished the early feasibility for the J valve, which is the Singapore valve, and we just submitted our IDE, and unlike ALIGN, we're going to allow CMR as a secondary diagnosis for AI, because the main reason I lost people in Jenna was either my echo underdiagnosed it or the annus was too big. And so now we're going to use CMR to also look at that, and J-valve actually has a bigger size. And these all come to us as when they're low risk, we love these as surgeons because they all have big annus, so they get nice big valves. And also, when you have central regurgitation, if you're a good patient, we can fix most of these. And if we can fix your valve rather than replace your valve, you're always better. But you're spot on. We underdiagnose and we undertreat AI.
Thanks so much. Thanks for lending me your microphone here.
Very short comment. The most important problem for the AR is the size of the annulus and the size of the valves. For the Jenna valve, for example, the largest size is 27. So it's a big problem, especially about the annular area when you look at. Some of the new, balloon expandable valves, MyVal, for example, have 30.5 and 32 millimeter sizes. So there is a very important study published in Eurointervention with very low complication rates. Maybe the balloon expandable valve problem was the usage of the 29 millimeter valve with extra large amount of contrast. But novel valves with bigger sizes are coming from the MyVal side, 35 millimeter, and Vita Flow, and also G valve with extra large sizes.
Thank you. And I would like to ask the last speaker, but not least, Dr. Vourdiris, a man with his presence and deeds sealed interventional cardiology in Greece, who is going to present TAVI in bicuspid anatomy. Vasilis.
Dear Chairman, dear colleagues, I would like to thank the organizing committee
for this kind of invitation. I'm the old interventional cardiologist. I'm in the last period. However, I'm still alive. So, bicuspid aortic valve is a common congenital anatomy that affects 0.5 to 2% of adults with a male to female ratio 3:1. May develop as isolated aortic stenosis, aortic regurgitation, or both, in a rate during follow-up from 12 to 37%. Aortic aneurysm has been reported in 20 to 40% of patients with bicuspid morphology. However, this aneurysm may be seen without or with coexistent aortic valve pathology. This is the main classification for bicuspid valve by Dr. Sievert, according to the number of the rafts as type 0, type 1, and type 2. Today, bicuspid morphology are much more frequent in Chinese and maybe in Asian population, TAVI, than in EU or USA TAVI patients. In the Venus trial, the incidence of patient screening for bicuspid morphology from 2014 and later on is close to 50%. But tomorrow, bicuspid valve will be much more frequent in EU and maybe in US TAVI patient than today because bicuspid valves are more frequent in younger patients. What's the potential problem for TAVI in patients with bicuspid morphology? This valve often is heavily calcified, so sometimes we have incomplete valve expansion, paravalvular leak, and annulus rupture. Frequently is associated with ascending aortic aneurysm, so there is a risk for rupture and dissection. Finally, the oval shape of valve area leaves a space for paravalvular leak, and we don't know at this time the long-term durability of these devices. For all this reason, bicuspid morphology has been excluded from randomized trials, and there is a relative contraindication for TAVI according to the guidelines. Early pivotal trials excluded patients from bicuspid with bicuspid aortic valve stenosis. The use of the first generation bioprosthetic valves has shown high rate of paravalvular leak in bicuspid morphology and a tendency for more stroke. This is a series from reported patients from 2010 to 2014 using the first generation devices. The device success rate, it was around 90%, and the degree of more than mild aortic regurgitation ranged between 20 and 30%. And of course, it was an increased need for pacemaker implantation. In this series, both at that time, valves type were used, balloon expandable and the self-expandable devices. This is the first. May I have this, please? Okay. No, the first one? Okay. So this is the first bicuspid aortic stenosis performed in our institution in 2008, I'm sorry, with Professor Cribier. It was a bicuspid aortic stenosis. You can see the pre-dilatation. Next, please. It was quite difficult, very, very difficult with the technology of this period to advance the valve through the bicuspid morphology. Finally, it was succeeded. And the final result was good, but we have a dissection. It was a small dissection treated medically. However, now data from the new generation TAVI devices have shown better results. No difference in mortality rate at 30 days and 1 year, and the stroke rate at 30 days still is higher in patients with bicuspid morphology. This is data from the STS-ACC-TV registry using the SAPIEN 3 valve from June 2015 to 2018. 2,726 bicuspid aortic stenosis patients were treated with the SAPIEN 3 device. At 1 year, the mortality, all-cause mortality, was statistically better in patients with bicuspid morphology, and there was no difference in the incidence of stroke. These are more recent data from China in patients with bicuspid morphology type 0. This is a retrospective study from 28 centers with a follow-up at least 30 days. The technical success was 98%, all-cause mortality less than 1%, and the stroke rate 3.6. The imaging evaluation of calcium distribution and morphology is very, very important. The sizing, implant strategy, and depth based on CT are essential. These are data for the self-expandable TAVI device from the same registry, from 45,938 core valve procedure using the Medtronic platform, the first core valve, the Evolut R and the Evolut Pro devices have shown all-cause mortality that was low with Evolut R and Pro 2.4 to 3%, stroke rate between 3 and 5, and permanent pacemaker decrease from 25% with the core valve to 8 to 11.2 with the Evolut Pro devices. And the degree of paravalvular leak after device implantation, more than moderate, was low. On the same direction are the more recent Bivolux result from Europe. Valve performance at 3 days was 97.9%. Freedom from severe patient prosthesis mismatch at 1 year, 96%. And freedom for moderate to severe AR at 1 year, 98%, using the self-expanding Evolut devices. Recent data of TAVI versus surgical aortic valve replacement in patients with bicuspid morphology have shown no difference in hospital mortality, stroke, paravalvular leak vascular complication between TAVI and surgical AVR. TAVI is associated with higher risk of permanent pacemaker implantation compared to surgical procedure, and a lower risk of acute kidney damage or any transfusion. At follow-up, median time 21 to 24 months, there was no significant difference in all-cause mortality. You can see the data for 30 days and 1 year mortality using balloon expandable or self-expandable device, and compare to the surgical AVR procedures in all-risk patients. In low-risk patients, almost half, 30 days and 1 year mortality, and it was comparable to the mortality observed with surgical aortic valve replacement. This is the existing recommendations for TAVR in bicuspid morphology. To be patients with bicuspid morphology and symptomatic severe aortic stenosis, TAVI may be considered as an alternative to surgical AVR after consideration of patient-specific procedural risk, values, trade-off, and preference, and when the surgery is performed at an experienced valve center. But I think, based on the new data, it is the time to have a randomized trial, surgery versus TAVR for bicuspid aortic valve disease. So in conclusion, dear Chairman, ladies, gentlemen, I don't know if it's correct, ladies and gentlemen, my dear. TAVI in bicuspid valve is feasible, but may be technically more difficult than the tricuspid valves. Results are comparable to the results of tricuspid valves. Paravalvular leaks may be more frequent. Rupture of the ascending aorta in patients with ascending aneurysm may occur. Oversizing of the valve should be avoided. Better results can be expected with better round. And with my thanks, I would like to show the beautiful city of our president, Professor Michalis. Thanks.
Thank you very much, Vasilis. Thanks a lot. That was a very nice surprise. Thanks a lot for your presentation that added all your experience to our knowledge. And I would like to ask Dr. Mavrogianni if she wants to make any comments or anybody else from the, okay, let's start with Dr. Karabinos.
Thank you for your great presentation. I'd like just to say that we saw last year a meta-analysis which confirmed what you have presented, that there is a drop between TAVR and SAVR. Regarding criteria to select patients, Yoon has shown since, I think, 2020 or 21, that in type 1 severs, if there is calcification of the RAF and burden of calcium over the leaflets are variables to predict mortality, higher mortality, if there are both of them, and if there is none of them, the mortality is very, very low. Severs, I think, is rather obsolete today. I mean, the classification of severs. It has been proposed that we should use either the truly bicuspid valve, which is the type O severs, type 1 severs, the presence of a RAF, and a new emerging category which shares some mortality, the partial RAF. We see a tricuspid valve, which actually is not, and we may just, suspicion may rise since there may be an enlargement of the ascending aorta.
I agree with you. I'm not sure if the last category is true bicuspid valve morphology. And we have many cases, many cases with calcifications between two RAFs, so you consider it's a functionally bicuspid valve morphology.
Thank you, Vasilis. Is anybody else who wants to make a comment? No, and with this, I would like to conclude our session, and we have to proceed with the opening session of the meeting. Thank you very much for being here and attending this session. Thanks. Thanks for being with us. Για να αρχίσουμε σιγά σιγά, να πούμε τους κυρίους που είναι έξω να... Good morning, dear colleagues, distinguished professors from all over the world, President, Dr. Tangas, Professor Reardon, it's always an honor to have you with us. I would like to start the presentation and the opening ceremony of this beautiful conference. We have here the President and CEO of the Joint Hospitals Υγεία and Mitera, Mr. Kartapanis, who is always helpful, always coordinating, and always pushing us forward. Unfortunately, Dr. Sparias, our chief and coordinator and mentor in the minimally invasive procedures, because of a minor strain of the back, he cannot be with us today, so we'll try to see what medicine can do for him, possibly to join us a little bit later. To talk about our presentation and talk about transcatheter heart valves in Greece, as you all know, has been made a lot of progressive steps. Initially, cardiac surgery thought that this would be an opposite direction, taking patients from us, but we all see that the progress is progress, the solutions are solutions, and the target is only one, the well-being of the patient. So if the patient is going to be done through a transcatheter approach or an open heart surgery, remains to what the guidelines are going to give us at the end. But we all work together, we all are happy to be together, to have solutions together, and we're really happy to have you with us today. Professor Vardas is also here with us. He is the coordinator and the administrative director of the heart section, and we'll ask him to come and join us here, giving us his thoughts.
Good morning. In my capacity as chairman of the Hygeia Hospitals Group, I would like first to welcome the chairman of the executive board, Mr. Kartapanis, and also I would like to welcome all of you, and especially those coming from abroad. Welcome to even weedy, cloudy, but still beautiful Athens. In very brief, I was thinking this morning how to address all of you, and finally I've concluded saying that if we had to frame the nowadays developments in medicine, but even beyond in many other domains, first we have to recognize the fast developments everywhere. In medicine nowadays, we are, and especially in cardiology of course, we are experiencing fast developments in artificial intelligence, in genomics, and last but not least, in the transcatheter valve therapies. Dr. Sparias, a highly recognized pioneer in this field already 20 years now, has established this marvelous department. And working together with Dr. Patakos, nowadays are performing a state-of-the-art department and a state-of-the-art also educational center. For us, the Hygeia Hospitals Group, innovation is absolutely first priority, and quality also. So this marvelous combination of quality and innovation, as I said, has been prioritized by the executive board as first priorities. We try very much to recruit very well-known colleagues and to organize this state-of-the-art sector of heart sector in Hygieia Hospitals Group in the most proper way. Today, personally, but also as the chairman of the sector, I would like to express my deep pleasure because it is here the kind and genuine example of this state-of-the-art performance. And I would like to take my academic hat saying this is not only because the quality of the talks. Outside, as it is stated in the introduction of the program, we have the opportunity to enjoy a first-hand experience of education provided by experienced peers coming from the industry, which is really marvelous. So, congratulations to the organizers. Congratulations to Hygieia Hospital Group for what he's doing here. And finally, a part of the quality and the innovation that I spoke about, it is the education which is highlighted here because the organization of the Transcatheter Valve Conference here at Mitera Hospital. Thank you very much. And now I would like to invite the chairman of the Hygieia Hospital Group, Mr. Karpanis, to come on the stage. Yes, please.
As a senior, we had you at the very last, but it's better to save you some time. So we'll give the podium to our chief chairman, Mr. Karpanis.
Καλημέρα και από μένα. Προτιμώ στην πατρίδα μου να μιλάω στη γλώσσα της και θα πω μόνο ότι αυτά που είπε ο κύριος Βάρδας, ότι πραγματικά ο στόχος μας είναι και η ποιότητα και η καινοτομία. Το έχουμε εφαρμόσει πάρα πολλά χρόνια σε όλες τις πτυχές της ιατρικής και νομίζω ότι πλέον το υγεία έχει καθιερωθεί στον κόσμο σαν αυτό το κέντρο ποιότητας και καινοτομίας και πρωτοτυπίας και πρωτοπορίας σε όλα τα επίπεδα. Και το λέω αυτό διότι πριν από πολλά χρόνια, το έχω ξαναπεί σε αντίστοιχες τέτοιες ημέρες, εδώ και πολλά χρόνια με τον κύριο Σπάρια και λυπάμαι πάρα πολύ που δεν είναι εδώ, ελπίζω να ξεπεράσει το πρόβλημά του και να είναι μαζί σας. Συζητήσαμε και αποφασίσαμε να ξεκινήσουμε αυτή την προσπάθεια που τότε στην Ελλάδα, αλλά και νομίζω και σε ευρωπαϊκό επίπεδο ήταν στα σπάργανα. Βλέπαμε την επιτυχία της, βλέπαμε ότι είναι το μέλλον και όπως και έγινε. Και όπως λέω και στους καρδιοχειρουργούς, στον κύριο Πατακό, του το έχω πει πολλές φορές, και στον νεότερο κύριο Πατακό, ο οποίος ακολούθησε την πορεία του πατέρα του, η εξέλιξη πρέπει να δείτε τι θα κάνετε, γιατί η εξέλιξη στην καρδιολογία θα σας πάρει τη δουλειά. Και ήδη το έχει κάνει σε πάρα πολύ μεγάλο βαθμό. Απλά προσαρμόζονται και καλά κάνουν στο να είναι μαζί με τους επεμβατικούς καρδιολόγους και να κάνουν μαζί τις πράξεις, γιατί απαιτείται και η γνώση και η εμπειρία ενός καρδιοχειρουργού σε πάρα πολλές περιπτώσεις από αυτές. Δεν θα πω κάτι άλλο. Καλή επιτυχία και όλα καλά στο συνέδριό σας.
Ευχαριστούμε κύριε Καρταπάνη. Είμαστε δίπλα μας και εμείς θα τα τακτοποιήσουμε τα θέματα, εμείς οι καρδιοχειρουργοί, και με λιγότερη δουλειά θα την ανεβάσουμε ποιοτικά, οπότε θα προσπαθήσουμε να αντισταθμίσουμε την ποιότητα με την έλλειψη ποσότητας. Thank you very much. Representing the scientific committee, Dr. Konstantinidis will give us his thoughts about what we do and what we should do. The scientific committee is always coordinating everything. Everything passes through their board, and always we're grateful for what they're doing. Dr. Konstantinidis.
Παίρνοντας τη σκητάλη από τον κύριο Πατακό και από τον κύριο Καρταπάνη, θα ήθελα να πω ότι η καρδιοχειρουργική έχει τη θέση της, η καρδιολογία έχει τη θέση της και η συνεργασία αυτών των δύο ειδικοτήτων μας έφτασε στο σημείο που είμαστε σήμερα. Αγαπητοί συνάδελφοι, κύριε Πρόεδρε του Ομίλου Υγεία, κύριε Συντονιστά του τομέα καρδιάς, κύριε Βάρδα, κύριε Κώστα Σπάρια, φίλε μου, ελπίζω να μας ακούς, κύριε Στρατή Πατακέ, αγαπητοί συνάδελφοι, καλημέρα σας. Είναι τιμή μου να χαιρετήσω το Συνέδριο των Διακαθετηριακών Βαλβίδων, το Διεθνές Συνέδριο, για 14η χρονιά, που οργανώνει το ομώνυμο τμήμα μας. Η εξελίξη τεχνολογία και η μεταλαμπάδευση γνώσεων ουσιαστικά στοχεύουν στην πρόοδο της ιατρικής για το καλό των ασθενών μας. Η επιστήμη το επιβάλλει αυτό. Και αυτό το σκοπό έχει αυτό το συνέδριο, μεταπαλάδευση γνώσεων και σκέψεις και ανταλλαγή απόψεων. Τελειώνοντας, θα ήθελα να τονίσω ότι κανένας Έλληνας δεν χρειάζεται αυτή τη στιγμή να μεταβεί στο εξωτερικό για καρδιολογικό πρόβλημα που πρέπει να λύσει. Και αυτό οφείλεται σε πολλούς συναδέλφους που αυτή τη στιγμή βρίσκονται μέσα σε αυτή την αίθουσα. Κύριε Πατακέ, το γνωρίζετε καλά εσείς αυτό. Τελειώνοντας, θα ήθελα να ευχαριστήσω τη Διοίκηση του Υγεία που πάντα ενθαρρύνει τις πρωτοβουλίες αυτές και προς την έρευνα και προς την εξέλιξη. Σας ευχαριστώ και καλή επιτυχία.
Good morning, everyone. Greg Patakos. It's an honor to be here today with everybody. I asked for the pleasure and privilege to introduce our good friend, George Dangas, who you know as the president of the Society of Coronary Angiography and Intervention. Dr. Dangas needs no further introduction, so we ask that he tell us a few words. He's a great friend of our department. We've done cases together here at Hygeia. And we have a fantastic international collaboration. George, thanks for being with us.
Well, thank you, Greg, and it's a pleasure always to be here. Many thanks and congratulations to Stratis, and I guess Dr. Vardas just stepped out for a moment, but the entire team here is very vibrant, and of course, Kostas Parias, who I already wished him well and to show up hopefully in the afternoon if he can. I've really followed and associated and collaborated with from the very beginning of this very vibrant and interesting symposium that is innovative from get-go. It was innovative for Greece, innovative for Europe, a department here that is truly, I would say, integrated between cardiology and interventional cardiology and heart surgery with great results and, you know, encompassing not only great clinical results, but also inclusion of innovative new trials and new protocols and new devices and new approaches into their everyday practice. And they maintain a strong relation with international centers. The best testament of that is that key leaders from the United States and Canada and Europe are arriving at this Congress pretty regularly. Well, this year, though, I'd like to get a moment to explain that I'm very pleased to greet as a president of the Society of Cardiovascular Angiography and Interventions. Actually, I just passed the baton to the previous one, to the next one, just a week ago in Los Angeles, California. We had the biggest meeting ever, very successful. The only glitch was it was during Greek Easter. So we had to, you know, all the Orthodox Greek people, we had to figure out a way to go to the Long Beach Kimistis Theotokou Church for all the proceedings. That was good, but a little strange to be off-site. But we heard Greg refer to our society, which is a global society, the only society that doesn't have a adjective of geography in its name, and founded by a radiologist and a cardiologist. Mason Sones and Melvin Judkins were the first two presidents and collaborators of the society. Initially, the Society of Cardiac Coronary Angiography, then Cardiac Angiography, then Cardiovascular Angiography and Interventions. Keep changing names, same society, with encompassing radiology, cardiology from the get-go, invasive cardiology, understanding, perhaps before anyone, that this global collaboration is needed and cross-specialty collaboration is needed in our field from a get-go. All these 46 years that we've been around since the inception of the selective chorangiography by Dr. Sones and the popularization of it by Melvin Judkins by creating the very simple catheters we all use today. This past year, I was able to actually initiate many special tracks that are outside cardiology and radiology. Cardiac surgeons have joined the Society of Cardiovascular Angiography and Interventions and become fellows of the society. As we will see, Gilbert Tang, he's going to give a talk right after. Why is that? Because they too perform a lot of invasive and interventional procedures. So it's not just a hospital collaboration such one you have here, but it's kind of a global, worldwide association of cardiologists and heart surgeons. Also, we have intensivists in our society. Why is that? Because they perform a lot of right heart catheterizations and they're part of the heart team. And obviously you know that perhaps many, if not the majority of our patients might not survive if not for a very, very specialized intensive care management shortly after the procedures that we do. And also we welcome cardiovascular imaging specialists that, again, what do they have to do with cardiac angiography and interventions? Maybe none with a traditional way, or maybe a lot with the knowledge they offer to all of us through the CT angiogram and TEE analysis and their presence in the procedure room in many, many instances. How could they not be valued members of what we call these days heart team, cardiovascular angiography and interventional team? We cannot do many procedures without the imagers, and quite frankly, the imagers who have an interest and specialize in what we do, they really like to be in our joint conferences. What do they have to do with the diastology, let's say, and the pericardial disease? Well, maybe they have an interest in that. Of course, they read those echoes and all that, but once they join the heart team, they have specialized, subspecialized, I would say, so that they really enjoy the interactions we have together as far as innovation, new imaging, and all that. And we all know that we cannot do and plan our procedures without CT angiography, TE, and echo of the highest quality, and more imaging to come. For these reasons, I congratulate once again the progress done throughout the world, in Europe, in Greece, and in this particular symposium over the years, and I think exemplifies what we try to do in the Society of Cardiovascular Angiography and Interventions as well. Again, congratulations, and we're up to a very great symposium for the next couple of days. Thank you.
We're ready to proceed to the next part. George, I think you are coordinating that. As you all know, the time is the only thing against us, so we have to keep watching our watch a little bit, and we'll start with the new presidium.
Okay, well, let's get the microphones up. And we invite Dr. Abropoulos, Dr. Tsolakis, and Dr. Kelic to join me up here. We have a very, very interesting session in TAVI. And we're going to get started with Professor Toutouzas. He is going to give us a lecture via internet. I believe the heavy traffic of today due to the rain is impacting his schedule, as well as a very important helicar conference that he's running at the same time.
Hello, everybody. I don't know if you can hear me, and I can show you my slides.
Yeah, go ahead, Costa. Good morning. We'll hear you and we can see you. Go right ahead.
Thank you very much. I'm really sorry that I'm not there, but you know we are running another congress. There are 2 more congresses right now in Athens, so we have to be everywhere. Anyway, I would like to thank the organizing committee and especially Kostas for the kind invitation to participate. And let's go directly to the speech, because I think the time is running. So the title was given about the TAVI durability and long-term outcomes. It's always a question regarding the long-term outcomes of viable bioprosthetic valves. There was an argument regarding the surgical long-term outcomes, that they always are better than the unknown long-term outcome of the TAVI valves. However, now we have several data. The first thing that I would like to point out is that, as we know, with aortic valve disease getting older, and since we are in Greece, you can see that the incidence of aortic valve disease is growing, and the prevalence. So we are getting more and more patients with severe aortic valve disease. What we knew regarding the long-term physical history of aortic valve disease is known that if it's symptomatic, then the long-term outcome of these patients is not favorable. In fact, more than 50% of the patients with symptoms are not living more than 5 years. So long-term outcome, if you don't intervene, then there is a problem. We know the classic slides from Carambello and previously in aortic valve stenosis. What we know also is that there is a disease progression, especially in calcific aortic valve stenosis, and that's why you can see the growth, the increase of the velocity transvalvulary. So there are several factors affecting the growth of the aortic valve stenosis, and we've done several experimental studies. We published last year in the JACC Science a proposal regarding the role of spongiosa in the middle layer of aortic valve disease, and how this may play a role in progressing aortic valve disease. And we've shown that there are several pathways. Hypoxia may play a significant role, and the VICs that they are around this area of spongiosa may also promote aortic valve disease, and therefore it might be an increase of the velocity of aortic valve disease progression. So there are several factors. However, let's focus only on TAVI. We know the history of TAVI. We know the last slides, the last valves that we have from 2002. The growth of TAVI the last years and the expected growth that we're going to see. The annual outcome that there is more than the surgical aortic valve disease replacement, TAVI is getting more and more increased. The same means in Greece. We have now 22 centers of TAVI in Greece, and 23 actually. We have last 2 months, and you can see that the mortality how was decreased the last 10 years in all these centers. We know the guidelines. I don't want to lose you now the time, but you know the guidelines that for sure TAVI is getting a special population that is needed to be done. More than 80 years and 65 to 80 ACC and AHA promotes both treatments. However, we can see that TAVI is getting more and more population in this area. And why is that? Because we know that several factors affecting TAVI are favorable. All these factors are favorable for TAVI compared to surgical outcome. I want to pass this slide because the time is running. So, what we know about the long-term outcome of the valves? we have the self-expanding valves and the balloon expandable valves. However, only for two valves we have long-term data for the Medtronics, the Evolut, and the Sapien from Edwards. There are, of course, several trials ongoing. However, if we're going to see the low-risk patients, because the high-risk patients, we know that we don't have any significant and important data because these patients, unfortunately, don't live too much due to extra cardiac reasons for mortality. So we have two large studies starting in 2019. This was partnered 3 trial comparing with the yellow the surgery and the blue the TAV. And you can see that the primary endpoint was similar with a p-value of 0.07. The primary endpoint, I remind you, was death, stroke, and rehospitalization among the two groups. Actually, the all-cause death with a p-value of 0.35 was favorable. It was exactly the same, 10 and 8.2% at 5 years post the implantation. And you can see that the quality of life and the durability at 5 years was the same. And also the stroke was with a p-value of 0.6, exactly the same between the two methods. And rehospitalization was almost unfavorable for TAVI with a 0.09 p-value. So regarding the non-inferiority, we can say that in both trials was, in both approaches was the same. And I would like to point out that it's very important because if you see in low-risk patients in the United States of America, you can see that more than 50% are getting TAV compared to in 2021, 52% of the patients are getting SAV and 42% are getting TAV in patients less than 65. So we are getting in a very low risk population and you're getting this, and you can appreciate that it's getting increased and decreased in patients with the surgical approach. So we need long-term data. The Evolut low-risk trial was one of these trials that they provide us almost 4 to 5 years data, and you can see that it was, for the first time, you can see that it was in favorable of the Evolut TAV compared to the surgery. At 4 years, the primary endpoint, which was mortality and disabling stroke, 10% compared to 14% in this population. And you can see the stroke and the mortality, how was different. Mortality was 0.07 p-value, and you can see if you add rehospitalization, then the p-value is getting 0.04 compared to the surgical treatment. And this might be explained by the last data that we saw 1 month ago in the American College of Cardiology, in the study that was performed regarding comparing the two, the SAV and the TAVI, and you can see 5.4 in the German study compared to 10% in the SAVI of SAV in patients with in low-risk patients, death and from any cause or stroke, which was significantly increased, and also the SMART trial comparing the balloon expandable with the self-expanding valve in the after randomization, and you can see that it was the first study demonstrating that at 1 year the trial met both primary endpoints. There was no significant difference between the groups in death, stroke, or rehospitalization. However, the self-expanding valve was for the first time found to be superior in terms of valve function, defined as in terms of structural and non-structural valve deterioration. So for the first time, it seems that a self-expanding valve may have better results and maybe explain the better results from the Evolut trial. Now, regarding the long term, what we should focus on? We should focus on several factors. One factor is the endocarditis. The other is the leaflet thrombosis, the structural valve deterioration, local inflammation, mechanical stress, immune-mediated calcification, and the non-structural valve deterioration resulting from mainly from the procedure, incorrect valve position, or ppm or PVL. These are the factors affecting. We published in 2021 this interesting study in the American Journal of Cardiology. The first author is Stavrogiannis Konstantinos, who is now in IGEA. And you can see that the cardiovascular mortality in very high-risk patients at 8 years was 8%. However, the major problem was non-cardiovascular mortality at 8 years. And if you see the after the long-term follow-up of this high-risk population, you may evaluate that. I'm sorry, I passed it. That the valve size was a very significant factor affecting the long-term mortality. The smaller valve size, the worst outcome of the patients. In the national trial, also, we have at 10 years comparing SARV and TAV in low-risk patients, and you can see that there was no difference between the two groups, 64 and 62.7, the mortality rate. So this is in favor of the TAVI, that you can have a minimal invasive strategy. And also, if you add stroke and myocardial infarction, you can see the same percentage. Structural valve deterioration between TAVI and SARV, you can see that they, I'm sorry, I don't know why it happened. Okay. You can see, I don't know what happened. I'm sorry for that. Okay, I'm going again to show the slide. Moderate structural valve deterioration, 19% in TAV, 36% in SARV, and the severe structural valve deterioration, 3 versus SARV, 11 in the SARV group, and the modified moderate structural valve deterioration was also had also the same results. Bioprosthetic valve failure, valve-related death, no difference. Severe structural valve deterioration, 3 versus 11 in the surgical group. Aortic valve reintervention, no difference between the two groups. This is a patient that I had the permission. George was there when we presented it last year. You can see him in the photo. This patient was performed in 2008, and you can see his echo. This is 16 years after the TAVI. You can see perfect bioprosthetic valve, and this is our target to have such groups. So this is the smaller valve, and for the long-term outcomes, I've already showed you this data. And we also proceed in the whole Greece, the long-term follow-up. We proceeded. A sub-analysis was presented in the European Society of Cardiology Congress, and we saw that post-TAVI, the pulmonary arterial pressure was a predictor for 8 years mortality. This was significant. We have also 10 years follow-up right now with 27% cardiovascular disease-related deaths and 10% strokes and 20% heart failure hospitalizations. We have the long-term of DIRECT trial that we've showed several times here in Greece, and there are several ongoing trials. I don't want to lose now our time. I just want to focus on this, that we're trying to have a multi-center trial with the beta blockers, if the beta blockers play a role or not, also in the low flow, low gradient. So in conclusion, I would like to end that and focus that on the long-term results, that they are reassuring that TAVI, regarding clinical outcomes and valve durability, are at least similar with surgical follow-up. Further data, of course, is needed regarding the low-risk groups. Of course, it's a hard team approach, and we need more and more data regarding the long-term outcomes. Thank you very much for your attention.
Great. Many thanks, Costa. This is a great presentation. May perhaps I want to introduce that we have Dr. Damaskos on the connected. If you have any, welcome. We can see you. If you have any comments, go right ahead. And I will also like to invite Professor Michael Reardon to join us in the panel up here, if you would like, and offer some comments afterwards.
Thank you, Professor Dagas. Apologies, I've not been able to attend as I'm currently abroad. Professor Tutus made an excellent speech. TAVI durability is really, really very important. It will become even more important as the years progress. Perhaps as they did an excellent work on identifying pathophysiology of the mechanisms that destroy the native valve, perhaps we have to look at similar mechanisms that might destroy the TAVI valve or any kind of biological valve, even the surgical ones. Currently, we have from the STS ACC registry about a 7% rate of valve-in-valve that we are performing, and this is something that will certainly increase in the future. So we have to identify common terminology, common benchmarks for this kind of operations, and we all have to work towards trying to better place our valves so they will last longer, and even valve valves will last longer because we keep treating younger and younger patients. Thank you.
That's great. Well, let's ask the Professor Reardon, University of Texas, a world expert of that, and then Dr. Kilic, to tell us how the durability is related with what we call lifetime management of aortic stenosis in some ways. But whenever I opened up this discussion with any patient, they don't fully understand what I'm talking about. They have difficulty understanding what is a projected well-being in a horizon of 10 to 20 years, and probably they tend to minimize what I'm trying to get across to them. So how do we figure that out, except for outside, of course, innovation in TAVI and all that? Dr. Reardon and then Dr. Kilic.
Well, George, I think that the surgeons, we deal with this all the time. Patients walk into my office and say, well, the cardiologist says a tissue valve will last 10 years. And I tell them that's a meaningless statement. I need to know how old you are to begin with, what's your physiologic state. It's different for every patient. Every heart valve is going to fail at a different rate, both surgical valves and TAVR valves. It's not a class effect. It's related to valve design and tissue science. I do plan to present the low-risk Evolute trial at ACC next year, and we'll see if the curves continue to diverge. And we did present the 5-year durability data on the Evolute valve from the high risk and intermediate risk, and found that it was actually higher in surgery than it was in TAVR, and it was related to a doubling of your mortality if you had moderate or greater structural valve obstruction, a doubling of your cardiovascular mortality, and doubling your rate of rehospitalization, which probably explains why we're seeing the curves diverge between surgery and TAVR, since TAVR with Evolute has a Doppler velocity index of 0.61 and surgery is 0.5. The bigger opening you start with, the longer it takes that valve to fail. And I think that's why we're seeing this.
Bigger is better then. Dr. Kilic and then Dr. Tsolakis, maybe.
Since there's a tendency now to do TAVI in young patients, durability is very, very important point to be considered. So, but most of the durability data is coming from the old generation valves. But also newer technologies are coming and novel valves are coming. So the exact mechanism also underlying structural heart valve deterioration must be also much more clearly determined. Also, I mean, what is the, for example, definition of the real structural degeneration? Only gradients or on other points? So all these points must be considered also according to the new criteria also of the Vascular Academic Research Consortium. So the old generation valves, most of the durability data are coming, these data also must be re-evaluated, my opinion. And we should also think about younger patients. When a young patient comes, durability is important. If the patient had also a surgery chance, we can also think about surgery.
I would like to say something different than you. I see that the patients that have a tissue valve either in SAVR or TAVR. The main problem is that the patient in the big age, in the higher age, can continue to live without doing anything more but living by food, small exercise, and so the durability is very good for them. The main problem remains for the patients which are in lower danger and in a lower age. So, first of all is the size. The second is the exercise. If you have a young patient with big exercise, with many exercise, so you cannot have durability. And the second thing is the size of the valve you can put. Many surgeons prefer to put size bigger, but the best we can expect from the valves is if we have a big annulus, we can have very good durability. Small annulus means small durability.
Yeah, no question about that. And again, coming across to the patient's priorities, the older patients, better durability. The younger patients, the not so good durability, but again, you see there's a lot of push of younger patients to not take anticoagulation, go against a mechanical valve. A lot of them now, the newer push, I don't know, perhaps a New York phenomenon, they don't want to take time off. So they really have too many things going on. They say, oh, you know what, I don't want to take the recovery, this, that. It's just very difficult to get through to them. We are, of course, but it's just like every age group has different priorities and different concerns. Let's look into optimizing TAVI outcomes, though, is our next subject, because durability is only good if you have a very, very, very good result up front. You have a bad result up front, there is no durability. So let's hear my partner and a fellow of the Society of Cardiovascular Angiography and Interventions, the first heart surgeon to join the FSCI program, Dr. Gilbert Tang, who is going to talk to us via the video due to the fact that right now in New York is like 3 a.m.
My presentation is on optimizing TAVI outcomes. Here are my disclosures. So what we need to optimize for TAVI in 2024 are these 5 things. Minimize PVL, perivalvular, optimize valve frame expansion, minimize pacemaker risk, avoid severe prosthesis patient mismatch or PPM, and facilitate lifetime management, mainly coronary access and redo TAVR. And to do that, you need commissural alignment and CT simulation. Here are the current generation TAVR devices. Some of the ones you see here, such as SAPIEN 3 Ultra or Resilia, Evolut FX and Navitor are now available in the United States. All these have external sealing mechanisms to minimize perivalvular leak. However, we still need to post-dilate when necessary to reduce the leak, particularly if it's only mild or moderate, and we should aim for trivial or none, based on the anatomy that we deal with. The other reason to post-dilate would be to optimize valve frame expansion. In balloon expandable valve that we have seen recoil during expansion, such as the Resilia, or self-expanding valve looking at the RAO caudal projection and the short axis of the annulus, such that you try to achieve a more circular geometry whenever possible. Here's the seminal paper from Circulation showing that a significant percentage of TAVI devices that we put in actually are underexpanded, and underexpansion is associated with halt or hypoattenuated leaflet thickening. So you can see that example here. This is an underexpanded 26 SAPIEN 3 despite nominal inflation, and you can see the area of the native annulus on 451 millimeter square, and when you deploy a 26 millimeter valve, you actually end up being more like a 23 millimeter across the entire frame geometry. And we actually have published 2 papers on this topic, such that we do not need to oversize much at all now with balloon expandable valve. In fact, if you undersize beyond the manufacturer recommendations, provided the mean diameter is 1 or 2 millimeters just above the nominal dimension, you actually, because of the native leaflet occupying space, achieve more complete expansion as we show in the CT without compromising hemodynamics, including mean gradient. At the same time, you can see that here on the top right panel, you By downsizing the valve, you actually would facilitate reduced TAVR, and you can see that here there's significant difference even at 80/20 deployment depth. The other thing we need to look at is pacemaker risk. Obviously, nowadays we try to implant high, and we use the cuss overlap view for self-expanding valve, and maybe even balloon expandable valve as well during deployment. But keep in mind that high deployment will reduce coronary access and reduce TAVR feasibility. This is the first paper that described the cuss overlap view published by our group on simplifying self-expanding valve deployment. And since then, as we know, that it has indeed reduced pacemaker rate. The other advantage of using this view is that you can aim to achieve commissural alignment in a variety of self-expanding devices, including Evolut and Accurate Neo. In fact, balloon expandable valve is also being deployed now in aerial caudal projection or cuss overlap view in certain centers, including this paper from Cleveland Clinic showing a reduced reduction in pacemaker rate. And so this is very important to consider now in the current TAVR era. Severe PPM after TAVR we now know is associated with increased mortality. And you can see the seminal paper from the left by Howie Herman and Longevity Registry showing 1 year increased mortality to a meta-analysis in JACC imaging showing the same pattern across several studies. Now this New England Journal paper just published on the SMART trial looking at self-expanding supraannular Evolut valve versus the SAPIEN 3 valve with Ultra in small annuli, showing that indeed with a supraannular self-expanding valve has some benefits. And in this particular study, balloon expandable valve did have higher gradient, lower EOA, more paraprosthetic valve dysfunction, and more moderate severe PPM versus the Evolut platform. Now, lifetime management after TAVR is increasingly important, and specifically coronary access and reduced TAVR are now hot topics in most meetings. And the reason being CAD after TAVR, it's really prevalent. You can see that here, even in intermediate risk patients, over 60% of them have coronary artery disease. And so really depends on the coronary angiography and PCI, depending on the device type and anatomy of the aortic root. And the reason why it can be challenging is that most operators out there are not familiar with TAVI at all. And so the number of barriers limiting reaccess, not just the native aortic valve leaflets, the valve frame, and of course, the valve commissure if you have misalignment. So really important to understand the aortic root anatomy and the TAVR device. The shorter frame valves will be more relevant in terms of reduced TAVR than coronary access. But the taller frame valves, most of them are self-expanding valve, will be relevant in both coronary access and reduced TAVR, particularly in supraannular devices. This JACC state-of-the-art review that we published outlines some anatomic and device procedural factors involved in coronary access. And you can see that here, commissural alignment is now extremely important because not just affect coronary access in taller THV, but also reduces coronary obstruction risk in TAVR shaft, increases the likelihood of redo TAVR. There's now early evidence of impact on durability and hemodynamics. Certainly, leaflet modification would not be feasible, such as basilica if the commissure pulse facing the coronary. And of course, all valve manufacturers now are focused on this topic, so clearly everyone's seeing this as critical to the lifetime management. And we have recently published a Aligned TAVR Consortium state-of-the-art review in JACC dimension, talking about this topic, defining the degree of misalignment to standardize the nomenclature, and talk about some of the coronary eccentricities and some of the other techniques as well to optimize alignment. For those of you who don't know what alignment is, you can see that here on the bottom, on the left side, if you have a commissure alignment with the native commissures, you really have a lot more open cells available to access the coronary, versus the right side, if you have a commissure pulse facing the coronary, you really have to go either side of the pulse to access. So for the Evolut platform, we now know that you can insert the flush port at 3 o'clock and then get the height marker facing you directly in the center front. And when you release the valve, as long as one of the head marker, the C-tab rather, faces the right side of the screen, as you see here, then you should have good commissural alignment. With the accurate neo2, it's a bit more complex. You start with the flush bar at 6 o'clock, and a 3-cusp view, you see where your projections are on your 3 paddles. And if you see that the 3 paddles, one of them may be here 111, you might need to actually go to the cusp overlap view and make sure that one of the tab is facing the right side of the screen, like what we described in Evolut. If not, then you should try to rotate clockwise or counterclockwise to achieve that. In fact, Giuseppe Tarantini's paper show that if you have commissural alignment with these tall self-expanding valve, you can see that selective coronary angiography is improved compared to if it's misaligned. Now, commissural alignment is also important for TAV and SAV because you can see this here on the panel E and G that even if you have leaflet modification, if you have a commissural post facing the split portion of the leaflet, you still have coronary obstruction risk. So clearly this is important for TAV and SAV even with leaflet modification situation. And you can see that if you have 2 valves in place after redo TAVR, the commissural alignment of the second valve, if the first one is short one, the second one being tall would be important, and vice versa. If the first valve is a tall valve, then the commissural alignment would matter first, especially if the second valve is a short valve or particularly a tall valve. The problem with having the tall and tall combination of redo TAVR is that these 2 valves don't align in the cells. So really you reduce the cell opening significantly after the second valve goes in. In fact, it might not even be feasible to perform coronary access afterwards. Now, what about lifetime management? You see that here, this nice European Heart Journal review shows the different aspects of sequencing of TAVR versus SAVR. And you can see that here, if you have a TAVR failure, the number of mechanisms involved, and depending on the mechanism, your management strategy would be quite different. Either will be usually redo TAVR or TAVR extra. And there are now new vocabularies to learn to be able to figure out some of the nuances involved. But thankfully, we have sizing charts now, and Minibaba just launched its Redo TAV app. You can see that here on the right side of the screen that walks you through all the workflow of how to reevaluate patients with failed TAVR for redo TAV feasibility. I've also have a YouTube channel that shows you how to perform CT workup, and they'll be updated soon. And you can see that here, these are some of the examples of the redo TAVR of different combinations. Now, CT simulation before the in-depth TAVR might be important because you can see what is the likelihood of redo TAVR. You can see this paper just published in Circular Measure by a group showing that if you have a higher implant, your likelihood of redo TAVR of unlikely will be going up, so it's less going to be, will be less feasible. At the same time, it could be the same in terms of coronary access as well after 2 valves being placed. So in summary, achieving optimal TAVI outcomes is now paramount as TAVI expands to younger and low-risk patients. Besides minimizing PVL and pacemaker risk, optimizing the index TAVR procedure will be important to confer durability. You want to avoid severe PPM and also aim for commissural alignment whenever possible. And lifetime management feasibility must be evaluated in addition to the above factors, particularly in younger patients where the patient will likely outlive the index TAV. I'd like to thank you very much for your attention.
All right, well, you know, Gilbert does a great job presenting a lot of things and also creating very complex slides. We're going to go to the complex scenarios right after, but first let's have some reflections from the panel about what we heard. And my first reflection is that all these things seem to be attractive. They seem to make sense, but it's so complex to figure out the slides. Are we really practicing them even sort of blindly while we're doing the procedure? Because, you know, all these alignments work well in the simulation perhaps, but while you are in the procedure, you look at the hat maybe or look at something else, And even the coronaries are not exactly aligned the same way in every patient. Perhaps we start from our surgeon that has much more experience with, the patient variability of coronary, let's say, ostia location, and how could we make some practical sense of all of those situations that we just heard.
Well, the good news is I can always align my valves. I never miss the commissures, ever. Sometimes the bicuspid valves are 180, and then you have to favor the left because we always want to make sure that we can get back to the left. But for the Evolut FX, we can pretty much always align that. We'll get about 90% alignment. It's got the dots on it now. The newer Navitor is going to be called the Vision. It has dots. A little harder to line up. The Accurate we can line up. It's a little harder to see because you look for the free cell. I can't line up with a balloon expandable yet, but the next generation is supposed to. And I think the closer you get to replicating what we do as surgeons, the better off you'll be. I think that having your sinuses open not only gives you access to coronaries, but there's a reason you have sinuses, and you need those open, and you really don't want to post in front of it. So Gilbert's done a lot of work showing us how to do this, and we teach all our fellows on all these self-expanding valves to line up the commissures.
I mean, coronary access is becoming a very, very important factor because we're moving to younger patients. And in the older population, perhaps AS protects in some ways or has protected them from development of CAD, or the disease is not aligned all the time, but the earlier you relieve the aortic stenosis, the more exposed you are to risks of CAD later, so it's an important factor to be considered. Perhaps Dr. Kilic and then Dr. Damascus.
For the commissural alignment, I want to make some comments, especially about the balloon expandable technology, with the novel balloon expandable technology. My wall octacore, for example, creates a clockwise octaline method. Especially, you had to look at to do CT image before the procedure. It's very important to find the geometric nodule of the valve salvationis and the exit point of the right coronary artery, and make a clock angle, and then according to that clock angle, you crimp the valve, balloon expandable valve, of the commissural post, at least one of the commissural posts, to the exit of the right coronary artery. So this shows that over 90% commissural alignment for the balloon expandable valve. As Dr. Riordan underlines, for the self-expandable technology, it's very important to look at to do procedural where the capsule head marker, center front or center back, especially in the cusp overlap views. So these all are very important for the future coronary access. But my question may be, how many of patients, older patients, after TAVI, do you routinely use coronary angiography, or how many PCI have you ever been performed for older patients?
No, not that much. I mean, of course, I follow the practice of if you need to fix a coronary, I like to do it when it's easy, before the TAVI. I don't understand quite frankly, I don't understand even the study designs that pushing coronary procedures after TAVI, because you just take something that's quite simple into something that just, even if it goes well and smoothly, it's definitely more complicated. So why muck around, so to speak? Let's go to Dr. Damascus and then Dr. Tsolakis for their comments. And anybody here, or by the way, anybody who welcome our internet attendees, you can send a note in the chat. I have it right in front of us here, and we're going to ask this question as you view the session through the web. Dr. Damascus.
Just want to say that deployment is very important even in older patients, because you never know how long they will be around and if they will need a second TAVI at some point. So we have to do our best to follow certain benchmarks and do the best deployment we can in the room. Of course, can we say that we can reproduce deployment 100% every time? No. We all have to work and get better at that. But we have to do our best in any case. Also, just to bring into attention, there are what I call hacks, like the basilica procedure. We have to take a good look at those kind of procedures and ideas, because they might give us some slack on a not 100% certain deployment, and give us the ability to make small mistakes in the room that we will not pay in the future.
Great. Dr. Alexei?
I would like to say something else. The main problem with the coronary ostea is the same problem for all the patients, and you will find these problems as long as you are doing younger patients. The height of the coronary ostea is the main problem, first of all. Second is the alignment of the commissures. As a surgeon, I know very well that there is not a circle annulus in every patient. There are so many differences between the patients that cannot be able to know before the operation, before any TAVI, the coronary alignment, the annulus alignment, and the leaflets. So the problem remains, if you're doing younger patients, you will see more problems, as we saw there's problems in open heart surgery. But the future is that if you are doing also younger patients, you will see that sure you're going to see also coronary artery disease. And the second operation will be much, much more difficult than the first operation TAVI in these patients. This is my opinion.
Yeah, no question. And let's come back to our heart surgeon. I want to ask a very specific question, because it's coming up. There's a wave of patient-driven preference to earlier ages. How facile is our surgical community into TAVI explant and reoperation? Where are we with that? You know, I'm not sure we're anywhere, quite frankly. And I mean, I don't know what to say, except that it's just becoming a reality with all the waves of these TAVI valves that, you know, some of them are going to treat with valve-in-valve, but some maybe not. And, you know, I think, does it vary according to what kind of valve you have before? Let's say a core valve or a balloon expandable, a taller or a shorter valve?
Yeah, well, clearly the taller valves, all the self-expanding taller valves are going to have a harder time having a valve-in-valve. And we usually put a balloon expandable inside a self-expanding, and when a balloon expandable fails, we put a self-expanding inside a balloon expandable. But 30 to 50% aren't going to be able to have a TAVR and TAVR, and they're going to need it explanted. And you know, Gilbert did the explant TAVR registry and showed that it had double the mortality of just doing a redo aortic valve. The problem was the mean number of explants done by surgeons was 1. Most people have not done, whereas centers, I mean, I haven't done one since Wednesday. That was the last one I did this week, because now they're coming in and the smaller centers don't see them. And so we're doing one almost every week now. Now in the U.S. we did over 100,000 TAVRs in 2023, and about half the people under 65 are getting TAVR. So for my younger generation surgeons, this will be the fastest growing operation they need to learn. And I have, these are all done by my fellows, because I'm really interested in how we can then teach this to our fellows. Because we're going to have to learn to do this and learn it better. But I do tell younger patients when they come in asking for TAVR, I can look at your CT and I can usually predict how likely we're able to do a second TAVR. You have low coronaries, small sinuses, you're going to get your TAVR explanted. If you have a really tiny annulus, you're going to get your TAVR explanted. And I tell them up front that this is not just it's not just like getting a first-time aortic valve. It has double the mortality. And I think the reason we're moving to younger people in the U.S. is we have some non-functional heart teams where surgeons aren't really playing a role in actually telling the patients that. And that's a problem.
Yeah, we'll come back to that last one after our last speaker of the session. TAVI in complex scenarios by Dr. Velianu, who are traveling from Canada. And we thank him very much for his year after year contribution to this great conference. And of course, now after we learn how to optimize, let's see how we're going to do all these things in the complex scenarios. Go ahead, James.
Ευχαριστώ πάρα πολύ. Είναι μεγάλο timi mu puima mazisas. Again, I'd like to thank the organizing committee for putting on a great session every year. This was a little difficult presenting this because I was following such great speakers and of course the audience that's here. And the title that Costa gave me really is a title that we should do all day. And that's what we're doing all day, is talking about complex situations. We know that variety and complexity in aortic stenosis patients determines the ultimate treatment strategy. And as Dr. Reardon pointed out, we need functioning heart teams to actually put all the information together to give the best chance of a good, successful procedure to a patient. And whether that means doing surgery, whether that means doing TAVI, or whether that means doing medical therapy, it's very important. Because ultimately, we shouldn't be just about putting in a TAVI valve, we should be about treating the patient appropriately. And again, you've seen this, everyone has seen this slide before in the European Heart Journal, but depending on the situation, we might favor one over the other, but ultimately we have to put it all together to see what is the most important. That's why, again, we need this heart team. And everyone is involved with this, especially the interventional cardiologist and the heart surgeon. But other people may come in and out of this team. You might need anesthesia during the procedure, but you might need their input before. You might need geriatricians, you might need neurologists. But you need a functioning way of treating these patients appropriately. I like to view complex scenarios in really carrying out the procedure. The access, the landing zone, and other factors. Of course, access can be complicated depending on the size of the vessel, tortuosity, calcium, and often we have to consider alternative access. In our center now, carotid has been the dominant alternative access. I still remember the days doing the transapicals, and they were fairly quick, but often these were sicker patients that other things would happen down the line. The landing zone is an issue. Again, this is where you need meticulous CT imaging, bicuspid valves, severe calcification, risk of coronary obstruction, and of course, pre-existing prosthetic valves in there and how to treat these. I'm not going to go into details of every single one because again, that would take all day to do that and it would take people who know more about this than I do. But needless to say, we really need the imaging to assess these appropriately so we know the actual risk of doing the procedure in a patient. And nowadays with lower risk patients or younger patients, and again, lower risk and young is not always synonymous, but a lot of these patients have big vessels, they're straight shots. You know, technically, most of them are not that challenging. But when we do come against challenging situations, especially in younger patients, we have to ensure that is the right way to go in terms of doing TAVI or not. The other issues that we have to think about, electrical issues, complex heart conditions, again, concomitant other diseases, whether it's valvular disease, aortic aneurysms. We cannot disregard these things for the simple fact of putting in a valve quickly. And the non-cardiac risk factors, frailty and lifespan limiting disease. Again, we may decide on a 50-year-old to do a TAVI because we don't expect them to live till 60. That may not be the wrong thing to do. And of course, an 85-year-old who's going to die at 86, we shouldn't probably do anything with. This is Grube's somatic of the big five, and I like to add on top of that because, again, it fits with complexity in what we do. Stroke, again, it's always there. There are ways to potentially prevent it, but we're waiting for more data and meta-analysis for cerebral protection devices. But stroke is not just ischemic. Stroke can be shower, where patients maybe have delirium or other issues, cognitive issues afterwards, or an increase in any cognitive issues that they have. They could have mild dementia, now they've become moderate dementia. And of course, bleeding. And bleeding can happen during the procedure, but you also have to think down the line. If this patient is high risk of cerebral bleeding, and we're putting a valve-in-valve that may require anticoagulation, we have to think twice about doing that procedure in that patient. PVL, but I like to, again, add annular rupture, coronary obstruction, and other factors in that landing zone. Kidney issues, of course, and other metabolic issues. Post-procedure, thinking of heart block, but not just heart block, atrial fibrillation, and VT. And I like to look at atrial fibrillation because there's some patients that may benefit from surgical MACE on top of their a SAVR, and also left atrial appendage removal. And maybe surgery in this patient may be a better a better choice. And of course, bleeding, but not only bleeding, but vascular compromise and inability to anticoagulate. We have to think of all these. So for an example, again, I don't want to show, I tried on purpose not to show data. I wanted to show more concepts and discuss approaches. Frail 85-year-old, multiple medical issues, and you can see their BSA is very low. LVH, typical severe aortic stenosis, possible cardiac amyloidosis. We don't test for all these patients, but a lot of the elderly patients do have this. We're seeing more and more. And even on echo, we could see that this patient had calcium. Oh, sorry, this patient didn't have calcium. That's the next patient. An annulus that is easily treatable with TAVR, but small access. So we're taking a frail patient in their 80s, and we have very small access, and we have to decide, can we do this or not? And if we have other options, younger patient, we may say, let's do something else. This patient didn't have option in terms of surgery, and they didn't have option of alternative access. So we felt that we could go slowly, dilate up the vessels, and take care of this, knowing that there was a risk to doing so. I always like to imagine this as truck to tunnel size. We're putting a big device into relatively small vessels. And again, depending on the device you're utilizing, you want to ensure you can actually place the device through the conduit. So we went slowly and dilated. And it's not just about dilating, and this was going to be a balloon expandable, not just dilating to get the sheath in, but dilating to get the device through the sheath. And some people will go in and balloon inflate, but this was sort of a diffuse small vessel, mild disease. We thought dilatation would be the best. Place the valve in. Everything went pretty smoothly there. Got better. But then we're left with this. So exactly what we were worried about happened. Now, we don't know where the problem was exactly. Was the problem on the closure? It was a clean closure area, but a smaller vessel. Or was the problem further up? So went across, wired it, and actually treated this with coronary balloon because it wasn't a big vessel. So put in a 6 millimeter coronary balloon over a coronary guide wire. And we could see that there was dissection as well as stenosis. There's the balloon. So we may have had two issues at the same time. So we had flow, and at that time I called our vascular surgeon. We have a very good working relationship. And I thought maybe we should treat this stent above the femoral head because I don't like putting in stents around the femoral head because of movement and crushing the stent. And you can see here the CT. He said, no, let's leave it alone. Let's see how it does. And as the surgeon said, sometimes the hand of God is better than hand of surgeon. And the surgeon was actually right. Was admitted to hospital, unchanged on CT. And patient did okay. Even with the stenosis that was still there, the patient was not that active to use their legs that much to have symptoms. So, get back to here. So they did well with that, no problems, went home. So this was a win. Although it was initially a loss, it was a win. Tortuosity. You can see very tortuous vessels. Now getting through this is very problematic. And sometimes with extreme tortuosity, as an earlier talk today, we have to think of alternative access. There is simply too much tortuosity, especially when it's and concurrently with calcium, because you cannot straighten out these vessels. And I think in these patients, we have to try and straighten out these vessels as much as possible. So initially, I'd be a minimalist saying, let's just try it. But I don't do that anymore, having been burnt. So I'll use buddy wires, both sides, Lunderquist, whatever I need to straighten out the wire and be able to get the equipment up. I'll even put longer sheaths in the accessory vessel. Just so once the sheath is in, you're not worried about placing equipment through it, catheters, things like that. And it will help straighten out the vessel. So transfemorally, before, we don't want the procedure to end before it starts because it can happen. With extreme tortuosity, we should be using stiff wires to try and straighten out, buddy wires, long sheaths. Sometimes in these calcified small vessels, we have to use things like Rotaglide. And for our surgical colleagues, that's basically Caesar salad dressing. that we use for rotablator sometimes that is very slippery. Or we use propofol, which is a lipidic substance, and I don't know if any of you have tried that. Wipe a bit of propofol on a sheath or dilators and use those to go up, and that will help. Also not help put it in, but also help remove the sheath in the dilator. Sometimes we have to do balloon angioplasty of the peripheral vessels or even intravascular lithotripsy. And we have to be able to do other things, whether it's a cut down. Often we will use a cut down instead of perk these vessels because we feel we have better control. It's always easier to surgically manage these after a cut down than after a perk that's failed. And again, with TAVR access, you see more recently, we see that the dominant axis is femoral, and it should be because that's where the evidence is. And slowly, carotid, I think, has overtaken subclavian because of the issues. Transcaval is, I think, being done less and less now. I don't have any experience with transcaval. I have experience with all the other ones. But it can be finicky. And of course, apical, we have not done an apical in our center probably for 8 years or so. I don't know if other people, if they're doing much apical right now. That still may be an option, but again, this isn't something we do. And rock, you can see there's a cave. And there's another patient. There's a patient that has severe AS, 83 male, other medical issues. We see this vessel, this annulus here in the outflow tract. There is calcium, but we thought this was treatable. Surgery was not a good option for this patient. So we went ahead, we ballooned, nice and slow, put in a valve. Post-dilated because there was a paravalvular leak. Nice slow inflation, and it was a double tap sort of mechanism, not necessarily more, but just to make sure it was inflated. And very good result there. But unfortunately, a bit of a fistula. Being that this patient was not a good surgical candidate, we elected to watch this. As we're doing so, we were also looking at the ECGs, as we all do. A bit of a bundle branch, increased a bit, got a bit better. We said, okay, things are going well. Let's send them home on an extended Holter. They did well, feeling well. Unfortunately, surprisingly, VT. So, story continues. We brought the patient in. They're a bit dizzy. Arrhythmia was involved and felt that given this fistula, there is some evidence that patients who have a bit of VT can progress to more VT. And they felt a defibrillator was appropriate. So they did that. I didn't really push back on that because they know the area better than I do. And the patient was discharged. But the story continues to continue. Patient was shorter breath 2 weeks later. After a nice TAVI, sometimes we discontinue their diuretics. So this patient's diuretic was decreased, but with a little bit of the fistula, a little bit of overload, patient came back in, diuresed, did well, has no problem since. So we're medically managing this fistula. Again, heart team approach. The surgeon looked at the situation, thought this was a restrictive lesion. We should just leave it alone, and patient's doing very well. So again, the predictors of annular rupture, again, this wasn't a rupture per se, but LVOT calcium and balloon close dilatation, which we did. We have to be prepared for these things. So to prevent annular complication, prosthetic sizing and selection, choose the correct device if you feel there's a certain device that's better for this. Procedural imaging. And it's not just doing the CT. A lot of centers will rely on a radiologist who really doesn't know what we do in the cath lab. I don't think that's good enough. I think we have to really review the images and understand the images. And all our fellows are taught level 3 CT when they come in, and they actually teach me. Modifying balloon inflation, nice and slow. It's like pulling on sutures quickly or pulling slowly on sutures. You don't want to disrupt a situation. And if there's significant calcification, sometimes you have to think of not doing the procedure. And again, other complications that can occur. That's why, again, meticulous planning, meticulous review. So what does the heart team need? Procedural excellence, procedural range, procedural humility, trust, and a view to the long game to ensure that our patients treated to the best possible way. And ultimately, the heart wants what the heart wants. And again, this may be in terms of love, but this is in terms of aortic valve, and the aortic valve is often needed. And when we cooperate, we can all climb Mount Olympus. Thank you.
Great. What a great, I would say, overview for this entire session. Let's. I have to say that the access issues are really the biggest one, because you get a problem there, and it's a problem with the stenosis. The worst are the perforations. We have been employing the ballooning through the sheath as a safer way than ballooning before you pass the sheath. And with obviously particularly one of the sheaths, which is expandable inside the body, enters and can pass through a smaller arteries, and then you make it big before the valve. It's a little tricky, and I have to say, in the beginning of the maybe 10 years ago, we used to do some cases, not the small number, but not a big number, of common iliac access to bypass all of those. Never done that since the advent of the self-expanding sheath, the expandable sheath, I should say, and since the working with the vascular group for the endoconduit, so to speak, that you line up an endovascular stent graft, let's say, and then you balloon through it. Pretty much the same thing, and then you pass the sheath. I don't know what other. I'm interested. Interestingly, the carotid is indeed surpassed the subclavian, and is, to my a little bit of a surprise, is very much permissive regarding stroke risks. That's an interesting, I would say, clinical observation. Dr. Kilic has some comments, and then Dr. Damaskos.
Especially for the first case, you, for example, can put a contralateral safety guide wire before the insertion of the sheath. Maybe I am doing in every case after ProGlide insertion, contralateral safety guide wire. In any problem, change the guide wire with a stiff guide wire and put a grave stent. So, because if any complication, vascular complication occurs at the index procedure, it is not very easy to come back from contralateral, and the patient is bleeding at that time. And you also mentioned the importance of the shockwave lithotripsy. It is really working. We did a lot of cases, especially in patients with circumferential calcification. We evaluated with the IVUS before also, and the shockwave really is working in femoral arteries, and it is a very good alternative.
I agree, and if it's discrete especially, I worry about people that want to treat the whole iliac when there's a nice simple carotid to go through. But absolutely, IVL is a great way to treat these.
Well, for those of us that are responsible for what the procedure cost and have our administrators, if I shockwave you, it costs me $2,000 extra. And so, unless I don't have alternative access, my young fellows all want to shockwave us. They find it so much fun. And yet I can get you your carotid in 3 minutes and it goes smoothly. I was just up at Cleveland Clinic 2 months ago. Samir Kapati asked me to come up there and do some carotids because their team were worried they're going to stroke everybody. Yeah. Now that they've just found out they're not going to stroke everybody, it's becoming their second alternative access. Shockwave works, but it's an extra $2,000. And again, my contribution margin is fairly slim, and I have to sit down with an administrator twice a year and justify my program.
So you have to imagine that's in Houston, imagine in Canada. So
yeah,
we have to.
I thought things were free in Canada. Is that not true?
Yeah.
Yeah. It should be less money in Canada than the United States, or more money, I think so.
No.
There's more money in, more money out.
That's
money
out. Thank you.
More money in, more money out. Higher reimbursement, higher expenses. That's how it goes. Dr. Damaskos?
Sorry, was just thinking that cutting costs, perhaps we can use our vascular surgeons when we're trying to access the femoral artery. We actually do it a lot here in Greece. We consult with them, and sometimes they are the ones that put in the sheath on our behalf, and it is really working fine for this special category of patients. I just want to say congratulations on some excellent cases that were presented. And I think that we all have to be ready to fix problems, because all these fragile patients have different problems, and we have to keep improving our skills to be able to deal with them. So thank you.
Well, this is a nice.
About what James said.
Yes.
You talked about the CT scans. One thing that really bothers me in the U.S., a lot of sites just take their CT disc and send it off to a company, and then it comes back, and they never look at themselves. And would you send a coronary bypass to a surgeon that didn't look at the cath? Of course not. And instead of looking at it and deciding how best to do the procedure and which valve to choose, they just send it off and do whatever the company sends back. I think your comment about looking at the CT, in my place, if the fellow can't read the CT, doesn't get to do the case.
Yeah.
Yeah, interestingly, that's two interesting comments. To begin with, when we started up the TAVI in the United States, or generally, what was the #1 study that was heavily criticized by then pioneers of TAVI? Let me tell you, the CT. The #1 question was, why do I have to do a CT on everyone? Why do I have to do this? Why do I have to do that? For many people who are now advocating for CT, not Mike, but others, and it was very, very common. But we all learn together. That's the message. As I told you in the introductory comments, we now accept the structural imagers part of the heart team in SCAI, our interventional society. Why? They have become such integral part, and all of us have learned the CT and the intricacies of the CT and the importance of planning. And nothing like, okay, kind of looks okay in the echo, let's go and figure it out. You know, that might have been good for the 2002 to 2003 and 4 era, but now not in the 23, 24 era of this century.
Absolutely.
No, James, isn't that your experience there?
No,
that,
I agree. My first TAVI, I'll tell you straight, 2008 with John Webb over my shoulder, and we embolized the first one. And we sized it with TE. He thought it was okay. We thought there was only 2 valves available at the time, at least balloon expandable, 23 and 26. This patient clearly needed a 29, but we didn't know enough. So we were flying by the seat of our pants at that time. So CT imaging now is very important, and I think anyone who nowadays coming in, not grandfathered in something, but anyone who's being trained now has to know the skills to do that. Absolutely.
Yeah, indeed, that's my #1 lesson to the new fellows and all that, is that the fellowship is really with the imagers primarily, in order to make the decisions, because you're going to go out, they're going to join a program. Some of these programs rely to our new graduates to start them up or propel them much. So you're not going to have a senior person knowledgeable about those new things necessarily. Maybe they have all the patients that control all the referrals, but they don't have the experience, and they definitely don't need you to blow up the balloon or deploy the valve. That's the least thing they need. What they need is a planning, is the integration of these imaging aspects with the clinical techniques. So they really have to do the first few months immersed in the imaging laboratory, which is a bit strange because everybody comes in and they want to put a perclosis and want to throw the valve in, but they have no idea what size they put. Well, that's not good. You know, that will really highlight that up top. And I'm sure Michael does the same for the surgeons who are even more impatient to implant and get out.
Yeah.
Isn't it?
No, I absolutely. We really, especially if you're going to take a healthy 65-year-old and not offer them surgery, which is low risk. A low-risk 65-year-old, this is a surgeon's dream. And in TAVI, if we're going to put a valve in, we have to make sure we get surgical-like results, right? We have to.
I tell you, it's all planning. It's all planning. Everybody wants to put the valve in. I could teach my wife in 3 days how to implant a sapien valve. Just hold still while I blow up the balloon. Yeah. But if the fellows at my place, if the fellows can't show me how to do a CT and which valve they're going to choose and tell me why they're choosing it, they don't get to implant the valve.
Well, a final question I want to ask actually to both James and anyone here and Mike is the following. Interventional cardiologists, or cardiology if you want, pathway, they're very motivated to learn about structural techniques. They look forward to structural techniques. To my limited experience, the heart surgeons are really not so enthusiastic. And that's I would say, a sad realization from my point of view, because they've had about 20 years and even the new trainees, I think only a minority are truly interested in planning and performing the procedures. They're very much interested, I guess, to discuss in the heart team and have some, I would say, spotty presence in different parts of the whole process. But I don't see that much of a zeal as that what I see in the cardiology trainees. And, they're included, of course, but, where is that going to lead us in a few years? Are going to kind of, step up with a program, or they're going to sort of like sideline themselves due to their kind of not so much interest in, I don't know, or is the fact that we're repairing more valves, I want to make it more interesting to them. Clearly, doesn't seem to have made it that much interesting so far. And are we doing something wrong in the way we integrate this? And Mike, what is your what's the experience in Canada with the surgical partners?
Well, so there's a rule for my surgeons that you can only do transcatheter structural 1 day a week, and every other day you have to do open heart surgery. Whereas my structuralists, I want them doing it 5 days a week. It's always going to be different, and not everybody. I have 2 surgeons that do this with me. And not everybody does it. A lot of them want to come in and implant the valve, but they can't. Again, they can't implant the valve, so they can show me. They can sit down with my imagers and with my cardiologist, and basically do it. I can do this with my cardiologist doesn't show up as long as I don't bang a coronary. I'm good. In fact, it's not uncommon that I start with the fellows because they're up doing a STEMI, and we call up and say, send somebody down. We're getting ready to implant the valve. You got to be in the room, and then they go back and finish their STEMI. That's not the norm. And it's probably, you're right, George, I think it's become less the norm. I think this will eventually in the US follow Europe, and it'll often become a single operator. But I hope that at least big centers where you're doing 300 plus a year maintain at least a couple surgeons that are deeply vested in this, because it makes a big difference if your surgeon's really there. You may not want to shockwave that bad iliac, just do a carotid, get the heck out of Dodge. Or if you're Jamie McCabe, you just do it percutaneously.
I agree with what you said. We're a fairly large center. This year we'll do about 500 TAVR, and we have 3 dedicated surgeons who have fellowship training in it that we've trained. We welcome this. A lot of our trainees, cardiac surgical trainees who come in want to do TAVI, but we've welcomed them. And we're one of the few centers in Canada that actually will train cardiac surgeons to do TAVR. So I may have a skewed view. In a lot of other centers, they don't want to train cardiac surgeons, so they may not feel welcome, and they may not go ahead and get that training because they won't see it as part of their realm.
We have 1 cardiac surgery fellow and 1 cardiology structural fellow every year. And the other thing we do is we invite our cardiology structural fellow to come scrub on our open cases and literally put them at the table and have them reach in there with a pair of forceps and look at the valve and feel the valve and get a feel for what the real anatomy is.
I fully agree with the heart team approach, but in real practice, we are seeing a lot of problems. For example, patient prosthesis mismatch is a very important issue. In generally, surgeons do not, and I'm not underlying different persons, but many surgeons do not look at CTs before the operation. And we are seeing a lot of, for example, smaller valves in large valsalva sinuses. Maybe aortic root dilatation surgery and the other parts of valve surgeries must be done in the structural heart surgeons, but for the TAVI, it must be done by the structural interventionalists. This is my opinion.
So in our valve clinic, not a TAVI clinic, valve clinic, attended by surgeons and interventionalists who do that, we do CTs on all of them now. So I think it makes the surgeons better surgeons to really know what they're going to put in, how they're going to approach the situation. That mimics Partner 3, where the gradients were pretty similar between TAVR and surgery for the first time, at least in the balloon expandable.
We CT everybody in the valve clinic, and we get an area-derived diameter of those that are going to surgery. And my cardiologists expect me to send back a pericardial valve with an internal diameter that matches that area-derived. Otherwise, they're mad at me. TAVI has definitely made us better surgeons, no question.
Yeah, great. Well, this can go on forever for the discussion. I think we'll have to conclude now. Thanks, everybody, and we'll move straight into TAVI rounds. We invite Dr. Georgiou and Dr. Dimas to join us up here, and Dr. Soulaidopoulos, who's going to present the first case of valve-in-valve from Hippocrates General Hospital, University Clinic, and Associate Dr. Professor Choufis to come here. Go ahead.
So, ladies and gentlemen, I welcome you to this very promising session of TAVI rounds. It's another innovation of Hygeia Hospital. We're going to have two case presentations, one from Hippocrates Hospital here in Athens, one from Onassis Cardiothoracic Surgery Center. So I welcome the first speaker who's going to present a valve-in-valve case from Hippocrates Hospital.
Καλησπέρα σας. Θα παρουσιάσουμε ένα περιστατικό από το Ιπποκράτιο. Ζητώ συγγνώμη εκ μέρους του καθηγητή κ. Τσιούφη, λόγω υποχρέωσης εκτός Ελλάδος δεν μπόρεσε να είναι παρόν.
Can I ask you to talk in English?
Yes, yes, of course,
because
no
you have
problem.
a lot of English-speaking guests, and it will be better to talk in English. Thank you.
So I'm going to present a case of a valve-in-valve patient who was hospitalized to our hospital actually a month ago. She is a 81-year-old female lady with worsening dyspnea and orthopnea starting 3 weeks ago, and she had 3 hospitalizations since the last month. NIHA score 3 to 4. She was hemodynamically unstable, and she was in constant need of inotropes at quite high doses in order to maintain blood pressure. Her background included surgical aortic valve replacement in 2011, an EPIC Supra 19mm valve. She had a permanent pacemaker implanted. She was also diabetic and hypertensive. She was on maximal medical treatment and high doses of diuretics as well. This is her ECG, sinus rhythm. We see the block also from the pacemaker. And now we can see the first images when she came to our hospital, except for the aortic valve that had the major problem. We also can see that there was quite severe mitral regurgitation as well, dilatation of both atria. And here we can see that there is a dysfunction of the aortic valve that was implanted 13 years ago, actually. Her ejection fraction was approximately 45%, and as we can see here, the mean gradient was approximately 23 millimeters mercury, and the aortic valve, the max, was 3.5 meters per second. So we are talking about the low flow, low gradient severe aortic stenosis, and as we can see here also, she had at least moderate tricuspid regurgitation as well. Concerning our patient, we can see here that we're talking about a lady who had the first valve implanted 13 years ago, and now she is 80 years old, as we can see here at the diagram. There is a degeneration of the valve, there is a failure of the valve. We can see that the durability of the valves implanted, either transcatheter valves or surgically implanted biprosthetic valves, have a durability approximately of 10 years, and there is a dysfunction of the valves. We can see that by these diagrams that the gradient is a bit more in case of a TAVI and a bit less in case of a surgical implanted valve. And as far as the outcomes of valve-in-valve in case we need, because the patients are nowadays having their first implantation at a lower age, so they might need a second valve as well. We can see that approximately the percentages are the same in case of a TAV-in-TAVI or a TAV-in surgical implanted valve. The numbers speak by themselves, I think. As the population is getting older and older, more and more patients are in need of a valve implantation of the aortic valve. And comparing the surgical and the transcatheter implanted valve, we can see that the surgical is better in case of coronary obstruction if we need to do, is worse, I'm sorry, worse, not better, if we need to do a TAV in SAVR instead of a TAV-in-TAVI.
Sorry for interrupting you. So the aim of this TAVI round is to have, have an interactive discussion. So before we move to how you deal with this case, can you prescribe for us what is the properties of this EPIC valve, this degenerated bioprosthesis? Is it a standard valve?
Yes, the diagram I also think is a standard with externally mounted leaflets valve, yes. I'm going to show also the characteristics of the valve later on. The ages are over 9 because the mean age of the valve, prosthetic valve, life expectancy is approximately 10 years. The lady is over 10 years, as we already saw. And just in order to say before I answer your question, of course, is that in the case of the lady, we concluded that it was a structural, the reason for the dysfunction of the bioprosthetic valve. And I'm going to show the characteristics as well. We had a hard team, as we already said, because it's a lady that not only had her aortic valve dysfunction, there was also severe mitral regurgitation and a moderate to severe tricuspid regurgitation as well. And the lady was in need of inotropes all the time she was hospitalized. So, depending on the guidelines and based on them, we know that the transfemoral approach of a valve-in-valve procedure has a 2A recommendation. And even if it's not the aortic valve, we can see also that the mitral tricuspid is 2B recommendation. This is the Euroscore 2 of the lady. It's quite high, as we can see, and the STS score as well. And the lady had a coronary angiography actually 2 months ago. She was, the coronaries were fine, not a problem, fortunately, by there. And the main problem of the aortic valve, except for the stenosis, was as well the aortic regurgitation, as we can see here by the aortography of the patient. So, as far as the valve selection, as you already mentioned, and thank you very much, we all use the app that we know that nowadays is used, and we see that we have quite a few options, but some of them are used with caution. So, depending on the data we had and the fact that the lady could not have a CT as it should be performed because she was inotrope dependent and she couldn't be easily moved to another facility or to do the CT, we can see, I'm going to come back just to say that the valve used, the EPIC Supra, is a stent post the leaflets valve. It's not bovine, the pericardium used. It was 19 millimeters, and it's a valve that can be fractured as well. It's good to know, of course, that before we decide what to do. So, depending on the algorithm used, we decided to have the second valve, that was implanted, was a 23 millimeter Evolut R. We had in mind that we might need to fracture the valve depending on the hemodynamic status of the lady.
Okay, thank you. So we have a lady of 81-year-old with a failed bioprosthesis, extended, internally mounted valve with stenosis and bifurcation.
Yes.
Any thoughts about the coronary protection of the coronaries in this case?
Yes,
Any
of
thoughts
course.
about, of course, this lady has already a pacemaker, no
No problem
concerning
with
AV.
that. What about the coronary protection? Any thoughts about that?
Yes, of course. It was always in mind that we had in mind that we might need to use the basilica and the chimney technique are the most used ones, of course. But we had also the chance to do. I just don't have the image to do not a full study of TOE and also to measure from the CD that we had was not for the preparation of the TAVs. We had the CD just to know if there was any other problems because there was also some markers of inflammation increased, and we thought that maybe there was also the endocarditis, the reason that had a role for her dysfunction of the valve, but nothing was. We could not.
The VTC of this case, it was good enough in order to.
Yes. And also the coronary ostal was above 12 millimeters. That's it. And also the sinotubular junction, there was quite enough gap, so we were okay, and we also did quite a few times. The reason why we did not also decide to do so was because she was quite frail, the lady. That was also the reason why we used the transradial approach for the second approach, while most of the times we use both femoral arteries.
In valve cases or in all cases you use the radial access? What is your strategy? What is your policy?
Yes, most of the times. If the radial access and the patient has the body structure that allows us to do, because most of the times we use left radial access, we use the radial. But if there is a problem,
yes.
Any thoughts about surgery in this case? Is it a surgical candidate, or we go straight forward to TAVI? No thoughts about surgery.
Given the age of the patient and the fact that the coronaries are normal, so we're really concerned. We're not really concerned with reaccessing in the future for coronary artery disease the coronary circulation, just avoiding obstructing the coronary circulation. I would proceed with
yes.
TAVR.
Valve in valve. What Hippocradion has done in this case, would you protect the coronaries with a wire, at least a wire, or no need for that?
I don't see any need for that. There is adequate height.
Okay.
There is a wide sinotubular junction. That's what I'm talking.
To be honest, at the heart team, the cardiac surgeon, because in our hospital there is a cardiac surgery unit and clinic. It was debatable, but the risk was too high, and also the anesthesiologist said that she won't make it through surgery.
Any comments from the audience? No. Okay. Yes, go ahead.
Were you preparing for a frac just in case? I know it's an older person, probably not that big, but and then were your measurements in CT big enough, considering that you might have to frac, even with the self-expanding?
So in this case, Dr. Valiano, would you think that a pre-dilatation is better or a post-dilatation is safer?
I think I like to post-dilate, and in this case, especially with a bioprosthetic valve that's already leaking a lot, I'd worry about pre-dilating and then the patient crashing.
Thank you for your comment.
Forcing valves tear. The pericardial valves are tough, they don't tear. You generally forcing valves don't tear. They go from moderate to severe AI into a real crash.
We did the exact same thing. We post-dilated the valve, just like.
So you did a pre-dilatation, this
post-dilatation.
is the post-dilatation.
Yes,
okay.
yes.
All right, yes. This is the
valve.
Evolut Pro 23 millimeter
yes,
valve?
Yes.
Okay. And the post-dilatation with an 18 millimeter
yes.
balloon.
And this is the orthography post-dilatation of the valve, which was quite convenient for us, depending on the patient and her background. The femoral artery was okay. We used a Manta 14 French in order to seal the artery. And
is this the Manta the main device you use for closure? Or what is your strategy
yes.
in Hippocradian Hospital?
In most of the cases, yes. But we also may use Proglide. But in most of the cases, nowadays at least, yes, it's the Manta. 18 or 14 millimeters. And after our procedure, the patient was hemodynamically stable
So I suppose it was a case with a conscious sedation, no transesophageal echo.
No.
You don't use transesophageal echo at all?
We might use it. No, it's not everyday practice to use it, even in valve-in-valve patients who are riskier patients most of the times. But if needed, yes. We don't have much experience on ICE, for instance, no.
Yeah. Okay, thank you.
So, just...
yes, there is a comment from the audience.
Of course, of course.
Go ahead.
With Professor Chouvis, I'm Assistant Professor Dimitriadis. We have done this case. Actually, this is one of the cases of urgent TAVI. I think this is something that's growing also in the publication. And I think if we haven't done this operation, the patient will definitely gonna end. And so we did our minimalistic approach. We tried to do the radial approach. We just did an orthography. And based on the results, we can say we were a little bit lucky, because sometimes you would want to be lucky in such kinds of situations. We haven't cracked the valve. We were not so sure about doing this. So we have done, as you see, the dilatation and afterwards the post-dilatation, and the results were just fine. And what we have seen, and also Irene gonna show us, is after the position of the valve, the patient really get well with conscious sedation. That's what we do in Hippocration in all the cases, and then also the MR and the TR really ameliorated. This is something that we see, but you're not quite sure. And actually, there was a heart team that was done 5 continuous days. The patient was in the ward, then it went down to the intensive care unit with inotropes. Nobody will try to touch her. And then we said, it was Wednesday morning, okay, let's proceed, because there was no other choice. And I think all in the audience, you're very experienced operators. You have cases like that. And this is one of the cases that we really are happy that we have proceeded.
So it's our experience too that when we have severe regurgitation, the improvement of the patient is impressive, and these patients are improving more impressively.
The amelioration of the clinical status of the patient was really something that we not really expected afterwards, just after the case.
Is there any specific reason you choose the self-expanding valve instead of a balloon expandable in this particular case? For example, a Sapien 20mm valve could be used in this case with good engagement of the coronaries in the future. Although it is a T1, maybe you will never need that.
Yeah.
What was the reason you decided?
Yeah, I definitely agree with you. A balloon expandable as a first case will seem to be a little bit a reasonable choice. However, we have more experience with this platform as a team, so we chose the platform. I think it's very...
Maybe with the results of the SMART trial recently, this valve is ideal because you have a better hemodynamic profile, and the gradients will be lower, the aortic valve area will be...
exactly, but of course there were not, I think, in TAV. In TAV it was in... the SMART trial was in... was for small annulus, you mean, but not in an annulus caused by generative valve already put into place. So, of course, if we can do it. Okay.
And also the coronaries that were okay was another reason why the balloon expandable that has shorter frame and shorter valve, it was a second choice.
Proceed.
Just in order to close the case, if there is no other comment, there is only a small paravalvular leak of the second valve implanted. Also, the gradient was 16 millimeters and 2.5 the aortic valve speed also. And just a few words in order to say that, as we know, there are a few different types for biprosthetic aortic valve dysfunction. In our case, it was structural valve dysfunction. And as we know, the mortality, even if we are doing TAVI and not a bioprosthetic valve that is surgically implanted, we know that there is a better mortality rate than in cases that we decide to exclude, to explant the TAVI. And also, as far as the choice of the valve that you already have mentioned, we do know that there is a larger effective orifice area in case of a self-expandable valve, but the balloon expandables have a lower rate of dysfunction of the valve, type 1 dysfunction. We already mentioned the VTA and the risk plane that it was okay. The basilica, as you already mentioned, that we did not need to do that, but we were prepared if something went wrong that we might need to protect the coronaries as well. And we remember the general rules in case of TAVI and TAVI that balloon expandable, same size, but balloon in itself, we downgrade the size a little bit. Just as far as bibliography is concerned, the registry of explantor TAVI showed that the TAVI explant was done quicker than TAVI and TAVI, but better results long term. And as far as our choices are concerned, we need to know, of course, the patient and his anatomy quite well. Also, if we have the right measurements, as far as the CT is concerned, it's the optimal for our preparation for the procedure. And also, be ready for everything that goes wrong, even if it's the valve itself or maybe also the arteries of the feet. Just a few words. Recently, Dr. Dimitriadis, Professor Tufts also, and myself, we had a meta-analysis including 17,000 patients that we compared TAVI in TAVI or REDO in SAVR patients. We saw that the reintervention was the only fact that favors REDO SAVR, and valve in case of transcatheter valves was better as far as new pacemaker implantation was needed, the stroke at 30 days and the MI at 30 days, and also, of course, the hospitalization that it was fewer days. The only points that were better in case of surgical valve was the mid gradient after the valve, as we saw in the beginning, also the paravalvular leak. And in conclusion, I would like to point out the fact that with Professor Tufts and his will, we started a registry in our hospital that includes all Greek hospitals, of course, for everyone who would like to participate in patients with symptomatic severe dysfunction of a biprosthetic valve implanted. And the primary endpoints are all-cause and cardiovascular mortality and ischemic composite. So, given the fact that the number of patients who need valve-in-valve procedures will increase due to the longer life expectancy nowadays, we need to say that we need to know the anatomical factors as well as meticulously have the data from the CT scan and also know the valve that we are going to implant in order to better position a size and to avoid all the major problems that may come in the near future. Thank you very much.
Thank you very much. Let me take the opportunity, since there are so many prominent surgeons and interventional operators in the audience, and ask a very simple clinical cardiologist question, but it may be complex also. What would be the valve of choice for a younger patient, 60-year-old, who will need, let's say, for bicuspid aortic valve replacement at the age of 60? Would it be a surgical valve? Would it be an interventional procedure? There is a chance that such a young patient may need 2 redo procedures in his lifetime. How do you approach this? Or already lived by the success, the immediate success of whichever procedure, but how can we see it in the future? What is the best investment for the patient? Any thoughts? I would invite any thoughts.
Well, we follow the guidelines. If you're healthy, you're 16, you're going to get surgery. The saddest thing about this case to me is she had a 19 valve. It's sad when surgery puts in a 19 valve or a 21 valve. In my operating room, the rule is no woman leaves with less than a 23, no man leaves with less than a 25. So if your surgeon's putting in 19 and 21s, you better just do a TAVI or get a new surgeon. But I think for somebody 60, they need a if they want a biologic valve. Mechanical valve is fine too. But if they want a biologic valve, pericardial, don't use porcine in the aorta. They always have more obstructive flow, and they also fail by AI, which is a quick failure. And make sure your surgeon puts in a reasonable valve. You come out with a 25 or 27 valve, not only is it going to last longer, but when it comes back to the cardiologist, you are now a better setup for a valve and valve. But 19, you should never, that's sad.
Well, I mean, for the bicuspid scenario you presented, clearly the surgery would be the first choice. The more tricky part is, though, becomes really interesting, what's happening with that same exact patient who's going to go for surgery and the aortic size is 4.1 or 4.2, very common sizes. And, how do we deal with that? Is okay to go for surgery and not replace a ascending aorta? You're replacing the ascending aorta. That is always a tricky one. And I don't think we know enough about that. I would welcome any research advices also over the time about this thing, because there may be some biomarkers we're going to have to find to indicate who are the people who are prone to develop a future dilation of the aortic arch versus the ascending aorta versus not. I know Dr. Reardon, and I see Professor Choufis also joined. Perhaps he will weigh in as well.
Well, they are developing biomarkers, but we're not going to do genetic biomarkers on everybody. It's just not going to happen. And 4.5 is the guidelines. But again, it depends on if you're a 6'8" man or a 4'10" woman, what 4.1 really means. And at 4.1, there's not a lot of chance it's going to do it. On another side of that coin, I'm actually running a type A and an ascending aorta stent graft trial. 5 years from now, we may have a stent graft for this too. I mean, there are things coming down the pike. But at 4.1, unless it's a really tiny person, I'd have a hard time replacing that. Or remember, all phenotypes are different. Type 0 with AI, those will progress. Type 1, they stay stable.
Professor Choufis maybe has a comment, and thank you for connecting.
No, just George, someone would like to set my up. Being able to connect it earlier due to another commitment in a meeting in Krakow in Poland. So I did attend the session, so just to thank you all, and please go ahead with your comments.
I think we're ready to conclude this case. Thank you for your presentation. It was very nice and elegant presentation of a valve-in-valve case with all the aspects of this technique. Thank you, Professor Choufis. We have to move to Onassis Cardiac Surgery Center and Dr. Iakovou. Ο κύριος Ιακώβου μάλλον online θα γίνει. Online θα είναι ο κύριος Ιακώβου. Online. Ωραία.
Okay.
Good morning, Yannis. Thank you for joining us. Dr. Georgiou from Cyprus, thank you for joining us. And please present your case.
Okay. Hi, George. I go directly to the case presentation since this is a kind of grand rounds presentation. So I hope you can see the presentation. So our patient is a 53-year-old.
So we cannot see your slides, Yannis.
Hold on a second. Let me see if I can do something more.
Please share with us your slides.
Yeah, I'm trying. So I'm sharing the screen again. So. Can you see now, George?
No. Now we can see them. Yeah. Go ahead.
Okay. Okay, so our patient is a 53-year-old male with gradual worsening for dyspnea.
You can maximize your screen, please. Can you maximize it?
Well, it's maximized. I don't know what else can I do here.
Okay. Anyway, go
maybe
ahead.
it's
It's
something
okay.
that has to do with the Inventix. Can they?
Okay, it's okay. Go ahead.
You think it's fine?
Yes.
Okay. So his past medical history included Hodgkin lymphoma. He underwent chemotherapy, chest radiation, a second cancer later, some years ago with lobectomy for lung cancer, chemotherapy, double radiotherapy again with 1219. This was followed by pacemaker implantation, and in 2020 he had a mechanical valve in another hospital. He had the baseline creatinine of 1 with good creatinine clearance, and then the coronary angiogram, there was no severe coronary artery disease. Because due to his young age, he had a low logistic Euroscore, but you see the logistic, the Euroscore 2 and the STS score is quite big due to the comorbidities. So this is the screen in echo with an AVA of 0.7 square millimeters with a peak of 66 and a mean gradient of 31. On top of that, he had a severe tricuspid regurgitation implicated with the pacemaker and the interaction with the pacemaker, the pacing cables. And this is the CT analysis. Of course, as Dr. Riordan said, we have to study meticulously the CT before doing any decision on pace and on the proper pace and treatment. You see it's on the smallest side with an area of 335 square millimeters and a perimeter around 67, or as you can see here. And also you can appreciate the mitral aortic annulus angle, which is 31 degrees, and there is a very small distance, less than 3 millimeters, between the annulus and the mitral valve, the aortic mitral distance, which we know for the Edwards, we need to have 3 millimeters, and for core valve we need to have 4 at least. The femorals were unimpressive, maybe on the smallest sides from the right femoral, but still there are not extensive calcifications, so it's something that we can do via the transfemoral approach. So we are dealing with the young patients, and with a young patient, this is the first question that we needed to answer in the heart team, and in this format, in the grand rounds. How do you treat these patients? We know that if it's in the States, we're not going to discuss a lot. For the patients with between 65 and 80, these patients have indication for TAVI. In Europe and in Greece, more specifically, we do TAVI for patients more than 75 years old. But you know, we have quite a large database. The last few years, the last 8 years, we have done 1,400 cases. So we have 11% of these patients are less than 75 years old. And one of the patients is that came to discussion with the heart team is this patient, 55-year-old with severe comorbidities with proliferative valve 22-23 annulus, and there are many aspects how to look at it, and as Dr. Velianou said, we have to have a view to the long game. So we're talking about lifetime management. We're talking about a patient that probably it's not the best candidate for a surgical approach, and now maybe it's the first time, you know, it is the moment to discuss with the surgeons if they could do these patients, if they were happy, they would be happy to operate on this patient.
You know, there's some rules that I have for my young faculty. One is I can do a redo chest, and I can do a radiated chest, but I don't do a redo radiated chest. This guy was radiated in 1986, back when they really used to burn you, and this guy's not going to live 20 years. He's going to be lucky to live 10 years. And STS in no way reflects what his actual risk is.
Exactly. So any other comments? Dr. Dimas?
I think the comment by Dr. Reardon says it all. Nothing to add.
So yes, so of course this is a young patient, but also, as Dr. Reardon said, this is not a patient that he has so many comorbidities, other valvulopathy as well. So we are not talking about a regular patient, a normal patient that with no other comorbidity. So we have to do a personalized decision as in all of these cases. So we discussed in the heart team of our hospital and decided to proceed, of course, with TAVI. So now we have to decide which valve to do, balloon expandable or self-expandable valve. So maybe we're in the borderline between 26 or 29 Medtronic. If we place a 26, we're going to have an oversize of 13%, and we know the recommended oversizing area is 13 to 30%. The sinus of Valsalva diameter and height, they were fine. They can, the valve can be accommodated easily, and you see the LVOT dimensions are on the smallest side. So probably 26. If we were placing an Navitor, 27 would have an oversizing of 17%, so which is fine, but still we have the issue of the mitral and mitral aortic distance, which is very small, less than 3 millimeters. So also the balloon expandable valves, which is more which are better suited for young patients, because we need to have easy coronary access, as Dr. Dangas said in the previous previous session. We need to have a proper and easier access in these patients. So he's a patient that probably in the future he needs to be cut again. So if we are dealing with the 388 area, the most probable and evident solution is to go with the 23 valve, which will approximately have an oversizing of 7%. We can also use the 20 millimeters, but then it's slightly undersized. And also at this time that we were placing the valve, we didn't have the results of the SMART trial, but we had the results of other registries, like the TAVI France registry, which showed that in the small annuli, maybe hemodynamically, it's more prudent to place a self-expanding valve. As Dr. Velianu said before, and I followed his discussion, with great attention. So he said that we need to have a surgical-like approach, and this is our aim in this kind of situations. So we decided to place a balloon expandable valve, and I don't know if there's any comment from the audience, if someone would go ahead and place a self-expanding valve due to the hemodynamically superior performance. So George, what's your opinion on that?
So I think one of the most important advantages of the self-expanding valve is the fact that this is repositionable and resheathable. So you can remove the valve and you can position it in a better position, especially in this case where the aortic mitral distance is very small and the result is unpredictable with a balloon expandable valve, even in experienced hands. I think the FX will be the solution for this problem, the new technology of Medtronic platform, because it's very stable and very predictable, and you can deploy the valve at the position you want to be, and then in this case will be the ideal with a good hemodynamic profile, and even with easy, if you manage to have the commissural alignment, to have easy access to the coronaries. Any comments from the audience, from Dr. Dimas? Yes, Dr. Kilic. Can I have a microphone, please?
Hi, Yannis. I am Dr. Kilic. Very good case. Did you measure fluoroscopically also the distance between the valve and the mitral valve?
Well, Theo, nice hearing from you. No, we don't do that. We just rely on our measurements on CT before, and as you can see in the case that we are presenting, we are doing our measurements by TOE real time in the cath lab.
Sometimes CT also in different angles and different perspectives can give some errors, and the fluoroscopy between different angles also during the implantation also give very good information. And one important point also, the presence of the sigmoid left ventricular hypertrophy is present or not, because of there are publications about, that watermelon effect during the implantation of the valves. But I think for fully retrievable and controlling the mechanism during the deployment, I would also prefer a self-expandable valve in this kind of very close mechanical prosthesis.
Yeah, these were very nice comments, Theo. Thank you very much. So we discussed a lot about that. So in these cases, in young patients, I'm really reluctant because despite doing our best to have a proper coronary alignment to place a supraannular self-expanding valve. So it's a young patient. So we need to have, the coronary is clear of cells. So maybe the FX, as Dr. Georgiou said before, would be a solution. It's not available for us yet. And in these cases, we have also very small distance between aortic annulus and mitral. So it's maybe in self-expanding valves you need 4 millimeters. In Sapien and in maybe in my valve, I don't know, you need a little less, approximately 3. So we are dealing with 2.3 millimeters distance, and these measurements were replicated in many angulations. The main angle, it's approximately 30 degrees, so it's quite favorable. So we decided to use the larger Sapien valve to have the best hemodynamic result as possible. And maybe we can proceed, and then we can discuss from there. So it's this is the procedure itself. I will go quickly. It's a little bit of deviation on our protocol. So in 95% of our cases, we do light sedation, and in this case, because we were dealing with TOE as well, we decided to intubate the patient, and you can appreciate the calcification and the stenosis of the valve. So we do the normal puncture echo-guided, as we do in these situations. So I go forward. And here you can see the distance, we can make the measurement as Theo said before, but we need to pay, I think, special attention to the TOE in these cases. in order to identify the place that we can land the valve. So we had information from the CT, but also from the TOE that we can relatively safe place a balloon expandable valve.
I think another advantage of the self-expanding valve is the fact that during the procedure you can estimate the impact of the valve deployment on the mechanical mitral valve. So you deploy the valve slowly. If you see that there is any interaction with the leaflets of the prosthetic mitral valve, you can pull it back and you can deploy it in a new position without interaction with the mitral valve.
Yeah, I agree, but still, George, you can see that the distance is very small. Maybe we need a little. I would feel more confident to avoid even, a delayed problem with both of the valves, with the self-expanding valve in this situation. So here you can see that there is some space to work.
So in these cases, you have to work in multiple projections in order to find the best angle you're going to use in order to have the distance, the proper distance from the aortic annulus to the mitral annulus and the mechanical valve in order to avoid any interaction.
Okay, yeah, I have to agree with that.
More LAO projections, as you showed just before that, more LAO projections showed a little bit much distance.
Yes.
Left anterior oblique, cauda, LAO cauda.
Yes. Okay. So we are, when we're placing...
It was a great comment, you're absolutely right.
And Edwards, we don't normally predilate, but in this situation we felt we should predilate in order to minimize any possible slippage of the valve, because we want to be as accurate as possible. You can see the predilation, there's a nice opening of the...
And you pace on the wire.
Yes.
Yes.
That's our practice. I think it's better pacing with a lot less complication. Especially, I think
so this is the LAO view Dr. Kilic mentioned before.
Yes, yes. And I think in this situation, when you will be really accurate, I think pacing with the wire is even more important. So when we changed our practice and started pacing with the wire, despite a lot of course, there are many advantages in that, not only patient-wise, but also economic. We managed to decrease our length of stay by 2.5 by doing by incorporating the benchmark protocol, which is very nice, and I suggest everyone, I think, to do it. Or the smart TAVI of the Medtronic, I think that there are very good options in order to optimize your procedure. Of course, this is the usual preparation of the valve, and
so we're going to have the SAVI wire soon, which will be the workhorse wire, guide wire for the stiff wire for the valve deployment, and also give us some important hemodynamic information throughout the procedure.
Yeah.
And pace, of course, and pacing.
It will cost, as Dr. Riordan said,
Yes.
like the shockwave, but yes, I think in the meantime we're very happy with the Safari wire that we use in the Edward prosthesis. And in this situation, you see the TOE can help us accurately place the valve in where we want to place it, and of course we do some tests before, and we proceed with a very low implantation of the valve, and by looking at the TOE as well, so we can make a small micro movements and facilitate the optimized implantation of the valve. So I think that we did was an uneventful placement of the valve, and then you can see from the cranial view as well, there is some small overlap fluoroscopically, but we don't see it in the TOE. So of course, maybe the TO has a point. We'll have to check it, from many times, but from many aspects and many regulations. But the fluoroscopy is a 2D imaging, so we need to rely on TOEs as well in this kind of situation. And then we measure the gradient as well.
So I think the 23 millimeter size was the proper size for the case. The 20 millimeter valve will be a small one. And I think it's an 80-20 or even 90-10 implantation, 80 to the aorta, 10 to 20 in the left ventricle, which is the ideal, very elegant implantation of the SAPIEN 3 valve.
Okay. And then we closed the access. So patient 1 month follow-up was feeling a lot better. He diminished the furosemide, maybe one tablet and the Pleranon.
What about TR?
Yes, he had a severe TR, but
any plans in the future
not do anything with the patient. Wires, and actually he didn't recover from that, and actually he came back very recently. He had even more severe TR. I wouldn't say torrential, but here you see larger ERO and LV volume. So maybe there is something to be done with TR, and we know that. If we use a tri-clip in these situations, we're never going to have a really good outcome. But we are investigating. We will investigate the pathophysiology. It looks cardiographically that there might be constrictive physiology as well, but patient is being implanted for a right heart and left heart catheterization, and we'll take it from there. So. By concluding these cases, of course, we chose the valve that facilitates easy coronary access in the future in a young patient, 55 years old. We paid special attention to hemodynamic optimization of the procedure. We used the larger balloon expandable valve that we could use, and we tried to make as accurate implantation as possible in order to avoid any possible interaction with the mitral valve, because of there was a very small distance between aortic annulus and mitral valve. So in all the situations, of course, as we discussed before, we need to have personalized decision making, which leads to better outcomes, and this have to be discussed in the grand rounds. And this simulation is very important, I think, for us, but also for the young colleagues who try to learn TAVI and how to better treat these patients. So thank you very much.
So I think this is a 50-year-old male patient with severe aortic stenosis in this age. If it's not a bicuspid aortic valve, maybe the radiotherapy was the main reason for that. And even the tricuspid regurgitation is not only for the impeachment of the leads, maybe there is some primary tricuspid valve dysfunction, and this may be estimated and clarified before you will make any thoughts to correct and to treat with a transcatheter procedure the tricuspid valve regurgitation. Thank you, Yannis. It was an excellent case, very didactic, very important for us. Any comment by Dr. Dimas?
Indeed, this was an excellent and very didactic case and very well executed. Very good analytical thoughts, the right considerations, with an excellent final result.
Any comments from the audience?
Choose whatever valve you want to choose. This person can die of radiation heart disease. I mean, you don't have both mitral and aortic
Thank you for your comment. So I would like to thank all of you for participating in this session, and we're going to have a break now. Thank you. Thank you, Yannis.
Thank you.
Tissue integrity diminishes over time, largely as a result of calcification. Tissue valves are exposed to a variety of calcification sources. Free aldehydes are one of these sources of calcification. They accumulate in the tissue during the glutaraldehyde fixation process and throughout valve storage. Collagen is a structural protein material that makes up 75% of bovine pericardial tissue. Bovine pericardium collagen is multi-layered and multidirectional, helping to give the tissue material strength and flexibility. Resilia tissue is bovine pericardium that has been transformed by a novel integrity preservation technology that virtually eliminates free aldehydes through the combination of two proprietary features. The first feature is stable capping, which permanently blocks free aldehydes in the tissue, preventing calcium from binding in vivo. A sheep study demonstrated 72% less calcium content after 8 months in valves with Resilia tissue. In addition, the COMMENCE surgical aortic trial showed that surgical valves with Resilia tissue demonstrated strong clinical outcomes and excellent durability at 7 years. The second feature is glycerolization, where water is displaced with glycerol, removing the need for preservation in liquid solutions like glutaraldehyde. This prevents further exposure to free aldehyde groups, thus protecting and preserving the tissue's integrity and enabling storage in dry conditions. Tissue integrity diminishes over time, largely as a result of calcification. Tissue valves are exposed to a variety of calcification sources. Free aldehydes are one of these sources of calcification. They accumulate in the tissue during the glutaraldehyde fixation process and throughout valve storage. Collagen is a structural protein material that makes up 75% of bovine pericardial tissue. Bovine pericardium collagen is multi-layered and multidirectional, helping to give the tissue material strength and flexibility. Resilia tissue is bovine pericardium that has been transformed by a novel integrity preservation technology that virtually eliminates free aldehydes through the combination of two proprietary features. The first feature is stable capping, which permanently blocks free aldehydes in the tissue, preventing calcium from binding in vivo. A sheep study demonstrated 72% less calcium content after 8 months in valves with Resilia tissue. In addition, the COMMENCE surgical aortic trial showed that surgical valves with Resilia tissue demonstrated strong clinical outcomes and excellent durability at 7 years. The second feature is glycerolization, where water is displaced with glycerol, removing the need for preservation in liquid solutions like glutaraldehyde. This prevents further exposure to free aldehyde groups, thus protecting and preserving the tissue's integrity and enabling storage in dry conditions. Tissue integrity diminishes over time, largely as a result of calcification. Tissue valves are exposed to a variety of calcification sources. Free aldehydes are one of these sources of calcification. They accumulate in the tissue during the glutaraldehyde fixation process and throughout valve storage. Collagen is a structural protein material that makes up 75% of bovine pericardial tissue. Bovine pericardium collagen is multi-layered and multidirectional, helping to give the tissue material strength and flexibility. Resilia tissue is bovine pericardium that has been transformed by a novel integrity preservation technology that virtually eliminates free aldehydes through the combination of two proprietary features. The first feature is stable capping, which permanently blocks free aldehydes in the tissue, preventing calcium from binding in vivo. A sheep study demonstrated 72% less calcium content after 8 months in valves with Resilia tissue. In addition, the COMMENCE surgical aortic trial showed that surgical valves with Resilia tissue demonstrated strong clinical outcomes and excellent durability at 7 years. The second feature is glycerolization, where water is displaced with glycerol, removing the need for preservation in liquid solutions like glutaraldehyde. This prevents further exposure to free aldehyde groups, thus protecting and preserving the tissue's integrity and enabling storage in dry conditions. Tissue integrity diminishes over time, largely as a result of calcification. Tissue valves are exposed to a variety of calcification sources. Free aldehydes are one of these sources of calcification. They accumulate in the tissue during the glutaraldehyde fixation process and throughout valve storage. Collagen is a structural protein material that makes up 75% of bovine pericardial tissue. Bovine pericardium collagen is multi-layered and multidirectional, helping to give the tissue material strength and flexibility. Resilia tissue is bovine pericardium that has been transformed by a novel integrity preservation technology that virtually eliminates free aldehydes through the combination of 2 proprietary features. The first feature is stable capping, which permanently blocks free aldehydes in the tissue, preventing calcium from binding in vivo. A sheep study demonstrated 72% less calcium content after 8 months in valves with Resilia tissue. In addition, the COMMENCE surgical aortic trial showed that surgical valves with Resilia tissue demonstrated strong clinical outcomes and excellent durability at 7 years. The second feature is glycerolization, where water is displaced with glycerol, removing the need for preservation in liquid solutions like glutaraldehyde. This prevents further exposure to free aldehyde groups, thus protecting and preserving the tissue's integrity and enabling storage in dry conditions. Tissue integrity diminishes over time, largely as a result of calcification. Tissue valves are exposed to a variety of calcification sources. Free aldehydes are one of these sources of calcification. They accumulate in the tissue during the glutaraldehyde fixation process and throughout valve storage. Collagen is a structural protein material that makes up 75% of bovine pericardial tissue. Bovine pericardium collagen is multi-layered and multidirectional, helping to give the tissue material strength and flexibility. Resilia tissue is bovine pericardium that has been transformed by a novel integrity preservation technology that virtually eliminates free aldehydes through the combination of 2 proprietary features. The first feature is stable capping, which permanently blocks free aldehydes in the tissue, preventing calcium from binding in vivo. A sheep study demonstrated 72% less calcium content after 8 months in valves with Resilia tissue. In addition, the COMMENCE surgical aortic trial showed that surgical valves with Resilia tissue demonstrated strong clinical outcomes and excellent durability at 7 years. The second feature is glycerolization, where water is displaced with glycerol, removing the need for preservation in liquid solutions like glutaraldehyde. This prevents further exposure to free aldehyde groups, thus protecting and preserving the tissue's integrity and enabling storage in dry conditions. Tissue integrity diminishes over time, largely as a result of calcification. Tissue valves are exposed to a variety of calcification sources. Free aldehydes are one of these sources of calcification. They accumulate in the tissue during the glutaraldehyde fixation process and throughout valve storage. Collagen is a structural protein material that makes up 75% of bovine pericardial tissue. Bovine pericardium collagen is multi-layered and multidirectional, helping to give the tissue material strength and flexibility. Resilia tissue is bovine pericardium that has been transformed by a novel integrity preservation technology that virtually eliminates free aldehydes through the combination of two proprietary features. The first feature is stable capping, which permanently blocks free aldehydes in the tissue, preventing calcium from binding in vivo. A sheep study demonstrated 72% less calcium content after 8 months in valves with Resilia tissue. In addition, the COMMENCE surgical aortic trial showed that surgical valves with Resilia tissue demonstrated strong clinical outcomes and excellent durability at 7 years. The second feature is glycerolization, where water is displaced with glycerol, removing the need for preservation in liquid solutions like glutaraldehyde. This prevents further exposure to free aldehyde groups, thus protecting and preserving the tissue's integrity and enabling storage in dry conditions.
We're ready. Can we start? Okay. Well, good afternoon, dear colleagues and esteemed professors. My name is Dimitris Giakas. I'm professor in cardiology and head of the department in the University Hospital of Alexandroupolis. And first of all, many thanks to Kostas Spargias for this kind invitation. It's always a pleasure to be here. And I would like to welcome you at the third session of the day, where we are going to discuss and delve into 5 practical aspects into TAVI procedures that I'm sure that have troubled all structural cardiologists in the audience, and not only. Alongside our panelist, Dr. Tsikaderis, who is our, okay, I see you, Dr. Iakovou, and one more. We have a group of distinguished speakers in the next 1.5 hours, and we will try to enlighten and to be enlightened. One more little thing. I don't like to interrupt any of the speakers of the presenters because I don't like it because it's their truth. So I kindly ask all speakers to complete their presentation in 1 hour in order to have some time for discussion at the end. All right. The first presentation is all about regarding the questions and comments are best asked at the end of the presentation. I think it's okay if you agree. Okay. The first presentation is all about prosthetic valve embolization, a rare but breathtaking complication. Well, in reality, when we talk about valve embolization, we include 3 different complications. I mean, the valve malpositioning, the valve migration, and finally the embolization, which implies a loss of permanent contact with native structural valves. So I would like to ask Professor Dr. Katsimaglis, a well-known experienced interventional cardiologist, my friend, director of cardiology, cardiovascular department, cath lab, here in Athens in General Naval Hospital, to proceed with his presentation. So, George, the first in line is always the lucky one. I hope we won't abuse it, okay?
Okay, thank you. Thank you, Professor Giaccas, for the introduction. I would like to thank the organizing committee for the kind invitation to participate to this very interesting congress, one of the most interesting congress related to the structural heart disease. These are my conflict of interest for this presentation, and we are going to begin with the definition. TAVI embolism is defined as the movement of the valve prosthesis after deployment such that loses contact with the annulus. Approximately, the incidence is around 1% and is associated with elevated post-procedural morbidity and mortality, and sometimes need a big number of cases for conversion to open heart surgery. TAVI embolism can occur towards the aortic or the ventricular direction and usually occurs during the peri-procedural period. However, there is also the delayed migration, approximately until 24 hours post-procedure. The main causes for this TAVI embolism for the balloon expanding valves is the high deployment undersized prosthesis, rapid pacing failure when this embolism is toward the aorta. For the self-expanding valves is the high deployment, the undersized also prosthesis, the post-dilatation error, and sometimes the disengagement of the prosthesis from the delivery system. When this embolism is toward the ventricular direction, for the self-expanding valves is the low deployment and the wrong annulus plane from the CT angiography. For the balloon expanding valves, the causes are the rapid pacing failure, the undersized prosthesis. This is the main cause for the balloon expanding valves, and the failure to pull the flex catheter off the balloon. In the early randomized TAVI trials, this embolization occurred at a rate of 0.5 to 1%, as we have already mentioned. In the latest randomized control trial for the balloon expanding valves is 0.2%, and for self-expanding valves is 1.2%. For more from data which are from more recent cohorts, the more recent cohort is from the German Center of Cardiovascular Research from Berlin, with 3,800 patients who have undergone TAVI from 2009 to 2021. 54 patients met the VAR criteria for TAVI embolism. In these 54 patients, there were not included cases with implantation of a second valve for the treatment of paravalvular leakage or after removal of the first valve due to coronary obstruction. The incidence in this cohort was 1.44%, and it was clustered in the beginning. It was 3.4 during 2009 until 2013, and 0.55% in 2020. 85% of this TAVI embolism occurred after implantation of a self-expanding valve, and 15% after a balloon expanding valve. The incidence of the embolism of the embolized valve after the self-expanding valve implantation was not changed significantly after introduction of the next generation devices. The mechanisms are the spontaneous embolization into the ascending aorta, the migration into the left ventricle, the accidental pullback of the TAVI valve into the ascending aorta during the removal of the delivery system due to incomplete release of the valve, the embolization during post-dilatation, and embolization due to loss of the capture during the pacing, the fast pacing period. The majority of the embolization the majority of the embolized valves were into the aorta, the 41%, and for this 41%, the majority was in the aortic root. The risk factor from this cohort for TAVI embolism were horizontal aorta, the use of self-expanding valves, and patients with reduced ejection fraction. Also, there were frequent finding of some clinical leaflet thrombosis. Perhaps this is the cause of more frequent ischemic attacks in these patients, and also dissection and perforation through the snaring attempt. Now, when we have a balloon expanding valve, which is embolized, when it is embolized in the aorta, the main reason is the interruption of the rapid pacing, while the embolized valve into the left ventricle, it is because there was not sufficient anchoring of the valve, and during the post-dilatation, the valve was embolized in the left ventricle. How we are going to face this embolized valve, this embolization when it is in the aorta? We try to reposition it with inflating a balloon and trying to retract the valve in the descending thoracic aorta. When it is difficult to pass the aortic arch, it's better to pass another wire and try to crush just a little the valve using a balloon valvuloplasty, and after to retract the valve in the descending thoracic aorta. After, we try to pass a second valve from this valve, inside this valve. During repositioning of this embolized valve, the ventricular guide wire should always be maintained inside the valve so as to prevent the inversion of the valve and potential flow obstruction. Sometimes it's better to implant a covered or uncovered stent within the embolized valve, leaflets. In general, how to face a TAVI embolization when it is deep embolized, it is sure that it's going to require an open surgical repair. Sometimes implanting a second valve, it's better to trap the embolized valve if it is not so deep, it is in the left ventricular outflow tract. It will be better also for the surgeon. In contrast, the aortic embolization can be managed in the majority of time interventionally, with the surgery to be reserved for cases which are complicated with dissection or perforation. Usually, repositioning maneuvers using snares or inflated balloon can be used so as to deploy the embolized valve or to crush the embolized valve at an ectopic location. If it is complicated with coronary obstruction, it would be a medial proximal retraction of the valve, and care must be taken while manipulating the valve to avoid aortic injury, and especially with certain self-expanding valves which have a more prominent outflow portion. For example, the Accurate Neo or Accurate Neo 2. Here we can see in the picture C the result of retraction of an Accurate Neo 2, which resulted in a type B aortic dissection. So there are some anatomical predictors for self-expanding valve, which is the STJ height to be more than 24 millimeters, or there is an AL ratio, that means annulus perimeter to LVOT perimeter, to be less than 0.96. These are two predictors for embolization of self-expanding valves. That to say, a conical left ventricular outflow tract and tall aortic sinuses are strong anatomical predictors of ventricular embolization during self-expanding TAVI. But it is not clearly the bicuspid and the calcification. These are data from a cohort from Asian population. The data that we have more are from the Travel registry, which was published in European Heart Journal. It is for 30,000 patients from 26 international sites. There were 280 approximately embolized valves. The main reasons are heterogeneous. It was malpositioning, which led to valve embolization because of manipulation, of post-dilatation, of sizing errors, and fast rate pacing failures. There are also a lot of technical issues during implantation, but there was, from this Travel registry, an independent predictor of embolization. This was the presence of the bicuspid aortic valve. Also, the use of self-expanding valves, lack of calcification of the native aortic valve, and inadequate identification of the landing zones. These are different technical issues. There is no time to mention all of them. Let's speak about the mortality rates. If the embolized valve goes to the aortic direction, then the mortality rate is 17% in 30 days and 30% in 1 year. If the embolized valve goes to the ventricular direction, the mortality rate in 30 days is 27%, and in 1 year approximately 40%. And it is according to the treatment strategy. That's to say, the repositioning, the patients in whom there was a repositioned valve, the mortality rate was lower. In contrary, with the patients in which there was a conversion surgery, which the rate was 32% in 30 days and 45% in 1 year. Let's proceed with the conclusion. With the prevention, we propose that a meticulous pre-procedural planning in CT angiography with correct measurements, it would be the gold standard always. The selection of the most appropriate prosthesis type and size of the individual patient, accurate deployment techniques, assurance of the adequate temporary pacing, proper closed-loop communication between operators, assistant and technician. This is for the pacing, for the past pacing especially. An embolized TAVI in the ascending aorta should be pulled to an area where the lumen of the aorta equals the diameter of the TAVI outflow, and a stable position without obstruction of important aortic side branches is assured. Aggressive manipulation in general should be avoided because of the risk of aortic dissection, and the self-expanding valves usually require snares for repositioning, and embolized balloon expanding valves are mostly manipulated with balloons. The bailout strategies for the embolized valves are chosen immediately based on treatment urgency. When the valve is embolized into the left ventricle, removal of the device is mostly performed by open heart surgery. However, conservative management by advancing a balloon over the wire and pulling the TAVI valve outside the aorta has been accomplished sometimes. The majority of embolization occurs into the ascending aorta and can be managed percutaneously. And now I'm going to show you an embolized valve during a live demonstration 3 years ago. She was a patient, a female patient with a mitral valve, with a metallic mitral valve. Πάμε ένα slide πίσω, σας παρακαλώ. Okay. This was in the beginning. The valve was embolized in the aortic root because of the delivery system. The cone. Yes, because of the cone, the delivery system. We tried to snare the valve, and after we implanted we implanted a second valve. We have changed also the wires. We used a Landerquist wire. Okay, thank you very much.
Thank you, George. Thank you for this wonderful, very didactic talk. Did you put any stent in the first valve or remain it as itself?
As it.
Okay. All right. Well, before passing the microphone to all of you, I would like to attest our experience with a BEV, balloon expandable valve, embolization due to loss of capture of pacing, rapid pacing, and on grounds of very mild calcification of the valve. So we snared with the balloon. The valve, of course, embolized into the ascending aorta, subsequently to the aortic arch. And after that, managed to snare the prosthetic valve and anchor it distally to the left subclavian artery level. We nailed it over there. After that, we put another very easy valve, and the patient is. I saw him 1 month ago. Is 3 years and a half in a very good condition till now, without any problem. Well, did you have such a case, or if yes, how did you deal with any of you?
The main cause for balloon expanding valve embolization is the loss of capture.
Loss of capture.
Is the loss. And the main cause for balloon expanding valve...
Self-expandable.
Yes, no. The main cause of balloon expanding valve inside the left ventricle is the bad measurement during the CT angiography.
CT angiography. Yeah, there are too many mechanisms for that, but we will talk. Dr. Iacovo, if you want to say something.
Yes, Dr. Giaccas. I think it was an excellent presentation. Congrats, George. I agree that after a certain period, this is something unavoidable. When you do more and more cases, you end up with a certain number of these cases. It's less than 1%. Now we have 0.3% in our practice. I think it's very important what you said on the meticulous study of the CT. But also a couple of things that I would like to point out. It's we should be generous when in doubt to pre-dilate, especially in the non-calcified valves, and also, as you said before, it's very important to pay special attention when we retrieve the nose cone of the self-expanding valves. This is where we have the problems. And I noticed in your case, which is really interesting, when we want to stabilize the self-expanding valve, which is embolized upstream, I think it's better to try to stabilize the valve with 2 snares as opposed to 1, because otherwise you risk the danger to distort the valve and also to damage the aorta. So I think this is something that we learned in the last few years. It's better to maybe you do one more, you have one more access, and then you place a second snare, you stabilize the valve, and it's easier and also more safe for the procedure and the patient to place a second valve inside the other one. Okay. So overall, I think it's something that everyone who is doing this business to try to pay special attention now.
Yeah, statistics never lie, as usual. Well,
can I say something?
Yeah, of course,
Dr. Skaderis, yes. I want to share 2 cases of late migration that we had. One patient presented 1 month later, and when she was lying down, she complained of chest pain. And that because the valve moved upwards and was occluding the left main. The second patient was a 34 valve that was positioned low in the ventricle, but because the LVOT was small, there was no leak. 2 months later, the patient presented with gross heart failure. We did another CT, and we saw that the valve moved more into the ventricle, and there was a gross AR. So we put a second valve, self-expanding valve, a balloon expanding valve the second time, and resolved the issue.
Yeah, thank you. Well, as you said, that the bailout strategies are chosen based on these urgencies. Exactly. If you have a hemodynamic compromise, exactly. If you have an obstruction to the brain, to the heart, etc. Well, I understand that most of the cases were the embolization of the ascending aorta will be managed pretty good percutaneously. What about, and I want Dr. Patakos to say about that, to make a comment. What about when we have an embolization into the left ventricle? Then the things, it's not, Doctor, if someone, is it safe? Is it a safe alternative to try to advance a wire, a balloon over the wire, and to pull up the THV to the ascending aorta? Is it a safe alternative, or send them to for the beginning to the surgeons to work out? We've been involved.
Okay, we've been involved a couple of times in these unfortunate cases. What you are going to do with your wires and with your balloons would be up to you. We're there, and from the point that we're going to see the valve into the left ventricle, we're going to intervene. And our approach would be the routine. We'll go on bypass, and of course we'll try to take the valve through an aortotomy. Now, what the procedures before that, it's going to be up to you, to Kostas Parias, and all the associates.
Did you have anyone of such an experience with the embolism? Oh. Yes.
Never lose your wire. As soon as you lose your wire, the balloon turns sideways, and they go into acute heart failure.
Yes, I have mentioned it. Yes, never to lose.
The wire, you go and snare it through the balloon and turn it sideways. It's only 90 millimeters high, and it will come out. Those ends are like knives. The risk of aortic dissection is really high. So when you take out, say, you're right. A surgical, now you got to be careful not to stab it. You can do it. The main thing is don't ever lose your wire.
Yes. Like in PCIs. If you lose your wire, you lose everything. Dr. Georgiou, this is...
So we do TAVIs for 14 years. We had such an experience with one balloon expandable valve. Maybe it was mainly because of the sizing issues. So there's a sizing issue. That's why it happened. It was a terrible experience. The valve was in the left ventricle. The patient was inoperable, as was discussed again with the surgeons in the cath lab. We keep the wire in the left within the valve. We try to pull the valve to the proper position, and unfortunately we managed to do that, but we had a razor of all the material which was still in the valve, and we had a massive stroke, and the patient died a few days later. So I think the only solution is the surgical approach, and in such a cases where the patient is inoperable, we are in trouble.
Yeah, I think so. Again, you're better off operating, but if you can't operate, there are ways to get it out. The main thing is don't lose your wire before you decide to do something. Then the valve starts to spin. As soon as it starts spinning, you go down a rabbit hole really fast.
Yeah. Okay, you're right.
Thank you, George. Now,
Yes,
Dr. Pachorakis will continue with the next.
Yes, let's proceed. I'm very sorry for the delay. Thank you for the invitation. I would like to call Mr. Georgiou. Mr. Georgiou is an interventional cardiologist at Apollonio Hospital in Nicosia, Cyprus. And he's going to tell us about TAVI and coronary obstruction. Thank you very much.
Thank you, Mr. Chairman. First of all, let me thank the organizers for their kind invitation, especially Kostas Parias. Transcatheter aortic valve implantation is an established procedure over the last 15 years, well documented, but still complications happen. One of the most life-threatening lethal complications is coronary obstruction, which according to the TVT registry, it happens at 0.4%. This registry that was conducted from 2012 up to 2014, including 26,000 patients. Same results from the Spanish National Registry, which included 13,000 patients from 46 centers in 12 years from 2009 up to 2021. Low incidence of coronary obstruction, 0.8%, no temporal trends, which means that despite the fact that we have been improved throughout these years with new technologies, more experience, this complication still happens at the same percentage. More interestingly, the coronary obstruction does happen in the cath lab. 80% of the cases happen during the procedure. In hospital, just after the procedure, in 10%, and 6% of the cases are presented as a late complication. Unfortunately, the mortality is high. The in-hospital mortality is 37%, while the one-year mortality is up to 50%. The balloon expandable valve presented here with the red dots is related with the acute coronary obstruction, while the self-expanding valves are more responsible for the delayed coronary obstruction, mainly because of the mechanism of the nitinol frame of the self-expanding valve, which still expands within hours or even days after the valve implantation. The incidence of delayed coronary obstruction, according to the valve type, shows that the self-expandable valve can cause more frequently coronary obstruction, but more significantly is that the valve-in-valve per se is an independent predictor of coronary obstruction. That's why the mortality is 50%, is extremely high in these cases.
The most common clinical presentation of delayed coronary obstruction is the cardiac arrest. If this happens within the 7 days after the index procedure, later on the patients complain of unstable or stable angina. The left main stem is the artery that is more frequently occluded, almost 90% of the cases, while both arteries, left and right coronary artery, are occluded in 20% of the cases. Here are the most important anatomical and other factors that are strongly associated with the coronary obstruction. The anatomical factors are the coronary ostia height less than 12 millimeters, the sinuses or valsalva diameter less than 30 millimeters, the cusp height to be higher than the coronary height, low STJ height and narrow STJ diameter, the valve to coronary distance less than 4 millimeters, which means that the distance from the coronary ostia up to the final position of the displaced, degenerated valve leaflets to be less than 4 millimeters is a high predictor of coronary obstruction. The presence of extreme calcification in the culprit leaflet more than 600, and of course valve-in-valve, as was already mentioned, is an independent predictor also for coronary obstruction, mainly in the stentless bioprosthetic surgical valves or the stented BSV with externally mounted leaflets like trifecta and Sorin mitral flow. Female sex is also related with high risk of coronary obstruction, mainly because of the smaller anatomy. And here is a proposed algorithm in order to predict the risk of coronary obstruction, cusp height more than the coronary height or coronary height less than 12 millimeters, valve to coronary distance less than 4 millimeters, and finally the culprit leaflet calcium volume more than 600 are all independent predictors of high risk production and in this obstruction, and in these cases we may consider coronary protection. Valve-in-valve cases, according to the VIVID registry, are also high-risk procedures. The risk of coronary obstruction if a stented valve is already in place with externally mounted leaflets is 6.4%, while the stentless valves cause coronary obstruction in 3.7%. And here are the characteristics of that we have to take into consideration when we do valve-in-valve TAVIs: the type of failed valve, the failure mechanisms, the dimensions of the transcatheter heart valve that is going to be used, and if it will be intraannular or supraannular, the coronary reaccess, the peripheral access, and some procedural aspects of coronary protection. This is a very well-designed trial which examined the independent predictors for coronary obstruction. According to this multivariable analysis, the only predictor of coronary obstruction was the stented with external mounted leaflet or stentless bioprosthesis with an odds ratio of 7.67, while in the model of the CT cohort, the VTC was the only independent predictor with an odds ratio of 0.22 by 1 millimeter increase. And this is why we talk about the VTC cutoff of 4 millimeters, because according to this trial by Ribeiro, the sensitivity of VTC cutoff is 85% and the specificity is 89%. And this is another proposed algorithm for valve-in-valve TAVIs, how to deal with these cases in order to prevent coronary obstruction and how to do further coronary protection. TAVI is a procedure that will be used in the near future in higher percentages, mainly because they have the TAVIs we shifted to younger ages, and the risk of coronary obstruction in these cases is 0.7%. This low percentage is mainly because of bias, selection bias. As before TAVI, we choose our patients very carefully. And if we are planning to do a TAVI, we have to predict the risk of coronary obstruction by taking into account the risk plane of the previously implanted balloon expandable valve. If the engagement of the catheter is above the risk plane, then this TAVI is feasible. If it's beyond the risk plane and the distance from the transcatheter heart valve to the aorta is more than 2 millimeters, then it's still theoretically feasible. If the engagement of the catheter is beyond the risk plane and the distance from the valve to the aorta is less than 2 millimeters, this is unfeasible and there is a high risk excuse me, for coronary obstruction. Here are the strategies to prevent coronary obstruction during TAVI. Exhaustive imaging evaluation and adequate planning. Sometimes have to reassess the risk and maybe may favor surgical aortic replacement if it's doable and the patients are not inoperable. Coronary wire protection, chimney technique, basilica technique, and the unicorn procedure. And by protecting the coronaries with a wire, we know from the Chimney International Registry that we decrease the rates of mortality. Here is a case of coronary wire protection. I think we are experienced with that. 74-year-old male patient with congestive heart failure, structural degeneration and dysfunction of the aortic valve bioprosthesis, predominantly incompetence, previous medical history of surgical AVR with a 25 millimeter Sorin mitral flow, externally mounted valve, and ascending aortic aneurysm with surgical repair. A pacemaker was implanted at the same session in 2014. Paroxysmal atrial fibrillation and chronic atrial failure. The distance to the coronaries, the VTC was large enough, 6.8 millimeters in the left coronary and 6.5 millimeters in the right coronary artery. So in this case, we knew from the beginning that the risk of coronary obstruction was low. Nevertheless, we used a balloon, and over the balloon, we introduced an extension guideline catheter in order to have a stabilization of the guiding catheter. We deployed a 23 millimeter Sapien 3 Ultra valve, a relatively high implantation, no paravalvular leak as used to be in valve procedures, no intervention, no need for any intervention to the coronaries. Chimney stent technique is also a very good alternative in particular cases with very high risk for coronary obstruction. This is a case of chimney stent technique that was done in our institution. 79-year-old female patient, congestive heart failure, severe degeneration of the bioprosthetic aortic valve, previous medical history of redo aortic valve replacement, so she had already 2 surgical operations. The last one was in 2012 with a 21 millimeter Sorin mitral flow. The pacemaker was implanted in 2021. This is, and here you can appreciate the very low takeoff of the left coronary artery compared to the mitral flow valve and the narrowing of the aortic root at that level. The coronaries were protected with wires. A stent was placed in the mid part of the LAD. Self-expanding Evolut Pro Plus 23 millimeter valve was deployed, which was post-dilated, relatively low implantation, no risk for pacemaker here because there was already pacemaker. Excuse me. So you can appreciate in the left side, in the left-hand side video that there is the left main was almost occluded at the ostium of the left main. Therefore, we retrieved the stent, we deployed it, we flared it, and the final result was good. No significant leak, paravalvular leak, so we finished with that result and we are very satisfied from the final result. Basilica technique addresses directly the problem of the coronary obstruction by lacerating the coronary cusp that is just in front of the coronary ostium in order to prevent coronary obstruction. It creates a coronary triangle flow through the coronaries are supplied. We have also some splitting devices. This is the shortcut from P-Cardia from Israel. Professor Dvirch published a small trial with 8 cases where the bioprosthetic degenerated leaflet was split by this dedicated device without complications. A very promising technique, and we'll see the results in larger scale trials if this will be the way to go for coronary protection. Finally, the unicorn procedure for TAVI in TAVI. This is done with using a coronary guide wire through the telescopic system of an Ablat's left guiding catheter and the microcatheter. We cause with the radiofrequency impulse a laceration to the coronary cusp, the bioprosthetic, the transcatheter bioprosthetic leaflet cusp. Then we dilate with the balloons, and then we deploy the valve. It's another way to go for coronary obstruction in TAVI. In conclusion, Mr. Chairman, ladies and gentlemen, to optimize outcomes in TAVI procedures, it is essential to identify patients at risk for coronary obstruction. These patients can be best identified by structured evaluation that includes specific CT measurements, coupled with appropriate preventive procedures. This comprehensive patient assessment can mitigate the risk of coronary obstruction. Further research is needed to validate the different strategies and emerging dedicated devices that aim to prevent that complication. And finally, as TAVI procedures continue to expand, identifying and managing the risk of coronary obstruction will remain an essential consideration for optimizing outcomes and improving patient safety. Thank you for your attention.
Mr. Georgiou, thank you very much. Your cases are very impressive. Okay, I would like to make one question, please. Sometimes at Zanio Hospital we make many cases of left main, but we don't make valve operation. But sometimes we put a stent in the left main and we don't know if we are protruding outside or we are in the left main. Do you prefer a special valve for this type of operation? I mean, if the patient have a stent in the left main, there is a special valve that you will prefer to put in this type of pathology?
It's a very good question. I think the most important in this case is to measure exactly the distance of the anticipated final position of the valve to the stent, the metallic frame of the stent in the left main, because it is the most important. And also it's very important when we do PCIs in the left main stent to flare the stent in order to open it better and to avoid the possibility to compress the stent struts towards the left main. I think there is no any answer to your question, exact answer. If one valve is better than the other in these cases, I think the proper and the very careful estimation of the distance of this valve that will be implanted to the left main is more important than the choice of between the valve expandable or the self-expanding valves.
Thank you very much. Do you have any questions from the audience?
Okay. I think this is a fundamental topic. It will soon become a fundamental topic in clinical practice, the obstruction, the coronary obstruction, and all the measures. What are these cases where the preventive measures are not so sufficient at all? And you better send these patients to the surgeon. Okay, you need a sophisticated imaging, you need some other things, but what are these cases that you better send it to the surgeon, even, I mean, you better avoid the cases to be for TAVI?
I think there are cases where there is diffuse severe coronary artery disease, left main stem disease, and the patient is still operable. Yeah. In these cases, maybe it's better to proceed with surgery in order to have a bypass surgery and surgical aortic valve replacement in the same session. In my country, unfortunately, from years 2013 up to 2020, the majority of the valves were deployed, implanted surgically, were Sorin mitral flow. So you have all of these cases coming back over the last 2 years with degeneration of the valves. And in these cases, when there is a very high risk of coronary obstruction and the patient is still young, for example, 70, and has no any comorbidities, and we know from the beginning that we're going to need a stent in the left main, having in mind that there is a risk of stent thrombosis or extrinsic compression of the stent, or you have some issues with dual antiplatelet therapy. In these cases, maybe you have to reconsider surgical treatment. And you have to keep in mind that the surgeons improved significantly their techniques, and the risk of redo surgery is not so high if the patient is still young and has no any comorbidities.
Dr. Iakovou? Yes, Dr. Iakovou, yes, thank you. So if I may add to that, and also the question of Dr. Patsourakos as well, we have to pay special attention in order not to deform the stent which is hanging in the aorta, the left main stent. I think this is very important, and it's very important how to do the chimney technique. I think it's
maybe to finish with a kissing balloon, Yannis. Sometimes.
Yes, that's what I was adding. Yes, in some situations when you need to do a kissing balloon with the inflation with the balloon, the post-dilatation balloon of the valve. So you have to be really careful in order not to deform the stent. And another good thing that we need to keep in mind is there is also delayed coronary obstruction. So some of the sudden deaths that occur in this category of patients actually occur because of the delayed coronary obstruction. So that's why we are generous in chimney technique. So when you have a very narrow VTC, I think it's prudent to do, regardless, a chimney technique. We have a small series with CTs that follow up to 1 year. So if you do a proper chimney technique, all of these stents will be patent at follow-up. And the last thing is that I would like to point out is, of course, we talk about basilica. It's very rare. It's the learning curve is very steep. I don't think someone has done any basilica procedure in Greece, and also the shortcut device. We know that it's not available in Europe, so we are limited in terms of how to better prepare these patients. So in these situations, I think patients need to be referred back to surgeons, and that's why it's very important for them to participate in the heart team and the decision as well of how to better treat these patients.
You know you have coronary disease and you think you're going to be coming back, and you chimney them, good luck.
Yeah,
especially with a self-expanding valve.
Yeah, with any valve. Once you have a chimney, you can't get back into that thing unless you're extremely lucky. So that's your last shot at the coronary. So just remember that you've now.
I think this is very important as we treat younger patients. So if you do a chimney procedure in an 80-year-old patient, most probably you'll be fine if you have taken care of the coronaries before. But if it's another question, if you have if you are dealing with a 65-year-old male,
Okay, we have a question. Just tell us your name, please.
Dr. Kilic from Turkey. Dr. Yorgi, very excellent presentation. Thank you. Nowadays, we are not seeing so much, but TAVI in TAVI will come. So these valves will degenerate, and in that positions, maybe we can see much more coronary obstruction, because one of the mechanisms of both delayed coronary obstruction and for future valve in TAVI is the valsalva sinus sequestration. So this point is very important, and you underlined it also. For this point, for example, commissural alignment is also very important, because to do future basilica procedures, and also for the self-expandable valves, balloon valves in self-expandable, etc. What's your opinion about for future interventions? Should we learn basilica, or really I appreciated about the unicorn technique that you mentioned. So it's also very important technique for future interventions.
I think the most important issue with the TAVI in TAVI is the sinotubular junction. So it acts as a bottleneck, anatomical bottleneck, and if the sinotubular junction is small, then you have a high risk of sinus sequestration and coronary obstruction, acute coronary obstruction. So here again, the anatomic measurements are very important from the CT, and sometimes you have to reconsider even which valve going to use, self-expanding in the balloon expandable valve or balloon expandable in the self-expanding valve. It's a very complicated issue. It's not so straightforward sometimes. There is no clear answer. Sometimes we don't have clear answer which valve must be used. We don't have a very large experience with this. We have done only few cases of TAVI in TAVI because 10 years ago or 14 years ago when we started, the patients were 80 or 85 years old. Now they are all died. So, but it's still something which is have to keep in mind that we're going to face it more frequently the next few years.
Okay, thank you very much. Mr. Tsigaderis, please, do you have a comment?
No, I just want to point out that the first implant is the most important one, and we should ask also our surgical colleagues to use valves that are friendly to us for valving valve.
Okay, thank you very much. We will proceed now, making a little switch between the fourth and the third presentation. Instead of Dr. Rigopoulos, Dr. Kapadia wants, if you agree. It's okay with that? Okay. So now we proceed to the prevention and management of stroke in TAVI. And I'd like to say that despite this meaningful, this seemingly triumphant progression of TAVI, there is still one major thorn in TAVI's side, and this is the procedure-related cerebrovascular events. Dr. Kapadia from Cleveland, a well-known authority in structural heart disease and intervention, will share his knowledge in stroke prevention and management for TAVI patients. Professor Kapadia, the stage is yours. Listen.
Thank you. Thank you so much, and thank you for accommodating me a little bit early. Good afternoon, and I was enjoying your conference, so thank you for inviting me too. So, stroke has been my personal interest for a long time, and I want to just start with these 4 things to say that what is the brief overview of the Protected Tower study, what are the data that are not typically covered in the stroke prevention trials. I will put some data in context with other things, and then personal clinical recommendations. So this is the idea. So Protected Towers trial is the trial that we generated. This is published in New England Journal last year. It is to study mainly to understand that what is the clinical stroke rate in transfemoral TAVR is reduced by the CEP protection device or not. And it was a prospective randomized trial. We enrolled 3,000 patients, and in the 3,000 patients, 1,500 were with the TAVR alone and 1,500 with the CEP. And the idea was to find the stroke at 72 hours or at discharge. And we also graded the stroke as disabling or non-disabling based on the modified ranking score. Primary endpoint was that. And if you look at the data, typical 80-year-old patients for TAVR, 1/3 were extreme risk, 1/3 was intermediate, and 1/3 were low risk. Women was a little bit more in the CEP group, just by chance. But if you look at the balloon expandable and self-expanding valves, they are 60% and 30% in each. The primary endpoint of the trial was negative, to say that the stroke rate was 2.9% in the control group versus 2.3 in the device group. And in the control versus device, the major stroke or the disabling stroke was 1.3 versus 0.5. So this was statistically significant, but the overall stroke rate was not statistically significantly different. If you look at the mechanism of disabling stroke, most of them were ischemic stroke. That's what you would understand, and that made sense, that 17 versus 6 ischemic strokes. And if you look at all the strokes in detail to say that which are the strokes that happened with the CEP to try to understand that why it didn't work, it is very clear that why it didn't work was because either they were hemorrhagic or these were massive complications that happened in those patients, like embolized valves, CPR, things like that. Only one patient where we could say that the ischemic stroke could have been potentially prevented, but we could not understand why it happened. So if you look at the all stroke versus disabling stroke, it is very important to recognize that in the patients outside of United States, there was no difference. But as you see in the bottom, inside of United States, there were patients who did, who did better with stroke prevention. So this particular subgroup was positive, 1,800 patients in this group. So what are the data not covered? So this is the outside versus in the United States. So as you see, the stroke rate was a little bit higher outside, 3.5% versus 2% in United States. And if you look at the after the stroke rate was not that different, the disabling strokes. But if you look at the 72-hour stroke by arm outside of United States, there was no difference between control and CEP group, 3.3 versus 3.7. But if you look at in United States, the difference was significant. So 2.6 versus 1.3 and 1.5 versus 0.4. So this just tells us that there may be some patients that benefit from the embolism protection devices. And if you look at this, this is again to say that the mortality after stroke was less, the discharge to home was more with the CEP, all suggestive that the strokes were less disabling when you use the CEP device. If you look at the United States registry, it is also very clear that in the United States registry, the NRD registry, if you look at the stroke death, the death after stroke was 6.3% versus 11.8% if you use CEP or you did not use CEP. So again, very important information to keep in mind. And if you look at the TVT registry, it was 1.4 versus 2.2%. Cleveland Clinic experience, if you look at our own experience, we have 3,000 patients, 1,000 patients treated with CEP and 1,800 patients that were treated with CEPs, 1,000 without CEP, 15 strokes in the patients without CEP, 8 with CEP. But very importantly, the stroke were less severe in the patients who were treated with CEP, and 4 patients died out of 15 who had stroke without CEP. Nobody died after the CEP and stroke. So they were all minor strokes. So the mortality of the risk of mortality after stroke is reduced in patients with CEP compared to those without CEP. So what are the things that we do? So this is our own data. This is the typical device that we use. Is the Sentinel device. That's the only device that is currently approved in the United States. So this is the CEP device. When we use the device, this is our data for last 5 years, 3,000 patients. We have 2023 data, look very similar. 0.4% mortality, stroke is 0.5%. More than 2 plus AR is 0.4%, and new pacemaker rate is 2.9%. So again, using the CEP device, we have been able to reduce the stroke to less than 1% in all patients, almost 4,000 patients now if you include 2023 data. What is happening in the landscape? So the landscape is changing in the sense that Sentinel is the first generation device. There are several newer devices that are being tested right now. They are all either deflecting devices or capture devices with the different pore sizes. Most of them are from femoral access, except for the Protumbo, which is the left radial access. And as you can see, the access site size also varies. There's another very important thing that's happening is that the BHF Protect TAVIS trial is already enrolling, and it has enrolled a large number of patients. We are expecting that by the end of the year, it should complete enrollment, and we will have some data. Their presumptions are different. We thought we will reduce from 4 to 2%. As you know, we were about 3% to 2%. So their assumptions are a little bit more realistic. So hopefully we will get better data with this particular trial. We have already said that we would like to combine the data, and we have already put that prospectively as a goal. So stroke is still a clinical problem, although the risk of stroke is getting a little bit better. The sentinel has been shown to be associated with decrease in the disabling or major strokes. Device is so safe. Stroke remains unpredictable. And we have been using sentinel device in all patients. Again, it's a cost. So if you can afford it, it's worthwhile in my opinion. And there are several new devices that may be slightly better, again, require more data. And then there was one other question raised in the talk to say that how we manage stroke. We have been managing stroke most commonly if they're minor strokes. As I said, most of the patients are minor strokes. Then we typically do not send them to neurointervention. But if they're major strokes or major artery occlusion, then neurointervention is necessary. Everybody should have a CT scan prior to sending them to the neurointervention because some of them may have a hemorrhage. Very rare again these days, but this is something to keep in mind. So thank you for your attention.
Thank you very much, Professor Cardario.
Thank you very much. I would like to make a question, please. Thank you for your speech, but I'm wondering if that stroke happens, it's something that we can do differently from the other strokes. I mean, if we have to manage this type of stroke, we have to make something different from the other type of stroke that we manage in other operations.
So yes, so since the TAVR is done with conscious sedation, first of all, the recognition of the stroke happens immediately after the procedure, right? So that the time from the stroke to the time of management is fast. So what everybody recommends is to take the patient from the cath lab or hybrid room first to the CAT scanner and make sure that there is no hemorrhage. If there is no hemorrhage, CT angio from the brain is necessary. And if you do the CT angio and if you either find a calcified embolic material or a major artery occlusion, then take the patient to the IR suite and try to retrieve the calcium. If you do not find either of this, so if there is no calcific material or there is no major artery occlusion, then conservative management is reasonable. So this has been the typical workflow for these patients, a little bit different than, let's say, open heart surgery or something like that, because by the time people are extubated or this thing, there is some time that has elapsed. So doing a neurointervention is less effective in those patients. But these days, with the embolic protection devices, in last 7 years, we have not taken anybody to neurointervention because these large strokes are not seen.
Thank you very much.
Is there anyone for a suggestion, a comment? Well, do you agree with the common belief among... Do we have it? It's gone? Is Dr. Kapadia with us?
I am here, I'm here.
Okay, thank you. Well, do you agree with the common belief among structuralists that all patients, especially those who calcified valves, should be treated with a protecting device? And if yes, is there enough evidence, published evidence, to support it?
As I said, that yes, in my opinion, if you can afford it, you should try to use it because the device is safe, and if it does capture embolic material. The published data are not enough to say that this is a class 1 recommendation. So there is no, because the randomized trial, the protected TAVR trial that I did was negative. But on the other hand, the BHF TAVI trial is ongoing. By the end of the year, we should have 10,000 patient data from a randomized trial. So very soon you will have an evidence-based data, but at least in United States registries, TVT registry, national registry, it looks like that there is benefit. Currently, I would say that if you are doing bicuspid aortic valve or TAVR valve-in valve, these are the patients that you definitely should use emboli protection device. And the rest, it is a little bit of we will need more data.
Thank you. If Dr. Tsikaderis or Dr. Iakovou want to make some, you can proceed. Thank you, Professor Kapario.
Thank you. My pleasure. Thank you.
Yes. Thank you very much. Mr. Rigopoulos is the Associate Director of Adult Cardiology, Mitera General Hospital. TAVI and need for permanent pacemaker implantation. Mr. Rigopoulos.
Thank you, Mr. Chairman. I would like to thank the organizers for inviting me to this exciting Congress. I have no conflicts of interest. And of course, we are not electrophysiologists but we need to think about the possible need for permanent pacemaker implantation after TAVI. And at first, we'd like to see a little bit of the anatomy of the aortic root, which the surgeons know very well. Well, the penetrating bundle of His emerges at the surface of the left ventricular outflow tract, exactly beneath the membranous septum. And this we should be aware of because this is our landing zone with the TAVI valve. And the length of this membranous septum is approximately equal to the distance between the aortic annulus and the bundle of His. So, of course, we know that about 15% more or less of our patients will need a permanent pacemaker. And if we look at the TVT registry data, we see that although the number of implantations during hospitalization is slightly reducing until 2018, there is an increase in the number of patients who will need a pacemaker after discharge. Well, newer data of the same registry show that overall the need for a pacemaker is reduced, and this is until 2020, perhaps due to the awareness of the need for a permanent pacemaker implantation in the patients. And, but there are differences in centers which do not have anything to do with the volume of the procedures in each center. So if we look at the data from this registry, the PACE-TAVI registry, with 377 patients, we see that the more the patients are getting paced by the pacemaker, the more problems we have with cardiovascular death and hospitalization for heart failure in follow-up, and this is up to 5 years. And what is more, we see that patients with reduced ejection fraction before TAVI that will take a pacemaker, that have a pacemaker afterwards, will have less improvement in the LVEF after TAVI, while patients with normal EF might have a reduction in EF at 1 year. And this is, of course, seen also in the symptoms of the patients, with patients having more than 40% ventricular pacing, having more symptoms. And this is a meta-analysis which included more than 50,000 patients, and here we see also that mortality and rehospitalization is increased in patients receiving a pacemaker after TAVI, while there is no difference in stroke or endocarditis in comparison to the patients who will not need a pacemaker. So although not everyone agrees with that pacing is bad for our patients, we have these data and we should believe them. What are the most common conduction problems after TAVI? First, we have the left bundle branch block, which is in different studies from 5 to 65%. It slightly decreases with the use of modern prosthesis, Typically, we see that during the intervention and rarely after 30 days post-interventionally, and very often it is transient. But if we see it longer than 30 days, then we should call it permanent. And it is extremely likely that a patient with a new left bundle branch block will need a pacemaker if the patient has a right bundle branch block before the intervention. The other most common conduction problem is the atrioventricular block. It's about 20% after TAVI and usually happens immediately during the intervention or just after the procedure, and often resolves on its own. But there we need a little bit longer temporary pacing for our patients in order to be sure that it has resolved and the patient is safe. But if the block does not resolve, then we need permanent pacing. And there are, of course, some cases with late or delayed high-grade AV block, which could possibly explain syncope or sudden death after TAVI. What we must know is that the risk of a delayed high-grade AV block is in sinus rhythm patients if we have a persistent new LBBB or prolonged QRS or PR interval, and in atrial fibrillation patients if we have consistent bradycardia, constant bradycardia less than 50. So there are some predictive factors that could increase the risk of a patient needing a pacemaker, and they have to do with anatomy, pre-existing ECG changes, technical things like balloon dilatation or the prosthesis, the choice of the prosthesis, or oversizing, implantation depth, and of course calcification of the aortic root. So if we see one by one, there are some demographic predictors. Possibly male sex is a predictor of need for pacemaker. Male patients need a larger prosthesis, but we need less frequently to oversize. And this is probably a weak predictor. Age is also a possible predictor, older age. Increased BMI is also a predictor. We don't have here an obesity paradox. And possibly patients with renal failure have also a higher risk. On the other hand, if we see the ECG and computed tomography predictors, a short membranous septum, as said, less than 8 millimeters is a predictor for permanent pacing, and the distribution of calcification and the size and shape of the LVOT and annulus may also play a role. A pre-existing RBBB, as said, is a very important predictor, and of course, if we have prior abnormalities of the AV conduction, this also increases the risk. Periprocedural factors, as said, is the valve choice. We had the Lotus Edge valve, which is not anymore in the market because of a high pacemaker implantation rate. And with the self-expandable valves, we have a higher need for pacemaker with a pooled incidence of 25% in older studies, and certainly higher than the balloon expandable valves. This is because of the, more or less because of the deeper positioning in the older times of these self-expandable valves. And with the balloon expandable valves, perhaps there is a higher risk of pacemaker need with the Sapien Ultra because of the outer skirt. But this we still have to see. With the Accurate Neo, there's a very low need for a pacemaker, probably because of the reduced radial forces and the supraannular position of the valve. And generally, with larger valves, more than 29 millimeters, we need probably more pacemaker implantation. The depth of the implantation of the valve, of course, is a very important reason because it has a direct relation with the need for pacemaker. And of course, the most important factor is the difference between the length of the membranous septum and the implantation depth. The post-dilatation increases also the rate of need of pacemaker, and as said, the ECG changes should also be considered. There is a risk score with a very good, predictive accuracy, which involves the device landing zone calcification with a precise characterization of distribution of calcification in aortic valvular complex, the short membrane septum length, the pre-existing right bundle branch block, and the ventricular implantation depth of the prosthesis. And we see that this has a very good negative predictive value, this risk score. And of course, if we have all three or all four factors, then we have a very high need for permanent pacemakers. This should be validated in further studies. So what we have to do, as said, we should avoid excessive oversizing and of course undersizing, because then we will have regurgitation. We need sometimes, as Dr. Georgiou showed, to make some compromise decision between the need for a pacemaker and the risk of coronary ischemia, and then of course we decide for the pacemaker. And of course we need nowadays to lower the implantation, to put the valves higher with the Midas approach or the cusp overlap technique. This is the Midas approach. They measure the length of the, with the CT, the length of the membrane septum, and then they try to position the valve a little bit higher so as to not interfere with the His bundle. And the cusp overlap technique we have seen in the last years, we implant the valve as high as possible, judging from the non-coronary cusp. And you can see in an old patient of ours with a pre-existing conduction problems in ECG and a very low left ventricular ejection fraction, after almost 2 years, the measurements in the ECG have become better than before the implantation, and the patient is doing fine. We have results from this meta-analysis for the cusp overlap technique, which showed that really we could implant less than half of the patient's pacemakers after using this technique. And then the question is, what happens if we really have abnormalities with conduction after TAVI? What we do then? We have the guidelines, the ESC guidelines of 2021, and we see that there are some cases, and then we have to decide according to what we have with the patient. If we have a persistent high degree AV block, meaning at least 24 to 48 hours after TAVI, or a new onset alternating bundle branch block, then of course we need a pacemaker. This is easy. If we have a pre-existing right bundle branch block with new procedure conduction disturbance, meaning transient high degree AV block, PR prolongation, or an axis change, then we need also a permanent pacemaker. This is a class 2A indication. And now it begins to become a little bit difficult. If we have a persistent new left bundle branch block with QRS or PR prolongation, and no further prolongation in the first 2 days after the procedure, then we may monitor the patient with ambulatory ECG monitoring or perform an EPS to measure the HV interval. Of course, a high risk for high degree AV block in a new onset LBBB is the existence of atrial fibrillation, prolonged PR, or a low left ventricular ejection fraction. And last, if we have a pre-existing conduction abnormality with further prolongation of QRS or PR interval more than 20 milliseconds, then we also need to monitor the patient with ambulatory ECG monitoring or perform an EPS. This is here a 2B indication, and of course with no further prolongation of QRS or PR during the 48-hour observation. Otherwise, we would fall to another category. The new LBBB is not so benign. Of course, we see it very often, but if we, in this study, the patients were followed with ILR reveal for a year, and they saw that many patients had, about half the patients had arrhythmic events during follow-up, and 11% of those would need a pacemaker or ICD. On the other hand, here is another study from the Mayo Clinic, and they showed that patients with a new LBBB needed a pacemaker, 14% needed a pacemaker because of progressive AV block in 30 days. So we need to look after those patients, although the patient is not anymore in the hospital. We are not electrophysiologists, but if the electrophysiologists are asked what to do in cases of new or pre-existing LBBB after TAVI, or patients with other... it's the last one. It's the last one. Then there are various answers, and this might be explained due to the differences in the guidelines between USA and Europe. So in conclusion, conduction disturbances remain a concerning complication after TAVI, and permanent pacemaker implantation is, however, associated with higher risk for mortality and rehospitalization. Patients will need continuous ambulatory ECG monitoring in order to have them safe and decide if they need eventually a pacemaker. Of course, we have some progress with the prediction for the need of permanent pacemaker implantation, but still this is an unmet need, and perhaps we have some gaps in evidence. We have to recognize the anatomy of the membranous septum, and probably we need to involve the measurement of the length of the membranous septum in the MDCT measurement protocol before TAVI, so as to decide for the corresponding optimal implantation depth in our patients. Thank you very much.
Thank you, Mr. Rigopoulos. Unfortunately, we will have to proceed to the last lecture from Mr. Makar, and I think it's a pre-recorded lecture.
The title of my talk is Top 10 Lessons After All the TAVRs I've Done in the Last 15 Years. And, you know, this is the first TAVR that we did, November 26, 2007. It was like magic, right? Everything worked. It was beautiful. And since then, the number of TAVRs that we've done every year has actually gone up, you know, and in fact, we are almost nearing or maybe north of 6,000 TAVRs at our institution. So the first lesson that I have learned about this TAVR is that TAVR is actually a team sport. And everybody, it takes a village, literally, to do a TAVR and to build a TAVR program. And I think everybody is an equal stakeholder, so there are no... This is not a one person, this is actually truly, you have to respect all the stakeholders, whether it is imaging, surgeons, your fellows, nurse practitioners, all of them. I think the most important thing that I learned very early on was that good imaging is key to successful TAVR, and I think the most important thing is accurate device sizing. And you will not believe this. This is pre-CT era, 2010. So this is how we used to size, right? Look at the CT, it's 20.9 on TEE, so we use a 23 millimeter valve. There is PV leak, moderate. But you know, when you look at later on, We dug out the CTs in these patients because we had acquired these CTs and we were able to go back and do the analysis. Look at the maximum dimension, it was 28. So no wonder there was PV leak with a 23 millimeter valve, and it became very clear that the annuli had huge variations in shape and they actually changed in systole and diastole. And here is another case example that we did in 2010, and if you look at it in one of the measurements, the measurement was 21.6. But look at the cross-sectional measurement. This is all retrospective analysis because we were using CT only for vascular access at that time. And it became very clear that even a 29 millimeter valve would have actually had PV leak, not just a 26. And there was no 29 millimeter valve at that time. So one of my associates actually did this analysis. We went back and looked at CTs in these patients, and our analysis was actually one of the first analyses to show that CT sizing was the better way to go rather than by doing echo. Now, this is just a case. This is something that we did in 2008, and look at this aortic root injury. And when we went back and looked at the CT, it became very clear to us that the minimum dimension here was 14.6. There was MAC, there was contiguous calcium in the LVOT, and if you look at the area, it was only 241, right? With a valve size of 23, it for sure caused injury. The second lesson I learned was data is powerful, right? I think we all know about it, but nonetheless, it just highlighted how these clinical trials were done in TAVI, so there was no shortage of patients. All right, patients were actually lining up to get these procedures done. So I think multiple successful devices in multiple trials was the key in convincing, and all of these trials published in the New England Journal of Medicine, the Lancet, and JAMA, all of these things were actually very, very important in driving the field forward, changing the guidelines, allowing for proper reimbursement. Very early on, I learned that what may seem outrageous may actually not be that unreasonable, and that age is no a barrier to TAVR. So this is a 100-year-old patient in 2011, had a proximal right, had a left main trifurcation. We stented the right, stented the left main, then actually did a TAVR in this patient. You can see this is the old valve, all right, and in fact ended up with a good result, no gradient. The valve function looked excellent, and the tall gentleman is the guy. He was actually a week later in my office, after his TAVR procedure. And, if you look at him, he actually continued to do better. And this is when he was 104. I got an email from his daughter that he was actually doing well, and he actually lived to be 106. So unless we had pushed limits, we would have not known where the limits are. And this technology actually allowed us to do that. The next lesson that I learned was use all available talent to help your patient. Set your ego aside. And here is a patient, 75-year-old. Okay, look at the LVOT calcium. And, it all looked good. A little bit later, we saw there was actually pericardial tamponade. We aspirated, put the blood back through the vein, and then actually did picture on aortic root angio. Nothing really lit up. But then we actually did a selective injection into the cusp, and you can see that there is extravasation, there is contained or not so contained aortic root rupture. We worked with our neuroradiologists actually, and we coiled this, and this patient actually did just fine. Was discharged a few days later, and we avoided a sternotomy. So this is, applying all the lessons and everybody's skills to the task. And this is a patient later on, and this patient went home, and this is something that we published. And in fact, I get texts from people, actually, the last text was from here in India a few months earlier, actually suggesting that they did something like this and actually saved their patient. What else did I learn? I learned that every crisis can be an opportunity. And very early on, I was a principal investigator of this Portico IDE study, and we had to halt the study because there was reduced leaflet motion. We were doing 4D CTs naively, and we saw that these leaflets were not moving. Our trial was actually stopped. But nonetheless, what we did was we undertook a very thoughtful investigation of this, working with the engineers. We generated a New England Journal of Medicine paper, a Lancet paper, and started a whole field of subclinical leaflet thrombosis. And actually we found out that this was not just related to one valve, but all bioprosthetic valves, including surgical valves. I think, and this is something that we all know. So another lesson is do not give up too soon on a crashing patient in the cath lab. And here is a lady, she's 9 years old. There's a tight left main, as you can see, subtotal. We put the Amplatz catheter across the valve, knowing that she may become unstable and we may have to do TAVR quickly. And we started doing the PCI, and she actually immediately arrested. She needed CPR. During CPR, no rapid pacing required. We actually then deployed the valve. This is the SAPIEN valve being deployed. And then, of course, we went ahead, put the Impella, stabilized her, crossed the lesion again, and did a nice bifurcation stenting. She was in the ICU for 4 days, and she actually was discharged a week later. And this is a few days after that. She actually turned 100. And then she lived to be 103. She was actually a Holocaust survivor. Be prepared for the worst. Here's a patient, 79 years old. This is a patient who's got severe aortic regurgitation presenting as angina. Okay, the valve that she has, the surgical bioprosthetic valve that she has, is a 23 millimeter St. Jude Toronto bioprosthetic valve. And if you look at this is 12, 13 years ago. All right, and if you look at the coronaries, they're actually very low. The quarters in the sinuses are very, very tight. There was no concept at that time of left main protection. We actually tried it. We said, okay, let's be ready here. And a guide catheter, you can see that the stent is actually in position. We deploy this valve. This is the earliest version of the SAPIEN valve, and it looked okay. So the LV this is pre-TAVR, and then shortly thereafter you can see what has happened to the LV. It's not moving much. You take a look at the picture. Of course, the left main ostium has been pinched. Good for us because we were able to pull this valve, pull this stent back and actually deploy it. And one wasn't enough. In fact, we had to reinforce it with another stent as well, and actually then did intravascular ultrasound and all those things at that time. You can see what has happened to the hemodynamics, normalized, and this is actually the ejection fraction 1 day post. So I think we were prepared to actually take care of this patient. I think what is the other thing that I learned? Learn from your mistakes, and some can never be repeated, such as this one. So this is once again, this is the old SAPIEN valve. This was a MitraFlow valve. We protected the left main, and we are deploying this. But shortly thereafter, the patient, in fact, decompensated. This is what happened. We couldn't have occluded the left main. We injected, we had protected the left main. But what had happened was, this is basically at a cardiac standstill. Immediately we went on heart-lung machine. The problem here was the old SAPIEN valve, you didn't know which way unless there was no way to verify. And that is exactly what had happened. So we very quickly put another valve now, this time in the right direction. And this is post second valve, all right? So the patient was extubated, decannulated in the cath lab and did well. Not only that, this patient lived. 6 years later, now you can see this patient has mitral regurgitation. Now we've used a dedicated mitral regurgitation device actually to treat this. So another example of what happened. So here, remember your previous experiences and be open to new ideas. And here is a patient with pure aortic regurgitation from healed endocarditis, not a surgical candidate. And we tried doing a balloon expandable valve here. He thought we had it good, and then we decided to post-dilate, and then the valve embolized, as you can see here. And essentially what we did was, we pulled this balloon back, then went ahead, put another valve. As you can see, this time we actually oversized it a little bit more, so the valve anchored. And then we took a evolute valve because the other valve was actually sort of bobbing. So what we did was we cut out the leaflets of the evolute valve and anchored that valve there, and this patient was actually able to go home and actually did well. Teamwork and collective thinking, and the best ideas at times come from your junior-most colleagues and your fellows. And here is a patient, who's got a evolute valve. You would think they never fail, but here is one. And it is hard to cross these valves because the leaflets are actually a little bit tall, and we couldn't. So in fact, in this case, what we did was we did a transseptal puncture. We crossed the valve antegratally, created a loop, snared it out from the femoral artery, and then in fact created a rail, and then crossed the valve and did this in a retrograde fashion. So, and I think, you will be humbled. And, I do live cases all the time, and here is one such live case we did. We were asked to show a very tough bicuspid aortic stenosis, look at the amount of calcium, and, this patient we thought did great, but later on, actually, after going to the ICU, in fact, this patient decompensated, had aortic root hematoma, and ultimately didn't make it. So I didn't want to just show you all my successes, or our successes rather, and I think that aortic root injury is an issue when you deal with some of these very, very heavily calcified valves. Heart-lung machine saves lives. I think we've all evolving to the minimalistic thing, but I think occasionally when you do a lot of TAVRs, you will have a case where you are thankful that you had a heart-lung machine somewhere in the vicinity. And here is a case that we did many, many years ago. All right, and this is a patient that we had enrolled in the one of the Evolute pivotal studies, and not a whole lot of calcium. We deployed the valve. Early on, you can see flow in the left main. Later on, we didn't see much flow in the left main, and there is a standstill. Immediately, we went on a heart-lung machine. You can see there is actually no flow. We yanked out this valve, all right, snared it out, restored the flow. Then we actually used a smaller valve. And then actually went through that, went into the left main ostium, ballooned it, and then actually stented it. Believe it or not, she actually is still alive and actually doing all right. So I think the important thing is, yes, we need to push the technical limits, but I think it's important to collect and publish data, and bicuspid is just one such example. So I think the only reason we can push limits is because we have data now to back us. So I think which is data that we have generated in bicuspids showing that the outcomes may actually be good. Being thoughtful and actually deciding what to do and what bicuspids not to do. The same thing with aortic regurgitation. We are doing it, but we are actually accumulating data. I think it's not about doing it willy-nilly, but actually learning from what we actually do. I think I've learned that some cases are more than procedures. They're actually spiritual experience. And here is a 49-year-old lady who came. She bought one-way ticket from Central Coast, California. She's got severe MAC. She's also got aortic regurgitation. This is one of the earliest cases of sapien in MAC in the world. We had no idea about neo-LVOT and all of those things. We got just lucky that this valve anchored and actually did well, and then we brought this patient a year later to actually do the aortic valve, which was done as a live case. So this patient has off-label use of balloon expandable valve and off-label use of the self-expanding valve. I think this whole field of TAVR was inspiring, right? To be inspired by these pioneers like Henning Anderson and Alan Cribier. I think what really mattered in America was strong leadership and properly navigating. So TAVR did not meet the fate of carotid stenting, all right? It is properly reimbursed, and this was by getting all the stakeholders. And I think I've learned you cannot miss out on game-changing innovations. And on that note, I will end by showing this case. This is a 78-year-old patient who actually had bypass surgery, but they forgot to fix the aortic valve and forgot to address the mitral valve. So this is a few months later. We, in fact, brought this patient, did a balloon expandable in the aortic position. Then we used a dedicated device called the EOS device for the mitral valve. All right, this is done transeptally. So this is the aortic valve, this is the mitral valve, all done during one procedure in a matter of about an hour and a half. So I think this is one month follow-up on this patient, and he's doing great. So let me just end my talk. And I mentioned earlier about my fellows. We are very fortunate to have 4 or 5 fellows, young people, and then also visiting fellows that come to us around the world, and they stimulate. And I think this is, the young do not know enough to be prudent, and therefore they attempt the impossible and achieve it generation after generation. I'm lucky to hang out with these young people. And I have to say, this is the last slide here. So, the little younger guy is sitting to the next old guy, he tells him, I didn't believe in reincarnation when I was your age either. So I think we should all have a very open mind. Thank you.
For your presentations. On behalf of Mr. Giakas, Dr. Tsigaresis, and Mr. Iakovou, I would like to thank you for your presentation here. Thank you very much.
Dr. Bouboulis, Dr. Dardas, and Dr. Ioannou with us. And we're ready to start with the first lecture. I would like to invite Professor Borger from Leipzig, Germany. He will tell us about the crucial role of surgeons for the TAVI procedure. Professor Borger.
Okay, thank you very much for the introduction and for the invitation to speak today about the role of the surgeon in the TAVI team. I apologize I wasn't able to join you there today in beautiful Athens. These are my disclosures. My hospital receives fees from these different companies on my behalf. So this may be some of the view of some cardiologists is that cardiac surgery is on the way to extinction with the ever-expanding indications for transcatheter valve and coronary artery disease treatment. But I hope I can convince you today that I have a different perspective. This slide you've seen many, many times. This is the isolated aortic valve environment in Germany over the last 15 years. And of course, you note the very rapid expansion in the number of TAVI procedures over the last few years, and a steady decline in the number of SAVR procedures since 2014. But if you look at 2022, you'll see there was actually more SAVR procedures performed than in 2021. And in 2023, I've seen the data, but it's not yet published, there was even more SAVR procedures being performed. So maybe we've reached, at least in Germany, sort of the equalization point, and this will probably stay this way until we get more data that suggests that the needle should move in one direction or the other. You are all very well aware of the market advancements that have taken place within the TAVI platforms over the last few years, starting with high-risk trials and then progressing to intermediate risk, and then finally the low-risk trials, where we recently had the 5- and 4-year outcomes presented for Partner 3 and Evolut low risk. We also have even longer follow-up for the Notion low-risk trial, although it's important to note that for Notion, the average age was 79. It's also important to note that for all 3 of the low-risk trials that we currently have longer-term data on, Evolut, Partner, and Notion, that bicuspid aortic valve patients were an exclusion criteria. Over this evolution, we've seen progressively less paravalvular leaks, less prosthesis patient mismatch, especially for the self-expanding valves, decreasing pacemaker implantation rates, decreasing access site complications, and a couple of randomized trials have shown that anticoagulation can be simplified down to simply aspirin, a daily aspirin dose. And all of these very positive developments have led to this marked increase in the TAVI procedures that I previously showed. But we are in a bit of a political question here, and does the surgeon need to participate in the TAVI heart team? In other words, the heart team, is this a catchword, or is it actually being performed at the individual sites? And here's a recent figure that I downloaded from the AHA website. And I was very surprised to see interventional cardiologist or a cardiac thoracic surgeon would be talking to you about your aortic stenosis. At least in Germany, it's legally mandated that both of these specialties are present when discussing optimal treatment strategies for the aortic stenosis patient. So I was quite surprised to see this in the United States. If we look back historically, we performed the first successful transapical TAVI in the world here in Leipzig. Tommy Walter and Fred Moore, together with Michael Mack, back in 2006. And back then there was a lot of complications, not just the transapical, but also the transfemoral patients, mostly because of the large sheath diameters, necessitating firstly surgical cut down. We even used cardiopulmonary bypass routinely for the first few patients. And there was a relatively high complication rate that required surgical bailout. Several such examples you just saw Raj Makar show in his presentation. But we felt that the heart team, which was based on the Syntax experience, for which Fred Moore, my predecessor here, was the surgical co-chair, that this would also apply well to patients with aortic stenosis. And this concept became increasingly popular over the several following years. And as a matter of fact, in the last version of the heart valve guidelines, the word heart team is mentioned dozens of times. And in Leipzig, we do live the heart team concept. It's not just a catchphrase for us. On the top left is Thilo Noack. He's our surgeon, who's the co-director of the structural heart team in conjunction with Mohammed Abdul Wahab. I'm sure many of you know him. Mohammed is a really gifted interventional cardiologist. And I would say that the surgical input here is very important for the reasons I'll show in just a few minutes, but this was originally Fred Moore's idea, is that the surgeons need to be actively involved. They can't just be sitting in the back corner fetching coffee and cream for the other members of the team. That such a role does not make one an active member of the heart team. And one of the ways to overcome that is to make sure that there's a common budget. So financial incentives are removed from the teamwork environment. And that's certainly what we have here. But here's an example of why I strongly believe that it's important to have representation from surgeons in this decision-making process. As you know, in the European valve guidelines in 2021, was suggested that patients less than 75 years of age should have SAVR as the procedure of choice unless there's a contraindication, and those older than 75, TAVI should be the first procedure to be thought of, whereas the American guidelines were more nuanced, saying less than 65, by default the patient should get SAVR, and more than 80, patients should get TAVI, and in between there should be a heart team discussion. However, in the United States, those guidelines that were published in 2021, there's been an explosion of TAVI procedures since then. And even though the guidelines very clearly state that SAVR is the procedure of choice under 65 years of age, you see from this publication 2 years ago that almost half of all patients under 65 in the United States are getting a TAVR instead of a SAVR. So this completely contraindicates or contradicts guidelines, and the question is why, and what we can do to try to encourage people to follow guidelines. And here's where I see the surgeon playing the most important role in the heart team. The surgeon is part of a very complex process, including the clinical and imaging assessment, and the heart team evaluation of the patient, of course also discussions with the patients regarding their goals and preferences. And in this review article that Stefan Windecker and Volkmar Falk from European Heart Journal, they outlined the different steps that are complex, multifaceted, and can benefit from input from many different points of view, including from the surgeon. And they said that the heart team is strongly recommended for achieving optimal patient outcomes. And this is also written in the valve guidelines. So here's a picture from our heart team in the pandemic. It's actually bigger now. We meet every day at 3:30 p.m. There is not only an interventional cardiologist and surgeon, but also radiologists, non-interventional cardiologists, anesthetists, et cetera, so that they can incorporate these complex decision-making processes like you see in the right side of the table, which was in this review paper. And here's a typical day in our center. You can see in 2 hybrid rooms, we have 8 transcatheter valve procedures done. This is not a big exception. Anybody who has been to our center knows that this is what happens every day, and we're finished by 3 p.m., 8 cases. I think we have the largest TAVI program in the world. So it's not like we are people actively working against TAVI by any means, but we strongly believe that the guidelines are there for a reason. So on the left, you see the average TAVI age, as well as the Foxplot distribution at our center over the last 15 years. And you see the average age was 82 in 2006. And in 2023, the average age is 81. So we strongly believe in the heart team concept, even though we are treating more and more lower risk patients that are elderly. Without a doubt, I strongly believe elderly patients, low risk, they should be getting TAVI rather than SAVR because they can get up and around much faster. The question is what to do with the younger, lower risk patients. And there's food for thought out there. This is one paper last year, which is a meta-analysis of reconstructed time to event data for all of the randomized trials for SAVR versus TAVI. And when you pool together all of the different trials, starting at 2 years after the procedure, there is a statistically significant advantage of surgery, and this is for all-cause mortality. This is not pacemakers or paravalvular leaks. This is all-cause mortality, suggesting that in younger, lower-risk patients, SAVR should be strongly considered. And these authors found a 25% higher hazard ratio for death and stroke after 24 months. So we have to take these facts into consideration. Here's another interesting slide comparing the recently published long-term mortality up to 8 years or survival in isolated SAVR from the STS database compared to the SAVR patients from the low-risk randomized trials. And the survival in the real-world all-comers STS database is higher than in the surgical arm of the randomized trials. There's several reasons for this, including patient selection bias in the United States. That is, the patients that are now getting SAVR in the US, because of the slide that I showed you before, are very low risk. But there's definitely a bit of a misconnect between those real-world data and the SAVR data from ongoing trials. So who are these low-risk and younger patients? Well, of course, they're mostly the bicuspid aortic valve patients. And as this case shows here, these can be very, very dangerous valves for TAVR. For us, for SAVR, it really doesn't play a role. Nobody ever even thought to compare bicuspid to tricuspid aortic valve stenosis patients for SAVR in the past, because we never, ever, ever saw that it really made a difference for us until this became an issue within the TAVI literature. So this is such a patient with this massive calcium, with this the horn of, now I've forgotten the word now in English. My English gets worse and worse ever since I've moved to Germany. But this calcified raphe that can puncture into the muscular septum during balloon expansion and can lead to a life-threatening annular rupture. An annular rupture in the fibrous portion of the left ventricular outflow tract, we can fix that as surgeons. An annular rupture into the muscular portion is almost uniformly lethal. And there's also coronary anomalies as well. Paravalvular leak rates, this is a meta-analysis, we know occur more frequently in TAVI bicuspid patients compared to tricuspid patients, TAVI patients. Conversion to surgery also occurs more frequently in bicuspid aortic valve patients than in tricuspid aortic valve patients receiving a TAVI. And device success rates are lower in bicuspid aortic valve than in tricuspid aortic valve TAVI patients. So we have to be a bit careful before we start applying these procedures in younger and lower risk patients. Also because of this reason, a meta-analysis of 10 studies, including 1,600 patients post-TAVI who got a SAVR, the STS predicted risk of mortality rate was high. These were 8.1% is a high-risk population. But when you look at the results are terrible. Half of the patients required concomitant surgery, including aortic repair, which is particularly common after self-expanding valves. And the 30% mortality was actually twice the STS predicted risk of mortality. There is no other operation we do as surgeons that has a higher risk than the STS predicted by twofold. No other operation. And there was no demonstrable interaction effect for endocarditis. So this was independent of endocarditis. So this is something we have to think of before we start routinely applying TAVI in patients under 65 years of age, especially if they're bicuspid. And the final reason I would say that a surgeon still needs to be involved in the TAVI team are the two papers I will present now. One was just recently accepted in JAHA, and that is this multi-center study from several German centers starting 2009 to 2001. You see that conversion to sternotomy, emergency sternotomy in the operating room, so during the TAVI procedure, is an uncommon event. It's only 0.5%, so that's fantastic.
We also excluded those patients that had non-transfemoral access, or those patients that we felt were critical, sort of being done as a last chance, either with shock or after resuscitation or mechanically ventilated. So we ended up with 152 patients who, to everybody's surprise, all of a sudden required an emergency conversion. You would see that these are high-risk patients. They're 80 years of age. Sorry, they have multiple morbidities and tend to be high risk. 63% were high risk, 19% intermediate, and 17% were low risk. Frailty in over half of the patients and multiple other comorbidities, as you can see here. So what happened with these 152 patients? They had to have their sternum opened because of mostly tamponade. These are not mutually exclusive, these indications. But annular rupture also occurred not infrequently, or valve dislocation, and left ventricular perforation also not too infrequently, whereas coronary obstruction tended to be more uncommon. And these were the different surgical techniques that were necessary: aortic valve replacement or complete root replacement Bentall, some sort of repair of the aorta or replacement of the aorta. Sometimes a root enlargement was required, or even an arch replacement, or bypass surgery for those patients with coronary problems, rarely mitral or LVOT patch repair. And the cross-clamp times and cardiopulmonary bypass times were not that long, and 9% of patients did not survive the procedure that were low risk versus 13% which were high risk. And this was one of the arguments in Germany, at least in the initial phases of TAVI, is they said, well, why do we need to have cardiac surgery on site? Anybody who requires immediate cardiac surgery during a TAVI procedure dies anyways. Not true, as you see from this slide. And in-hospital mortality, although much higher, was also, at least for the low to intermediate risk patients, somewhat acceptable at approximately 1/3. And when we looked at their 1-year survival, the low intermediate risk patients that survived the hospital during landmark analysis actually had a very good prognosis. So 94% of those patients were still alive 1 year if they survived the first 30 days. And this is another paper that we've already published in EJCTS, just based on our own experience in Leipzig. 7,000 transfemoral patients, 1.1% needed to be converted, more frequently during the early years of the study, 2006 to 2010, compared to the most recent, 2016 to 2020. The vast majority never required conversion, but like I said, 74 did, 1%. And we found in-hospital mortality and 1-year mortality very respectable, 12.5% for the low to intermediate risk. So as we expand the indications for TAVI and we start doing these procedures in lower risk and younger patients, it's even more important to have a surgeon immediately available in case a disaster occurs. And here's the 1-year survival curve for low intermediate risk versus high risk. So in summary, market progress continues to be made in TAVI technology and outcomes, leading to increased TAVI implantation rates. And the most recent low-risk studies are encouraging, but we need to remember that these studies, first of all, excluded all bicuspid patients, and secondly, the average age was 74 for Evolut and Sapien, Partner, and 79 for Notion. This is miles away from what's happening right now, at least in the United States. And from my point of view, surgeons remain an integral part because of the knowledge exchange that they can contribute to, and also for backup of emergencies, especially in younger and lower risk patients. Thank you very much for your attention.
Thank you very much, Professor Borger. I think you convinced us that how extremely important the role of cardiac surgeons are during the process of patient selection and management for TAVI patients. Regarding patient prosthesis mismatch, I would like to ask you a question. Since we seem to go to lower age groups for TAVI, how do you manage, how do you discuss in your heart team the possibility of avoiding this phenomenon of patient prosthesis mismatch with TAVI? Do you discuss what options there are for the patient regarding
transcatheter versus surgical procedure?
Yeah, it plays a role in our discussions. Obviously, if the patient is at risk of patient-prosthesis mismatch and we're going to do a TAVI, then we use a self-expanding and not a balloon expandable. Having said that, the self-expanding valves, there is some data suggesting that SAVR post-TAVI in those valves is particularly bad, the outcomes, which also makes sense for anatomic reasons. And therefore, you have to keep that in mind if the patient is young enough that they may need a SAVR in the future. There's also the issues of coronary access as well after a self-expanding valve. We don't forget also that for surgery, there are options and there's increasing use of annular enlargement. And even sometimes for really extreme cases with a very small annulus and small root, we do a full root replacement with a special technique that the valve is sitting outside of the heart afterwards in order to really maximize the size of the implanted SAVR valve. Those are all things that we take into consideration.
Thank you. Are there any comments from Dr. Ioannou?
Thank you for the information of a well and especially organized center. I would like to ask you, do you think that the difference in the distance from the guidelines is related with the cost of the operations?
So the disconnect between the guidelines and what's currently happening in the United States, well, I don't want to speculate too much. I don't practice in the United States anymore, but there's obviously some pressure being put on in those environments on the cardiologists and on the surgeons for whatever reason to not be following the guidelines. Financial pressure to me makes the most sense, but I can only speculate. I'm surprised that the funding agencies aren't going after this because to me it's a blatant transgression, so to say, and there's a lot of money that I'm sure the insurance companies and the state would be saving if they started trying to enforce or at least trying to get people more in line with the guidelines. But thus far, I haven't heard anything. It's surprising. I'm watching it from afar with a lot of interest, especially as the co-chair of the next set of European guidelines for valve disease.
Please. Comment?
Dr. Borge, congratulations for your excellent presentation. And our heart team is in agreement with your team more or less, and we participate in difficult decision making if we need to take alternative accesses. And of course, everything is done for the better outcome of the patient. But I have the feeling, as you mentioned at the end, that the industry, different associations, push everything towards the TAVI procedure, despite the guidelines about the low-risk patients. And of course, I would like to ask our colleagues from USA how they accept a patient under 65 years old to half of them to treat it by TAVI, despite the recommendation and the guidelines recommend against that. And this is not very...
It's a great question, and I would like to ask my American colleagues that as well. I don't know the answer to that, especially with the legal environment in the US is a lot more punishing than it is in Europe, a lot more.
Take the microphone, please.
Michael, Mike Reardon, how are you? Great talk. So I'll answer from the U.S. perspective. I think the problem, Michael, is severalfold. First of all, a very distinct minority of cardiologists or cardiac surgeons can really tell you what their low-risk trials did, who they tested, and what the outcomes were. You start asking cardiologists or surgeons how many people were less than 65 in these trials, they can't tell you. How many were less than 70? They can't tell you. Outside of bicuspid valves, they can't tell you who was and wasn't treated. And then all these people, of course, were approved locally, and then they go to a national screening committee, and as you remember, one trial, over a third were turned down there, and the other one, 15% were turned down. So they clearly are not all-comer trials. These were very selected patients because they were protocolized, and then they were further selected. And then you get down to sites that may do 50 cases a year, which is the majority of the sites in the U.S., and there's no surgeon that's really even part of the heart team. And so it's really sad, Michael. I think in the U.S. the problem is non-existence or dysfunction of heart teams in the majority of sites.
So I agree with you totally, Mike, and therefore I'm very happy that the organizers here asked me to speak about this topic today, and this is something that we just have to keep talking about.
Yeah, I think in the U.S., we've written several articles about this, about who wasn't treated, and I think that fortunately we're starting to see this come into the AATS this year, had some structural stuff. I think surgeons need to be better educated so they're not afraid to come into the heart team and voice their opinion, but they need to know the data.
Couldn't agree more.
But a great talk, Michael. Your place does super work.
Thank you.
Thank you. I would like to ask Dr. Dardas and then Dr. Kilic for a comment.
Hello. Congratulations. That was a really excellent talk and put things into a very clear perspective regarding the cooperation between interventionalists and surgeons, and I really enjoyed it. I would like to ask two questions. The first question is, do you pre-plan or pre-select your surgical valve with the mind of this person may need a TAVI procedure in the future? And do you have any special recommendation? What surgical valve would you put? And the second question is, if you have a, say, 70 years old male with very good anatomical features, everything is clear cut, and he can either receive a very good TAVI or either receive a surgical valve, would you recommend on this patient to have a surgical valve or to have a TAVI, say, a Resilia, which they claim that it lasts longer? What would be your opinion on that?
Great question. So for younger patients, especially those with a small annulus, yes, we will use the Inspiris valve in order to facilitate a future valve-in-valve procedure. For patients with a larger annulus or patients that are a bit older, we like the Avalis valve for financial reasons. I work in a center that's owned by a private company, so we always have to be thinking of financial aspects as well. And your second question regarding the 70-year-old who's otherwise healthy, I would definitely suggest a SAVR for that patient, because the reasons that I said before. SAVR post-TAVI results are a catastrophe. We don't know what we're doing with that operation. We have to get better at it. It's the fastest growing operation in the United States, but we need to understand why those patients do so poorly. And TAVI post-TAVI is also not nearly as good as first-time TAVI. So you're basically a 70-year-old who's really healthy. You're expecting that person to have a reasonable chance of outliving the valve, and then you're sort of committing that person to a less optimal solution when they're 80 or 85 years old. And doing a SAVR at 80 or 85, and we do them all the time here post-TAVI for endocarditis or for failed TAVIs because we put in so many TAVIs, you're not doing the patients any favors. I would suggest SAVR first and then plan that patient for a TAVI valve-in-valve later.
Okay, thank you very much.
I
would agree with you.
Thank you. Last question from Dr. Kilic.
Questions? Dr. Berger, first of all, congratulations for your speech. But when we look at the comparison of the TAVI trials and the surgical trials, especially in meta-analysis, we should never also forget that some of the transapical patients were also in that meta-analysis. So as we know that TAVI is superior if transfemoral done. So this is very important point. And the second point that you mentioned in your Leipzig experience, I show that there are a lot of, for example, ventricle rupture during the conversion to the TAVI, to the surgery. So really, we believe that in our institute as a heart team approach, but especially some of the risk scores, when we look at to the SDS, also the Euroscore, in some patients, some indexes are not present in that risk scores, like liver cirrhosis, especially in young patients, previous radiotherapy, and also the emergent valves are also coming from the TAVI perspective. So I think we should look at not only in one eye, but with two-eye perspective for evaluating all the trials.
I would like to respond to you with two eyes, okay? Liver cirrhosis and severe radiation-induced mediastinal changes, we're talking about less than 1% of patients. We're talking about 0.1%, okay? So that, you can't say that that's a common reason for TAVI. That's just not true. Regarding your first comment that the meta-analysis include transapicals, that is true, but also this is a very small minority of the patients. At our center right now, we do about 1% transapical. And you also said TAVI is superior to SAVR. It's not. I'm sorry, it's not. And this is the sort of miseducation that so many people have. Those trials did not show superiority. They showed non-inferiority, or the superiority that they did show was in safety outcomes at 1 year. So if you're talking about a 60-year-old, I don't think we should only be worried about their 1 year outcomes. We need to be thinking about what happens later on. And as for comparison of any transcatheter to surgical procedure, there's worse outcomes for surgery because it's much more invasive. But the effectiveness tends to be better, and that's why the curves start to cross over time, which they did for PARTNER 2, which they've come together for PARTNER 3 for Evolut low risk. They haven't yet crossed, but I'm suspecting that they probably will, but it's just speculation. So please don't say TAVI is superior to SAVR. That's just not true.
There are a lot of points to be discussed, maybe ongoing. Maybe Dr. Reardon, maybe you can give some examples from the...
Year-old, I'm going to pick my surgeon properly. The big mistake people make for young people is picking the wrong surgeon and getting a bad valve. But you know, you get the right valve, you'll do very, very well. You operated me, Michael, I'll be out of the hospital in 4 days, and ask him when I can go back to work. I'm going to see you when I come to Leipzig, though, not one of those other guys.
Hopefully you don't need surgery.
Yeah, I hope not.
Thank you very much.
Thank you. Thanks very much.
We go to Dr. Andritsopoulos. I know that she prefers Greek. Είμαι πολύ χαρούμενος που καλωσορίζουμε τη Βίκη, κυρία Αντρουτσοπούλου, εδώ στο νοσοκομείο μας, όπου έκανε μια πολύ καλή θητεία και δοκιμάζει τις δυνάμεις της σε ένα απομακρυσμένο νοσοκομείο, και αυτό χρειάζεται πολύ μεγαλύτερες ικανότητες για να τα ξεπεράσεις τα προβλήματα όταν δεν έχεις πάρα πολλούς να σε υποστηρίξουν. Περιμένουμε με ενδιαφέρον να μας πει την εμπειρία της από το θέμα που έχει επιλέξει.
Αξιότιμο Προεδρείο, κυρίες και κύριοι συνάδελφοι, και εγώ πραγματικά χαίρομαι που βρίσκομαι πάλι σήμερα στο φιλόξενο χώρο του Υγεία μετά από 5 χρόνια απουσίας. Θα σας μιλήσω για την επιλογή ανάμεσα στην επανεπέμβαση και στην valve-in-valve τεχνική στην περίπτωση της εκφύλισης των βιοπροσθετικών αορτικών βαλβίδων. Δεν υπάρχει σύγκρουση συμφερόντων σε αυτήν εδώ την παρουσίαση. Δεν γυρίζει. Η εκφύλιση των βιοπροσθετικών χειρουργικών βαλβίδων είναι πολυπαραγωγική. Το μηχανικό στρες, η επασβέστωση και η ανοσολογική απάντηση παίζουν σημαντικό ρόλο. Οι βαλβίδες περικαρδίου και οι στηριγμένες βαλβίδες έχουν μια τάση να εμφανίζονται κλινικά με στένωση όταν εκφυλιστούν, ενώ οι χείριες βαλβίδες και οι βαλβίδες οι σούτσρουλες συνήθως εκδηλώνονται με την εμφάνιση ανεπάρκειας. Και το ερώτημα σε αυτές τις περιπτώσεις είναι τι είναι προτιμότερο για τον ασθενή, επανεπέμβαση ή valve-in-valve τεχνική. Το Heart Team θα πρέπει να αποφασίσει ανάλογα με την περίπτωση, συνυπολογίζοντας κάποιες παραμέτρους. Στον πίνακα που παραθέτω, το Heart Team πρέπει να προτιμήσει χειρουργική επανεπέμβαση όταν ο ασθενής είναι χαμηλού ή ενδιάμεσου χειρουργικού κινδύνου, όταν είναι νεότερης ηλικίας, όταν υπάρχει σημαντική παραβαλβιδική διαφυγή που δεν είναι εύκολο να διορθωθεί με διαδερμικό κλείσιμο, όταν ο ασθενής το επιθυμεί. Ενώ η valve-in-valve τεχνική θα πρέπει να προταθεί σε ασθενείς που είναι υψηλού κινδύνου ή απαγορευτικού χειρουργικού κινδύνου και μεγάλης ηλικίας άνω των 80 ετών. Όμως δεν είναι οι μόνοι παράμετροι που λαμβάνονται υπόψη. Πρέπει να λαμβάνεται και το είδος της χειρουργικής βαλβίδας που έχει προηγουμένως εμφυτευτεί και ανατομικά χαρακτηριστικά. Και έτσι, σε αυτή την περίπτωση, χειρουργική επανεπέμβαση προτείνεται στις μικρές χειρουργικές βαλβίδες που έχουν σοβαρό PPM προεγχειρητικά και σε εκείνες τις βαλβίδες που δεν υπάρχει δυνατότητα να γίνει κάταγμα του σκελετού της βαλβίδας ώστε να εμφυτευτεί μεγαλύτερο μέγεθος διακαυτηριακής βαλβίδας. Επίσης, στους ασθενείς που έχουν υψηλό κίνδυνο για απόφραξη των στεφανίων κατά την διενέργεια της valve-in-valve τεχνικής, υψηλό κίνδυνο για μετακίνηση της συσκευής, υψηλό κίνδυνο για ρήξη του αορτικού δακτυλίου, σε όλες αυτές τις περιπτώσεις προτιμάμε τη χειρουργική επανεπέμβαση. Ενώ η valve-in-valve τεχνική ενδείκνυται σε μεγάλο μέγεθος χειρουργικής βαλβίδας που δεν έχει σοβαρό PPM ή σε εκείνες τις χειρουργικές βαλβίδες που είναι κατάλληλες για σπάσιμο του σκελετού τους. Ενώ όταν η ανατομία των στεφανίων επιτρέπει, είναι δυνατόν να προτιμηθεί η valve-in-valve τεχνική. Η διακαθητηριακή εμφύτευση θεωρούμε ότι είναι λιγότερο επεμβατική, όμως και εδώ υπάρχουν προβλήματα σοβαρά. Μία από τις πιθανές επιπλοκές είναι η απόφραξη των στεφανίων κατά τη διενέργεια της valve-in-valve τεχνικής, το PPM και τα υψηλότερα ποσοστά κακής τοποθέτησης της βαλβίδας. Οι στηριγμένες βαλβίδες, όπως βλέπετε στον πίνακα εδώ δίπλα, λόγω ακριβώς της ύπαρξης του σκελετού της χειρουργικής βαλβίδας, έχουν μικρότερη πιθανότητα να εμφανίσουν, όταν τοποθετηθεί valve-in-valve τεχνική, παραβαλβιδική διαφυγή, ρήξη του αορτικού δακτυλίου και διαταραχές της αγωγημότητας. Όμως, όταν γίνει valve-in-valve σε στηριγμένη χειρουργική βαλβίδα, δυστυχώς, τα μετεπεμβατικά διαβαλβιδικά gradient είναι εξαιρετικά υψηλά. Υψηλός είναι ο κίνδυνος θρόμβωσης της βαλβίδας και υψηλός είναι και ο κίνδυνος απόφραξης των στεφανιαίων. Αν χρησιμοποιηθεί βαλβίδα αστήριχτη, δηλαδή βαλβίδα που δεν έχει σκελετό, τότε ναι μεν τα μετεπεμβατικά διαβαλβιδικά gradient είναι χαμηλά και η πιθανότητα θρόμβωσης της βαλβίδας είναι χαμηλή, όμως είναι εξαιρετικά υψηλός ο κίνδυνος απόφραξης των στεφανιαίων και μεγάλη η πιθανότητα κακής τοποθέτησης της βαλβίδας, παραβαλβιδικής διαφυγής ή και ρήξης του αορτικού δακτυλίου. Η αχίλιος πτέρνα της valve-in-valve τεχνικής σε μία εκφυλισμένη βιοπροσθετική βαλβίδα χειρουργική είναι τα υψηλά μετεπεμβατικά διαβαλβιδικά gradient. Και πότε συμβαίνει αυτό? Όταν η στένος είναι ο βασικός μηχανισμός εκφύλισης της χειρουργικής βαλβίδας, όταν προϋπάρχει σοβαρό PPM, όταν η χειρουργική βαλβίδα είναι στηριγμένη και όταν η διάμετρος της χειρουργικής βαλβίδας είναι μικρότερη ή ίση των 21 mm. Επίσης, αν η διακαυτηριακή βαλβίδα τοποθετηθεί intra-annular ή σε μεγάλο βάθος και όταν δεν υπάρχει δυνατότητα για να γίνει κάταγμα του σκελετού της χειρουργικής βαλβίδας. Σύμφωνα με τα αποτελέσματα του Vivid Registry, οι μικρές χειρουργικές βαλβίδες, δηλαδή εκείνες που είναι ίσες ή μικρότερες των 21 mm, έχουν πιθανότητα στο τέλος του πρώτου χρόνου για θάνατο που αγγίζει το 25%. Ενώ αν η χειρουργική βαλβίδα είναι μεγάλη, το αντίστοιχο ποσοστό δεν υπερβαίνει το 6,7%. Και όταν μιλάμε για χειρουργικές βαλβίδες και για μεγέθη, θα πρέπει να λάβουμε υπόψη ότι πολλές φορές ίδιου μεγέθους χειρουργικές βαλβίδες που έχουν κατασκευαστεί από διαφορετικές εταιρείες δεν ανταποκρίνονται στην ίδια εσωτερική διάμετρο της βαλβίδας, ούτε και το μέγεθος της βαλβίδας στο κατασκευαστικό αντιπροσωπεύει τις ακριβείς εσωτερικές διαστάσεις της πρόσθεσης. Και δεν είναι φυσικά όλες οι στηριγμένες βαλβίδες κατάλληλες για κάταγμα του σκελετού τους. Εδώ ας σημειωθεί ότι εξαιρετικά καλά αποτελέσματα για valve-in-valve τεχνική έχει μια βαλβίδα χειρουργική Resilient Spears που κυκλοφορεί εδώ και 7 με 8 χρόνια και η οποία έχει τη δυνατότητα ελεγχόμενα κατά τη διάρκεια της valve-in-valve τεχνικής να σπάσει στη θέση των 3 κομισούρων και να εφυτευτεί μεγαλύτερο μέγεθος διακαυτηριακής βαλβίδας ώστε να αποφευχθεί μετεπεμβατικό PPM. Ένα άλλο σημαντικό θέμα που μπορεί να συμβεί κατά τη διάρκεια της διακαυτηριακής εμφύτευσης πάνω σε χειρουργική εκφυλισμένη βαλβίδα είναι η απόφραξη των στεφανιαίων. Τώρα τελευταία, εμείς οι χειρουργοί προτιμούμε εμφύτευση των βαλβίδων σε supraannular θέση με σκοπό να αποφύγουμε το PPM. Όμως σε αυτές τις περιπτώσεις αυξάνεται η πιθανότητα απόφραξης των στεφανιαίων, όπως επίσης και μερικές χειρουργικές βαλβίδες όπως η Trifecta και η Matro Flow που έχουν αποσυρθεί βέβαια, αλλά εκφυλίζονται γρήγορα και γι' αυτό χρειάζονται εμφύτευση valve-in-valve κάποιες φορές, έχουν τέτοια διαμόρφωση που αυξάνουν δυστυχώς τον κίνδυνο απόφραξης του στεφανιαίου. Όμως το πρόβλημα δεν λύνεται μόλις τελειώσει η επέμβαση. Οι ασθενείς που έχουν valve-in-valve βαλβίδα μπορεί σε δεύτερο χρόνο, μετά από κάποια χρόνια, όταν εμφανίσουν ένα οξύ στεφανιαίο σύνδρομο ή κλινική εικόνα στιθάγχης, να χρειαστεί να καθητριαστούν και τότε μπορεί να υπάρξουν δυσκολίες. Οι δυσκολίες εξαρτώνται από το ύψος και τη θέση των στεφανιαίων, των στομίων των στεφανιαίων, από τον τύπο της χειρουργικής βαλβίδας, από το ύψος της εμφύτευσης, από τις διαστάσεις της κολποσωληνώδους συμβολής και από το είδος της διακαυτηριακής βαλβίδας που έχει εμφυτευθεί. Αν είναι χαμηλού ή υψηλού προφίλ, αν έχει γίνει ευθιασμός των κομισούρων μεταξύ της διακαυτηριακής βαλβίδας και της χειρουργικής βαλβίδας. Και σύμφωνα με μια πρόσφατη δημοσίευση, φαίνεται ότι υψηλότερου κινδύνου για δυσκολία στο άξις των στεφανιαίων μετά από μια valve εμφύτευση υπάρχουν όταν τα στόμια των στεφανιαίων εκφύονται χαμηλά, όταν οι διαστάσεις της αορτικής ρίζας είναι μικρές, αν η αρχική χειρουργική βαλβίδα ήταν αστήριχτη ή αν ήταν supraannular ή στηριγμένη, όπως είδαμε προηγουμένως, Mitral Flow ή Trifecta. Και εδώ, πριν από 4 μήνες, δημοσιεύτηκαν τα αποτελέσματα της TAVI-SMALL-2 μελέτης, όπου αφορά ειδικά τους μικρούς αορτικούς δακτυλίους και φαίνεται ότι ήδη από το follow-up του πρώτου χρόνου, οι ασθενείς που είχαν σοβαρό PPM εμφάνισαν υψηλή θνησιμότητα από κάθε αιτία. Και δεν είναι η μόνη μελέτη. 5 μήνες πριν και λίγο παραπάνω, τον Νοέμβριο φέτος, η μελέτη αυτή σε 2.000 ασθενείς επιβεβαιώνει ότι σοβαρό PPM συνοδεύεται όχι μόνο από αυξημένο κίνδυνο θανάτου από κάθε αιτία, αλλά και από θρόμβος της βαλβίδας και από αυξημένο κίνδυνο πρώιμης εκφύλισής της. Ενώ, αν εμφυτευτεί supraannular βαλβίδα διακαθητηριακά σε έδαφος μιας εκφυλισμένης χειρουργικής βαλβίδας, ο κίνδυνος για σοβαρό PPM μεταπεμβατικά δυστυχώς φτάνει το ποσοστό του 39%. Ενώ το μέτριο PPM αντιστοιχεί σε ποσοστό 29%. Τα ποσοστά αυτά είναι εξαιρετικά υψηλά. Χωρίς αμφιβολία, αν κατέστη δυνατό να γίνει σπάσιμο του δακτυλίου της χειρουργικής βαλβίδας, είναι επόμενο ότι τα διαβαλβιδικά gradient θα είναι μετά χαμηλότερα. Και είναι καλό αυτό να διενεργείται μετά την τοποθέτηση της διακαθητηριακής βαλβίδας, καθώς έτσι εξασφαλίζονται καλύτερο αιμοδυναμικό αποτέλεσμα και λιγότερες επιπλοκές, παρά αν προηγηθεί. Σύμφωνα με αυτά τα αποτελέσματα που δημοσιεύτηκαν πέρσι από αυτό το registry, φαίνεται ότι στο τέλος του πρώτου χρόνου, μετά από τη valve-in-valve εμφύτευση μιας διακαυτηριακής βαλβίδας, η θνησιμότητα υπερβαίνει το 10%. Ενώ σε αυτή τη μετανάλυση που συγκρίνει τη χειρουργική επανεπέμβαση με τη διακαυτηριακή εμφύτευση σε σύνολο 8.500 ασθενείς, διαπιστώνουμε ότι στους ασθενείς που υποβλήθηκαν σε επανεπέμβαση, τα διαβαλβιδικά gradient ήταν αισθητά χαμηλότερα, ενώ οι ασθενείς που υποβλήθηκαν σε valve-in-valve τεχνική είχαν λιγότερη αιμορραγία, λιγότερα εγκεφαλικά και λιγότερη θνησιμότητα 30 ημερών. Άλλη μία μεταανάλυση και ανασκόπηση σε 594 ασθενείς επιβεβαιώνει ότι με τη valve-in-valve τεχνική ο κίνδυνος για εμφύτευση βηματοδότη είναι χαμηλός, αλλά όμως ο κίνδυνος για εμφάνιση παραβαλβιδικών διαφυγών είναι υψηλός. Και με τη valve-in-valve τεχνική έχουμε χαμηλότερη πιθανότητα εμφάνισης οξείας νεφρικής ανεπάρκειας μετεπεμβατικά και χαμηλότερα ποσοστά νεφρικής αναγκαιότητας για νεφρική υποκατάσταση. Σύμφωνα με μία μετανάλυση πέρυσι το Γενάρη, πολύ σημαντική, σε 3.300 ασθενείς, επιβεβαιώθηκε το εξής, ότι ναι μεν η valve-in-valve τεχνική εξασφαλίζει όφελος επιβίωσης στους ασθενείς για τους πρώτους 6 μήνες, μετά όμως από τους 6 μήνες αυτούς το όφελος αυτό εξαφανίζεται. Και φαίνεται ότι πλέον η χειρουργική επανεπέμβαση μετά το εξάμηνο εξασφαλίζει καλύτερη επιβίωση στους ασθενείς μας. Ενώ, άλλο ένα νέο δεδομένο, πάλι από μια άλλη καινούργια μετανάλυση, με 6.700 ασθενείς, επιβεβαιώνει ότι οι ασθενείς με valve-in-valve τεχνική είχαν ναι μεν χαμηλότερη ενδονοσοκομιακή θνησιμότητα, αλλά περισσότερες επανεισαγωγές, τόσο στο τέλος του πρώτου μήνα, όσο και στο τέλος του εξαμήνου. Και επίσης, οι ασθενείς με valve-in-valve τεχνική 5 φορές περισσότερες επανεπεμβάσεις στην αορτική βαλβίδα, παρά αν έχουν υποβληθεί σε valve-in-valve, παρά αν έχουν υποβληθεί σε χειρουργική αντικατάσταση. Και ας δούμε λίγο και την χειρουργική επανεπέμβαση. Σύμφωνα με μια δημοσίευση πρόσφατη από το Αττικό, χωρίς αμφιβολία, η valve-in-valve τεχνική είναι μια εναλλακτική θεραπεία για εκφυλισμένες χειρουργικές βαλβίδες σε ασθενείς μεγάλης ηλικίας, υψηλού κινδύνου και σε ευάλωτους ασθενείς με συνοσηρότητες. Όμως η χειρουργική αντικατάσταση πρέπει να είναι η επέμβαση εκλογής σε νέους ασθενείς χαμηλού χειρουργικού κινδύνου, με μεγάλο προσδόκιμο επιβίωσης, ειδικά σε εκείνους που έχουν πάρει μικρού μεγέθους χειρουργική βιοπρόσθεση, η οποία είτε δεν έχει τη δυνατότητα να εκτίσεται όπως η Inspiris, είτε δεν υπάρχει δυνατότητα να εφαρμοστεί σε αυτήν κάταγμα του σκελετούς της. Και επίσης έχουν ένδειξη εφόσον μια επέμβαση valve-in-valve θα ήταν υψηλού κινδύνου για απόφραξη των στεφανίων, τόσο κατά τη διάρκεια της επέμβασης, όσο και σε δεύτερο χρόνο για δυσκολία στον καθετηριασμό τους. Άλλη μια μετανάλυση, πριν από ένα χρόνο, 6.500 ασθενείς συνολικά, και ναι, χωρίς αμφιβολία, η χειρουργική επανεπέμβαση σχετίζεται με περισσότερες μεταγγίσεις, γιατί η πιθανότητα αιμορραγίας είναι μεγαλύτερη, με συχνότερη εμφάνιση μετεπεμβατικής νεφρικής ανεπάρκειας και με μεγαλύτερα ποσοστά εμφύτευσης βηματοδότης συγκριτικά με τη valve-in-valve τεχνική. Όμως, οι ασθενείς που υποβλήθηκαν σε χειρουργική επανεπέμβαση σταθερά έχουν χαμηλότερα διαβαλβιδικά gradient και μεγαλύτερη ελευθερία από επανεισαγωγές που έχουν σαν αιτία την καρδιακή ανεπάρκεια. Άλλη μια μεγάλη μελέτη δημοσιεύτηκε φέτος το Φεβρουάριο σε 6.800 ασθενείς και τα αποτελέσματα είναι πραγματικά εντυπωσιακά. Όφελος επιβίωσης με τη valve-in-valve μόνο για τους πρώτους 6 μήνες. Από εκεί και μετά ωφελούνται οι ασθενείς όσον αφορά στην επιβίωσή τους μόνο εκείνοι που έχουν κάνει χειρουργική επανεπέμβαση. Από την ίδια μελέτη, με τη valve-in-valve τεχνική, υψηλότερες επανεισαγωγές και στις 30 μέρες, αλλά και στους 6 μήνες μετά την επέμβαση, συγκριτικά με τη χειρουργική. Πριν από ένα μήνα δημοσίευση για τα αποτελέσματα της χειρουργικής επανεπέμβασης, θνησιμότητα 4,6%. Αν αφαιρέσουμε τα ποσοστά της ενδοκαρδίτιδας, διεγχειρητική θνησιμότητα πέφτει στο 2,5%. Το ποσοστό είναι εξαιρετικά χαμηλό. Και άλλη μια πρόσφατη δημοσίευση. Εμείς οι χειρουργοί έχουμε στη φαρέτρα μας κενές βαλβίδες, όπως αυτές εδώ οι σούτσουρλες βαλβίδες, οι οποίες μας επιτρέπουν να πραγματοποιούμε την επέμβαση σε μικρότερο χρόνο, με χαμηλότερους χρόνους αποκλεισμού της αορτής και εξωσωματικής κυκλοφορίας και με ικανοποιητικά αποτελέσματα ακόμα και σε ασθενείς ψηλού κινδύνου. Και τελειώνω με αυτήν εδώ τη διαφάνεια. Μετανάλυση σε 8.800 ασθενείς, όπου επιβεβαιώνει για άλλη μια φορά ότι δεν υπάρχει διαφορά στην θνησιμότητα μεταξύ της χειρουργικής επανεπέμβασης και της valve-in-valve τεχνικής μεσοπρόθεσμα. Τα αντίστοιχα ποσοστά, τα περιεπεμβατικά, είναι 2,8% για την valve-in-valve έναντι 5% για τη χειρουργική μέθοδο. Και ναι, οι προσθετικές βαλβίδες έχουν σχεδόν πάντοτε υψηλότερα ποσοστά σοβαρού PPM, υψηλότερα ποσοστά παραβαλβιδικής ανεπάρκειας, σταθερά υψηλότερα διαβαλβιδικά gradient, ενώ φαίνεται, σύμφωνα με αυτή τη μελέτη, ότι δεν υπάρχει στατιστικό σημαντική διαφορά στα αγκιακά εγκεφαλικά επεισόδια, στις εμφυτεύσεις βηματοδότη και στα εμφράγματα του μυοκαρδίου. Και θα ήθελα να σας ευχαριστήσω κλείνοντας με την φωτογραφία του ομότιμου καθηγητή καρδιοχειρουργικής του Πανεπιστημίου Θράκης, του Γεώργιου Μπουγιούκα, ο οποίος δυστυχώς απεβίασε πριν από 2-24 ώρα. Ήταν ο ιδρυτής και θεμελιωτής της καρδιοχειρουργικής κλινικής στην Αλεξανδρούπολη, στην οποία εργάζομαι αυτή τη στιγμή. Ευχαριστώ.
Ευχαριστούμε πάρα πολύ, κυρία Ανδρουτσοπούλου, και ένας έπαινος για το σεβασμό στους δασκάλους, τον οποίο πάντοτε οφείλουμε να κάνουμε. Είχαμε πάρα πολλές πληροφορίες από εργασίες. Η ερώτηση που ήθελα να σας κάνω, στο κέντρο σας λειτουργείται ομάδα καρδιάς? Οι αποφάσεις παίρνονται από ομάδα ή ο ασθενής πάει κατευθείαν στον καρδιοχειρουργό ή στον καρδιολόγο για την επέμβασή του?
Έχουμε hard team, αλλά όπως ξέρετε δεν δουλεύουν πάντοτε τα hard team όπως θα έπρεπε να δουλεύουν. Τον πρώτο λόγο συνήθως έχει ο γιατρός, στον οποίο απευθύνεται πρώτα ο ασθενής και ο οποίος παίρνει τελικά και την απόφαση, αν είναι κατάλληλος για χειρουργείο ή όχι. Πάντα συζητάμε με τους καρδιολόγους μας, αλλά τον πρώτο λόγο έχει ο αρχικός γιατρός που θα δει έναν άρρωστο.
Νομίζω και εδώ η πρακτική και η εμπειρία μας περίπου ίδια είναι. Δεν ξέρω αν οι συνάδελφοι θέλουν κάποια ερώτηση. Ναι. Ο κύριος Δάρτας, ναι.
Συγχαρητήρια για την ομιλία σας. Θα συμφωνήσω σε κάποια από αυτά τα οποία είπατε. Δηλαδή υπάρχουν ασθενείς για valve-in-valve που έχουν μη καλά προγνωστικά ανατομικά χαρακτηριστικά. Δηλαδή χαμηλή έκφυση στεφανιαίων, υπάρχει κίνδυνος απόφραξης, υπάρχει πιθανότητα υψηλού gradient, βαλβίδες που δεν σπάνε, είναι μικρές ή χειρουργικές. Παρ' όλα αυτά, την εμπειρία που έχουμε πλέον τόσων ετών που ασχολούμαστε με τη στάβη, οι ασθενείς οι οποίοι έρχονται με μια failed βιοπροσθετική βαλβίδα, συνήθως είναι ασθενείς σε κακή κατάσταση, δηλαδή είναι ασθενείς υψηλού ούτως ή άλλως χειρουργικού κινδύνου. Και ναι, συμφωνώ ότι αν δεν υπάρχουν τα κατάλληλα ανατομικά κριτήρια και αν τα ανατομικά κριτήρια είναι δυσμενή για τάβη, θα συστήσουμε επανεπέμβαση, αλλά συνήθως δεν είναι. Συνήθως οι ασθενείς αυτοί είναι πολύ βαριά. Δηλαδή η κλινική τους εικόνα είναι τέτοια που μας οδηγεί στο να ψάξουμε να βρούμε εάν μπορούμε να εξαντλήσουμε μάλλον τα περιθώρια να κάνουμε τάβη και να χρησιμοποιήσουμε την επανεπέμβαση μόνο σε ασθενείς που έχουν πολύ κακά ανατομικά χαρακτηριστικά.
Θα ήθελα να κάνω ένα μικρό σχόλιο εδώ, καθώς τα ηλικιακά όρια για την εμφύτευση βιολογικών βαλβίδων διαρκώς και κατεβαίνουν. Σύντομα θα έχουμε να αντιμετωπίσουμε ασθενείς που έχουν εκφυλισμένη βιοπροσθετική βαλβίδα και δεν ανήκουν σε αυτή την κατηγορία. Θα είναι και νεότεροι.
Δεν διαφωνώ σε αυτό, αλλά από την εμπειρία μας η πλειονότητα των ασθενών που έρχονται και κυρίως, ξέρετε, κάποιες βιοπροσθετικές που κάνουν γρήγορη εκφύλιση, κάνουν ανεπάρκειες, ιδίως οι ανεπάρκειες, έρχονται σε πολύ κακή κατάσταση. Δηλαδή, αν αυτούς τους ασθενείς οδηγήσει σε επανεπέμβαση, το ρίσκο είναι πολύ μεγάλο και αυτό είναι κάτι που πρέπει οπωσδήποτε να το λαμβάνουμε υπόψη μας.
Ωραία, ευχαριστώ.
Ευχαριστούμε πολύ, κυρία Ανδρουτσοπούλου.
Next speaker is Dr. Kilik. He's a professor, director of structural heart intervention at the Kocaeli University School of Medicine in Turkey. He's going to give a talk on a difficult topic.
Yeah. Thank you very much. First of all, I want to thank you very much to Dr. Spargis and Dr. Patakos for their kind invitation, and on behalf of Turkish Working Group of Interventional Cardiology, I bring all my greetings from our executive board to our friends, Greek friends. So a lot of things are discussed before, but I will try to make a short presentation. A lot of procedures we know that were done with old generation valves, and we have got important lessons learned from the old generation devices. One important lesson is, yes, TAVI is a revolution therapy in the elderly and high-risk patients with severe aortic stenosis. So all the studies show that in high-risk patients, TAVI is superior to surgery. I can say this, in patients with high risk. But the survival benefit was only found with transfemoral femoral TAVI and appeared more pronounced in women than in men. And so we have got important lessons learned from the old generation devices that TAVI is also not an innocent procedure. There are some procedural complications: annulus rupture, coronary occlusion, ventricular rupture, device embolization, and early periprocedural complications, paravalvular leak, pacemaker, vascular complications, stroke, early valve thrombosis, and during the follow-up, the durability is also an important issue. But when we look at also to the risk scoring systems for TAVI, everybody knows STS, Euroscore, and Logistic Euroscore, but fragility is not indexed in this score. And chest deformity, malnutrition, porcelain aorta, liver disease, previous radiotherapy. So I think a specific TAVI score must be done before the evaluation of these patients. When we look also the randomized clinical trials, mean age is actually at 80. And limitations of risk scores. Let's look at this example. 85 years old man, severe aortic stenosis, no risk factors. We all know that STSF score is 1 point, and this patient go to TAVI in many centers. In real practice, what we understand from low risk, old and young patients. So what is the limitations of surgery in patients with older age with low risk? Actually, I didn't bring the meta-analysis to this presentation, but you can find all these meta-analysis from the literature. So limitations of surgery in old and low risk patient, there are some procedural limitations. 1, duration of hospitalization. 2, cost effectivity and risk of heart development of heart failure. And early periprocedural, new onset atrial fibrillation, bleeding and renal failure, and follow-up patient prosthesis mismatch. We all discussed in the morning. But limitations of TAVI in young patients, I underlined again, annulus rupture, risk of coronary occlusion, risk of ventricular rupture, device embolization, and also during follow-up, coronary reaccess, durability and valve-in-valve TAVI. And we never forget that. Bicuspid aorta and aortopathy in these patients, because a lot of a lot of randomized clinical trials, these patients were excluded from the studies, patients with bicuspid aorta. So when we look into the studies, which is compared to the TAVI versus surgical aortic valvuloplasties, when you look at the risk scores, yes, TAVI is superior, but when the risk score decreases, TAVI is equal to the surgery. It seems equal. So there is a tendency now to do TAVI in young and low-risk patients. But anatomy must be transfemoral. And paravalvular leak mild, okay, we don't know. We don't know that. We know left bundle branch block or pacemaker benign, prosthesis patient mismatch matter, and coronary access for coronary artery disease straightforward, and lifetime management of aortic valve disease very important. So what is important if we will TAVI to low risk and younger patients? Safety is deferred. We must end the procedure with 0 stroke, 0 complications, and early recovery with no long-term adverse events, and lifetime management very important, good hemodynamic results, durability, and providing the ability to perform redo-TAVI in these patients. So I will only speak about 2 randomized trials, about their 5-year clinical and echocardiographic outcomes. As you see, one is the partner 3 study, 1-1 to randomization study, and primary at one endpoint at 1 year was composite of all-cause death, all stroke or rehospitalization, and 91% of patients available for primary endpoint analyzed at 5 years, and these 5 years show that TAVI in low-risk patient, the endpoints are lower than surgery. So this is a very important result of this study. When we look at the cardiovascular death rates were similar. And additional clinical endpoints are very important. New onset atrial fibrillation is higher in surgery and serious bleeding is higher in surgery. Valve thrombosis is an important issue, especially in TAVI patients, so we must be careful about reduced leaflet motioning and hypoattenuated leaflet motion. And the early experience of our surgeons that when they put a bioprosthetic valve in a patient, sometimes among high-risk patients, they give, anticoagulation. Maybe NOAC will be an issue in this kind of patients. And the mean gradients of the balloon expandable valve was not superior to surgery, similar, but Mr. Reardon is here and he will explain maybe the other results of the Evolutar study also. So main results, both TAVI and surgery were associated with similar and low clinical event rates. Difference in the primary composite endpoint rate, which favored TAVI at 1 year, were attenuated after 5 years. But other important endpoints were either similar for both therapies, favored TAVI, especially for new onset atrial fibrillation and serious bleeding, and favored surgery for mild paravalvular leak and valve thrombosis. So the Evolute Low Risk Trial, 4-year outcomes, when we look, it's designed as a real-world trial where each site's heart team determine patient risks and minimize exclusions after consult. So when we look at only 23 of patients were below 70 years of age, but this trial also showed significantly better mean gradient and effective orifice area and index effective orifice area with Evolute TAVI at all follow-up time points. And 26% relative reduction in hazard for dead or disabled stroke with Evolute TAVI versus surgical aortic valve replacements here. All-cause mortality was better in TAVI group and significantly less mean gradient and severe patient prosthesis with Evolute TAVI versus surgical aortic valve replacements. So what are now hot topics in 2021? One is the commissural alignment for coronary access and the coming new generation valves. I will speak a little bit about these points. Why is commissural alignment important in TAVI? Tendency to do TAVI in younger population, appropriate implantation technique will allow future coronary access. So commissural alignment may reduce risk of acute coronary obstruction during TAVI and especially in valve TAVI procedures. Increase likelihood of redo TAVI by reducing risk of sinus sequestration and coronary obstruction. May have a long-term impact on durability because increased halt or gradient with misalignment. Basilica is not feasible if commissural post phases to coronary osteums, and all valve manufacturers are now focusing on this topic. So what are the new generation systems? MyValve is a real game changer in balloon expandable valve technology with intermediate and extra large sizes. And octacore is much more superior game changer because of its very important foreshortening property. And commissural alignment will be accurately done with the octaline technique. And the next generation Evolute FX is very, very important because of this much more flexible delivery system, and radiopaque markers provide a reference for deployment depth and commissural location. And Allegra will be very good option for the valve-in-valve procedures. And Portico Navitor will be very important about increased sealing zone and reducing for paravalvular leaks. And Duraver is the next generation balloon expandable valve with large cells and a good commissural alignment and very low gradients. And Gene valve for pure aortic regurgitation, G valve for pure aortic regurgitation, but because of their inadequate corresponding annulus diameter size, maybe larger sizes are required. But for the pure aortic regurgitation, MyValve Transcatheter half valve series X large are very, very important 30.5 millimeter and 32 millimeter and 35 millimeter valve is coming. And Scalia TAVI system is a new TAVI system, is a polymer valve and ultra long lifespan. The polymer valve has a lifespan of 25 years, a significant increase over the 10-year lifespan of traditional interventional bioprosthetic valves. This means very long-term durability. Here is an example of a Scalia system with type 1 bicuspid anatomy. And Vienna aortic valve is coming with different sizes. And tubercular optimum valve is the lowest self-expandable valve height and allows full access to the coronary artery disease and reduce risks of conduction disturbances and intra-ulnar leaflets and designed for valve-in-valve implantation. So I want to give also an example to you about a young patient, 55 years old, male with chronic aortic regurgitation. She was admitted to different clinics before and severe heart failure was diagnosed and has been follow-up severe heart failure due to chronic aortic regurgitation. Ejection fraction was calculated as 5 to 10%, and patient also discussed to be a candidate for heart transplantation and referred to our center for a possible TAVI. When we look at the area was measured as over 600 and 667.3 millimeters, as you see. Femorals are okay. But when we decided to use an extra large size of MyVal in this patient, so we should never forget that ideal valve sizing may be in the range of 5, 10 or 15% higher than the area derived annulus diameter to have a good valve opposition. So this is the importance of the intermediate and extra large size, and I am sure that new balloon expandable valve also will do the same with intermediate size and extra large sizes. So we decided to put a 32 millimeter valve, as you see here. You can see the initial valve position in annulus and dog bone appearance of the balloon and the valve. And the final aortography showed no regurgitation. So this patient recovered very, very quickly after 3 months. Ejection fraction was completely increased. You can see the post-procedural transthoracic echocardiography. And the final femoral arteriography showed, but at the end of the procedure, we show complete AV block also, then we put a CRT to the patients. So what are the home messages? Current TAVI devices are not designed to achieve commissural alignment, but newer technologies, especially MyVal octa-core, Evolut FX, Safian X4, and Duraver are coming. And most important changes are observed in the delivery systems and valve designs of novel technologies to facilitate commissural alignment for future coronary access. Although new systems are developing for TAVI for pure aortic regurgitation, sizing problem is still an important issue, and novel devices with X large size have important advantages. New generation octa-core, Duraver, Evolut FX, Scalia, and tubercular TAVI devices will be future stars of the treatment of aortic stenosis, especially in low and young risk patients. Thank you very much for your attention.
Congratulations, Dr. Kielik. Dr. Iano wants a short comment.
Congratulations. Let me tell you that as a clinical cardiologist, when I heard all these types of valves, I felt like somebody who is in a very expensive restaurant with a list that knows no one and cannot collect the type of wine to match with his meal. So we depend completely on the doctor who is doing the procedure.
It's true, but much more valve means much more food, and it will automatically decrease the price of the meal. So these technologies are coming, and we should follow up all these technologies, especially if we want to do TAVI relatively younger population. I fully agree. For example, in our country, we are definitely following the recommendation of the European Society of Guidelines for the age limit. 75 is a good limit. Maybe 65 in the American Society of Cardiology Guidelines should be discussed in our countries. But when we look at the ACC guidelines also carefully, why 65 years old? Because of the inability of the current risk scores to find the exact risky patients. So that kind of patients are present in the real world practice also. And also new technologies and new studies are coming.
Thank you.
We will follow up.
Thank you.
Thank you very much.
Dr. Dardas.
Yes, congratulations, an excellent talk. It reinforces the idea is not only the age, it's the whole spectrum. We have to see the patient with all the problems. I saw with interest this last case you showed with severe AR and low ejection fraction, and we had a similar patient with severe AR after a failed Ross operation. It's a relatively young patient with an ejection fraction of 10%, and nobody would touch her, no surgeon would touch her, and we did TAVI despite of the young age. She did very well. Now she has an ejection fraction of more than 50%. So we need to individualize and not only to see the age of the patient.
Yes.
Congratulations.
Thank you.
Bear in mind, they add to the age in America that less than 65 are going to live 20 years or more. And the average life expectancy for a woman in the U.S. right now is about 86, 87. For a man, it's about 83, 84. So if you add 20 years to 65, I think that's how they got there. So they're really, age is nothing but a surrogate for how long you should live. You know, if you're 65 and we don't think you're going to live 10 years, it doesn't matter what your age is. It's how long are you going to live. And it's just a surrogate for survivability.
Yeah, very important point. Thank you.
Thank you very much.
Thank you.
I would like to move ahead and call for the next last topic, Dr. Gregory Patakos, who is going to talk to us about this very important subject, TAVI or SAVR for the small aortic annulus. Dr. Patakos.
Perfect. Thank you very much. It's very difficult to follow such good talks. I'll try and impress everybody by making my talk short. I think at this hour of the day, that's the best you can do for a talk, because always the most interesting part is the conversation at the end. I think we should all remember that the person who likes to talk the most is always the speaker. So our outline, why is SAVR preferred for small annuli? I think we should look at the harms of patient prosthesis mismatch, how aortic root enlargement can avoid this, discuss which situations we should perform aortic root enlargement in, how do we perform the procedure, is this procedure safe, and what are the implications for a future valve-in-valve? So what's the problem with the small annulus? Size matters. Having grown up in Washington, D.C., I like this photo of the Bullets, Washington Bullets. They're now called the Washington Wizards. They had the tallest player and the shortest player in the NBA. All right, so nobody wants patient prosthesis mismatch. We look at this, everybody knows to look at the EOA over the BSA, and we see all the bad outcomes. And the valve companies all know this too, right? This is a brochure from a company, right? Looking what are the negative clinical effects of PPM, decreased post-op cardiac index, decreased late survival, the list goes on and on. These are all things that we don't want our patients to have. So we have sizing charts, and we look at them. I look at this frequently to see, you know, what size valve does my patient need? And we don't want to be anywhere near being borderline, so we want 1 or 2 valve sizes above what's going to get us in the green zone. And so most patients will do well with a relatively smaller valve until you start getting to a BSA of about 2.2. So what does a BSA of 2.2 look like? I think it's important for all of us to do the math. And when the patient walks in the door, we know who's going to be at risk for PPM, right? We have especially females, smaller body habitus, extra kilos, 100 kilograms, 175 centimeters tall, or 110 kilograms, 155 centimeters tall. And I did a case like this about 2 weeks ago. So when you see a patient whose body type is more along the cube size, then you need to be aware. So this is the outcomes of replacement with the Edwards Magnum valve, 19 millimeter valve in 447 patients. 54 of them received the 19 millimeter valve, and mean follow-up of 4.9 years, maximum 15.4 years. Echo data available pre and post. And when we look at this, we know that the 19 millimeter valve had slightly higher gradient and more patient prosthesis mismatch. However, in this study at least, there was no difference in overall survival, cardiac-related mortality, or MACE. Now, that's not saying that we should go and implant 19 millimeter valves in everybody, because we know that from multiple prior studies, patients have worse outcomes when they have PPM, either after SAVR, after TAVI, and some studies have looked at both. But however, we need to look at the following problem, right? More patients want biological valves. We heard about this. I had a lady come to my office a couple weeks ago. She had a biological valve implanted at age 50. It has now deteriorated. She's 60. So we have to discuss, are you going to want a biological valve again? Are you going to want to transition to a mechanical valve now that you're older? What are we going to do with the first valve? Can we do a valve-in-valve? It's all these issues that we talk about. But I think we need to be careful with biological valves in younger patients. So I think for when we look at our guidelines, this is 2020 ACC-AHA. Let's keep in mind that for the time being, for asymptomatic patients, let's be honest with ourselves. When there are no symptoms, all roads lead to SAVR, pretty much, with few exceptions. When patients under 50 years old, we're definitely going to be placing a biological valve. And almost definitely a biological valve. We're going to be placing mechanical under age 50 and a biological over age 65. In between is a bit of a gray zone. The European guidelines, as we said before, look at TAVI for those over 75 who can do transfemoral. I think it's important in the equation to not forget that the good outcomes of TAVI depend upon it being done transfemoral. And in general, in most of these trials, these are not patients who are having balloon valvuloplasty of iliac vessels in order to get their TAVI done. These are patients who from the get-go had good femoral vessels. So what are the key steps for getting many decades with a biological strategy? The most common strategy probably for most of these patients is going to be SAVR and then TAVI and SAVR, but it's also possible to do SAVR, then redo SAVR and TAVI after that. So TAVI as first valve, implant followed by TAVI and TAVI, or TAVI explant is also possible, but it's usually not the best choice. All the studies that we've seen being mentioned previously show that there's a high mortality rate for open surgery after a TAVI procedure, 15 to 20% in most series. So the first surgical valve, we want it to be as large as possible, especially keeping in mind that we're going to possibly do a TAVR into it later. When you look at the commercials that the valves put out, it's very interesting to see this, the Medtronic valve. Why did only one TAVI valve have better hemodynamics than SAVR? There's many reasons you can speculate. And so you see the Evolute low risk at 3 years, and obviously we have newer data than this that's come out. But when you look at the PARTNER 3 trial, I think it's interesting, when you dig back into the appendix that nobody looks at, there were 21 patients that had root enlargement in the PARTNER 3 trial. And I think it's always interesting to look at the nitty-gritty of all these trials and to say, hey, maybe that gave surgery an advantage in this trial. And so if you look at the gradients here and you look at the EOAs, et cetera, it looks like the surgeons didn't do too poorly in this trial. So I'm going to go through this really quickly so we can have a discussion at the end. As I said, I promised to give a quick talk. So this is the anatomy of the aortic root as we all know it. And there are a variety of methods for doing an aortic root enlargement: Manugian, Nix, the relatively newer Yang technique, which is kind of a modification of the Manugian. There's a Roscano. There's multiple other techniques involved. So this is one of the nicest videos I found. I don't have as nice a video as they made out of Toronto, but you can see it's not that complicated. And I think the main barrier for most surgeons to do this is that if you've never seen one, you're probably not going to do one. But if you've seen one, you know that it's relatively straightforward to open the annulus, sew in a patch, and then it's just a matter of someone, taking you through your first one, and then see one, do one, teach one, pretty much for these cases. So this is a case that, one of the more recent cases that we did here at Hygeia. So you see a similar thing. The aortic annulus has been opened. We have sewn a biological patch. This is bovine pericardium into the root. And then you can see that the bovine pericardium also gets used in order to close the aortotomy. The interesting thing about this technique is what the safety of this procedure. And there have been a lot of studies done on aortic root enlargement. This is a 2022 meta-analysis of 9 studies, over 200,000 patients with over 7,000 with the root enlarged. And you can see that SAVR with aortic root enlargement, they had pretty much the same safety. There's no difference. And also, when you look at matched patients, and this is important to interpret this correctly. So I think the issue is here that these are comparing patients who just had a straightforward SAVR. They already haven't had an annulus big enough for an appropriately sized valve, and patients who needed an aortic root enlargement, right? So these are patients who had a smaller annulus. When you do an aortic root enlargement, these patients now go to being toward like their colleagues who had a large annulus, towards their peers. So 809 matched patients from Ontario showed no difference in survival, CHF readmission, or aortic valve reintervention after having their aortic root enlarged. This is one of the more interesting recent techniques, also showing that depending on the way you do it, a lateral left-right commissural root enlargement may reduce your risk of coronary artery obstruction when you go to do your future TAVR and TAVR. I think a lot of nice studies have come out of Michigan, and out of Michigan they've shown that when they did a retrospective analysis, about 50% of their patients would not have been candidates for TAVR and TAVR. So we give patients one TAVR. If we say this fails, yeah, just come back, we'll just do another one. In their analysis, that was applicable to only 50% of the patients. We have newer surgical valves that are designed for valve-in-valve with a surgeon contribution for some of these. And I think a lot of us are now doing these valves minimally invasively because what patients want is a big valve through a small incision. I'm not going to belabor the point. Thank you very much for your attention. I tried to keep this brief so that we would have 5 minutes early, so we have a little bit of time to chat. So I think the conclusion is bigger is better for valve size. Thank you very much.
Very nice and insightful topic and presentation. Don't you think that despite this data, we do perform much less aortic root enlargement than what is needed, and why is that?
Yeah, 100%. And I knew this question was going to be asked because this is what's asked every time that I give a similar talk. So I'm going to turn it square back to you and say it's all your fault entirely. It's the fault of the cardiologists. Come and demand this. You have a lady with a small aortic annulus, you've done her echo, and you know you're not sending her for TAVR, you're sending her for an open operation. So we can't do this. So you should find a surgeon who can do this, and you should demand it. It's the same thing that people tell us about mitral valve repair. They say, Greg, your slides are fantastic, but I send my patients for mitral valve repair and they come back with a mechanical valve. I think you need to select your surgeons. I think you need to demand it. God bless, Greece is a country that has the highest ratio of cardiac surgeons to population in Europe. Did you know that, Dr. Reardon? So there's no shortage of cardiac surgeons here. You can find people to do this for you. If they're not doing this for your patient, and your patients are coming back with small valves, I have a couple extra cards that I can hand out at the end of the session. I say this jokingly, but the point is we can do it. We should be doing it more often as surgeons. I'm not saying that it's for every patient, but I think we need to demand more of ourselves. And I want you as a cardiology community to put the pressure on us to do it. The patients need to come and ask for it. Otherwise, most surgeons, I'm not going to say whether I include myself or not, we may not want to do the extra work, but there's a demand for it. Just like now you wouldn't send someone for a CABG without demanding that they get a lima to the LAD. This should be standard, that when you have a small aortic root, you're going to get an enlargement.
It's also changed, Greg, with the Y angioplasty. So we used to do Nicks and Manoogians. You could go up one valve size. Sometimes you could force it to. You do a Y, always 2, usually 3. And bow often goes up 4 sizes, which I think is a little crazy. But in the absolute low risk, my annual enlargement rate was 5%. In my practice now, it's 46% because of what we can do. And we never let a woman leave with less than 23. Never leave a man less. That's the bottom that we'll go out with. 19 and 21s, we just don't even use them anymore.
Bad idea. Yeah.
Yes, please.
So, Greg, in general, I agree with you that the larger, the better. And procedures such as Ross procedures, we should be strong advocates for. But I don't think we should get over enthusiastic about it to the point that patients may end up being hurt by somebody that's not experienced in root enlargement.
Yeah.
And, you know, there is a Sweetheart series published in JACC 6 months ago of 16,000 patients followed for 15 years. Half of the patients had PPM. Now, 48% were moderate PPM and only 3% were severe. And the 15-year survival difference between patients with moderate PPM and no PPM was 2 months.
Yeah.
So I think that moderate PPM is not as bad as we're being led to be, and it's predicted PPM, not measured PPM. Right. That's the most accurate in terms of doing it. So in general, I agree with you, and I think that if the plan in a patient, a younger patient, is to put in a biologic valve because they can get a valve-in-valve inside it, then we're doing a disservice if we're not putting at least a 23 in.
Yeah.
Independent of whether it's PPM at the initial one or not.
Fantastic. Thank you very much, Dr. Mack, for your comments. And I think, you know, having Dr. Reardon, Dr. Mack, Dr. Kiltz, and all of our guests, local and international here, this is what this meeting is about. So, you know, we're very excited to hear everybody's input. I think that, you know, part of the issue is, as I said, with planning, that you don't want to have a 19 millimeter valve in a patient and then tell them, yeah, we're going to do a TAVR down the road when this fails, because we know that's going to be exceedingly hard, or you're going to end up with huge valve gradients, which are things that we don't want. So obviously, you know, in the country that invented the term of everything in moderation, we wholeheartedly agree with you. Pan metron ariston.
Dr. Chrysocheris?
Yeah, I wanted to ask, should CT angiography of the aortic root be mandatory also for patients referred for surgical aortic valve replacement?
Yeah, I don't know whether it should be mandatory, but I do it very frequently. When there's any discussion, you know, as you know, Mike, I do, you know, both. I'm comfortable with both operations. So patients frequently come to see me, not predetermined. They come and see you. They know they're going to get a TAVR. They see somebody else who doesn't do TAVR. They know they're getting a SAVR. People come to me, and we discuss both options. And there are pluses and minuses. And if they're still on the fence while they're trying to decide, I say, let's get a CT scan. Let's look at your annulus. Let's see how things are going to be for SAVR, for TAVR. Let's look at your groin vessels. And this may sway you towards one operation or the other. But I think 100%, I don't know if it should be mandatory, but I think it's definitely good practice. The more information you have, the better decision making you can do.
Very much. I think it's time. Dr. Dardas, you have a comment on this?
Yes, congratulations, Greg, about your talk. I just want to ask you, in a lady who's got a small annulus, would you prefer surgical self-expanded valve, Percival, something like that, rather than doing a root enlargement?
I'll tell you, I think that, you know, Percival, I think, is a good valve, and you need to customize it. I would say that I use the spectrum of most valves that are available, including SAVR and TAVR valves. I don't want to knock or overemphasize any one valve. I think it's important to look at the patient and their characteristics. I think there's definitely a role for Percival, and I think that a lot of surgeons use Percival instead of performing an aortic root enlargement. I don't think it's fair to say that putting in a Percival obviates the need for surgical root enlargement, if that's kind of what you're getting at.
Yeah. I agree with you. Thanks a lot.
Thank you very much.
If you ever take a Percival out, they are really hard to get out.
I've only removed the Percival out when it's fresh, only a few days in. When it's been in there for a long time.
Once they heal, they're horrible.
Yeah.
They're just terrible.
Thank you.
Thank you very much, all of you. On behalf of Dr. Yaro, Dr. Bullis, and Dr. Dardas, we thank you for attending this excellent session. I think we'll go on for a short break and come back for the next session. Thank you all.
tissue integrity diminishes over time, largely as a result of calcification. Tissue valves are exposed to a variety of calcification sources. Free aldehydes are one of these sources of calcification. They accumulate in the tissue during the glutaraldehyde fixation process and throughout valve storage. Collagen is a structural protein material that makes up 75% of bovine pericardial tissue. Bovine pericardium collagen is multi-layered and multidirectional, helping to give the tissue material strength and flexibility. Resilia tissue is bovine pericardium that has been transformed by a novel integrity preservation technology that virtually eliminates free aldehydes through the combination of two proprietary features. The first feature is stable capping, which permanently blocks free aldehydes in the tissue, preventing calcium from binding in vivo. A sheep study demonstrated 72% less calcium content after 8 months in valves with Resilia tissue. In addition, the COMMENCE surgical aortic trial showed that surgical valves with Resilia tissue demonstrated strong clinical outcomes and excellent durability at 7 years. The second feature is glycerolization, where water is displaced with glycerol, removing the need for preservation in liquid solutions like glutaraldehyde. This prevents further exposure to free aldehyde groups, thus protecting and preserving the tissue's integrity and enabling storage in dry conditions.
Ξεκινάμε λοιπόν μετά το διάλειμμα δυναμικά για το τελευταίο τμήμα της πρώτης ημέρας, πολύ ενδιαφέροντος συνεδρίου. Είμαι στην Προεδρία με τον κύριο Τρίκα, γνωστό σε όλους, και τον κύριο Ασναουρίδη, νέο συνάδελφο της Πανεπιστημιακής Κλινικής. Θα μιλήσουμε σχετικά με TAVI και Coronary Protection is the next one. Dr. Trendafilou, TAVI and coronary protection from Evangelismos General Hospital. So make sure Dr. Trikas himself, General Director, is here.
Yes,
make sure you perform.
I'm honored to have the opportunity to speak in this great meeting.
Mike, please.
I think it's okay. I think it's okay. I just have to speak louder, as always. I thank you for the invitation, the GIA Heart Valve Clinic, Dr. Sparias, Dr. Patakos, and I will proceed. I have a case to present, as we were asked. And so, it's about a lady, 75-year-old, small, relatively small, who presented with shortness of breath on minimal exertion. She had a severe stenosis of bioprosthetic aortic valve, a trifecta, which was implanted back in 2018. It was a trifecta, 21 millimeter. She had as risk factors hypertension and dyslipidemia. She was on permanent atrial fibrillation, and she had moderate renal failure with an eGFR around 50. Without any other specific problems from her lab work, and she was in atrial fibrillation with a QRS duration of 70 milliseconds with no other abnormalities. The coronary angiogram performed back in June 2022, it was a case that was performed in 2022, showed one vessel coronary artery disease with a mid-LAD 60 to 70% stenosis, and focal mid-ostial PDA stenosis, which was not important. It's better? Okay. The ejection fraction was 65%. The LV was not dilated. She had severe bioprosthetic aortic valve stenosis, as mentioned previously, with a Vmax of 4.2 meters per second, a valve area of 0.7, mild AR, and moderate mitral and tricuspid regurgitation, without significant pulmonary hypertension, just mild, and preserved RV function. The Euroscore 1 was more than 20%, but the Euroscore 2 and STS score were not too high, but she was a frail, small lady. So we discussed about her with our cardiac surgeons. We tried to see further with a CT scan what would be better to do. So the CT scan showed that it was a trifecta with an internal diameter of 18 millimeters, rather small coronary sinuses with diameters between 26 and 27. The smallest was the left with a diameter of 26.6. Very, very low coronary ostia, especially the left was at 7.7 millimeters from the annulus, and the right at 11, and very low sinotubular junction as well, and narrow sinotubular junction with a diameter around 22-23. When the virtual valve was positioned in the anatomy, it seemed very difficult to accommodate a 23 millimeter evolute, which would be the first choice to treat with a TAVI. So we went back to the surgeons and we tried to avoid the bitter glass of which was approaching. But they persisted that she was not a good surgical candidate because she was very frail, and that we should perform TAVI. So it was obviously a case of very high risk of coronary obstruction. The axes were mildly, there was some tortuosity, but the diameters were okay and there was not much calcification, so the axis was not the problem. And we went to premeditate with the valve-in-valve application. So the trifecta is 21, is a valve with an internal diameter of 19. It is non-fracturable, although in the literature there are some reports that some attempts of fracture have been made with high-pressure balloons, but it's not the case for the average case. Okay. But we see how an Evolut 23, which would be the valve of choice, should be implanted, having as target 4 millimeters below the annulus of the bioprosthetic valve. And we see what would happen in our case when the leaflets of the external leaflets of the trifecta would be pushed at the side from the new bioprosthetic valve. It was almost certain that the left main at least would be obstructed. And it would not be obstructed just because of ostial obstruction of the coronary, but also because of sinus sequestration in our case, because the STJ and the VTC and the V2 STJ trended to 0. So it would be a case of almost definite obstruction of the left main. So what would be the options that we would have? One is snorkel or chimney stenting. This is a report, a registry of 16 centers, 60 cases among 12,800 TAVI procedures, which means that it is necessary in 0.5% of cases in this registry. They had some failures with deaths during the procedure, but only 3, and this happened only when the obstruction occurred because there was no wire protection. When the chimney was done correctly, there were only 2 cases of stent failure at 6 months because of in-stent restenosis and 1 possible late stent thrombosis at 1 year. So according to this report, chimney or snorkel stenting is an acceptable bailout technique for coronary artery obstruction. The higher event rates are expected when established coronary artery obstruction without wire protection happens. And the short and mid-term results are acceptable. The long-term follow-up, though, is always a question. The other solution for this case would be basilica, which is something that, as far as I know, has not been performed in our country yet, and is a complex procedure that needs about three, I think, at least skilled interventional cardiologists. There has been reports that describe the technique. Very good imaging is needed from the CT to predict the best angulation for the X-rays, and also guidance by a very experienced echocardiographer with transesophageal echo. It should be done under general anesthesia. And what happens in this technique is an Astato 20 wire crosses with instantaneous electrocautery the menacing leaflet towards the LVOT, where it is received by a loop, a snare, externalized. A flying V is formed by the operator, and then it goes back in the leaflet in order to do a new electrocautery to create an incision this way and a splitting of the leaflet, thus avoiding the obstruction of the coronary when the bioprosthetic valve is implanted with the TAVI procedure.
Costa,
Yes.
just interruption. What are the hemodynamic consequences of basilica or other leaflet splitting techniques until the implantation of this?
There is a very delicate moment when the splitting happens. There is acute AR, not always hemodynamically significant. There is no hemodynamic impact always, but it should be expected. And the valve must be prepared to be implanted very quickly in order to correct the situation. That's the problem with this technique. One must be very fast from the leaflet splitting until the valve implantation. Okay. If the AR is hemodynamically significant, one trick that one can use for several minutes is to pace a little bit higher at 120 BPM in order to minimize the impact of the acute regurgitation, as far as I know.
And another question, what happens if coronary intervention is indicated after chimney stenting?
This is a problem. One should be, not many reports have been made. There has been one published by Dr. Taleb, I think, that it is described for a chimney with, I think, not a self-expanding valve with a tall frame, but with a balloon expandable valve. It has been done, intercoronary intervention, through the stent that is as a snorkel outside. And to do that, you must be cautious not to crisscross the struts of the chimney stent. You must create a loop, be in the stent, and then in order to do the intervention, you can try to put an extension guide catheter in the stent. It can cause hemodynamic compromise because the extension catheter can block the supply, so you have to be fast.
Okay.
So it's something that is difficult, but not always feasible. It has been described, I think it's not always feasible.
Okay, we can continue.
So for this case, our planning was to do general anesthesia in order to have a patient that will not move because we had a complex technique. Our main access would be the right femoral artery with echo-guided puncture. Pre-closure with two per-close. A secondary access would be the left femoral artery for the guiding catheter for the left main, which would be an XB3. The right radial artery for a JR test for the right coronary artery. We should start with a fast PCI of the middle AD lesion, and then position wires and drug-eluting stents standby in the coronary arteries, left and right, in order to use them in case we will need it during the TAVI. We would cross the valve conventionally with an AL1 and a straight tip guide wire. We should use a Safari extra small. We would pace over the wire during Evolut 23 deployment. We would assess before final release of the valve, the coronary perfusion, to decide if snorkel stenting is needed. We should have IVUS available, and we should close at the end and assess finally what happened. So that's how it went, a fast stenting in the LAD. Then guiding catheter and a stent in the LAD through a wire, a guiding catheter and a stent in the right coronary artery through the other wire. The first step of the implantation of the valve at the depth that we intended went well, but before final release, we assessed what happens at the right coronary artery and at the left main. At the right coronary artery, there seems to be some distance from the frame of the valve to the ostium. On the left, the aspect is ominous, and it's from the image that we had, it would be certain, it seemed certain that the left main would be blocked in case we released the valve without protection. So we decided before the final release of the valve to implant a stent. The stent that we had selected, by the way, was a high radial force stent. The diameter was 5 by 35, it was 5 diameter and 32 the length. We tried to target the distal left main and to be above the senotubular junction at the proximal part of the stent. We implanted it as we saw here. And then on the left, you see the final release of the valve. And on the right, the final result with injection from the guiding catheter for the left main, which was retracted a little bit higher. So we had an hemodynamic measurement here. You see the pigtail in the left ventricle. We had a good hemodynamic result without a gradient more than 10 millimeters of mercury. We thought about post-dilating, but it was a trifecta, and we had a stent that we had a good result, so we decided not to do anything more. We wanted to verify that the right coronary artery would not be blocked after the release, after withdrawing the wire, so we did a final check with IVUS, and with IVUS, we saw that the ostium of the right coronary artery was clear. There was no leaflets prolapsing or menacing the ostium, so we didn't do anything for the right coronary. And this was the final angiographic result with a pigtail, and the final angiographic result at the axis. So the patient
Another
went well.
important question is if there is an increased risk of stroke with this kind of techniques for these patients.
I think that with any technique that increases the number of manipulations in the ascending aorta, it is logical that the stroke risk increases. But I think that with leaflet splitting techniques, it is logical that it is somehow more than with compared to snorkel technique. So I will comment it later as well. I will do some comments later as we advance. Here we see that the alternative that we had is basilica. But with basilica, it is not certain that there will not be coronary obstruction. There is a 7% chance that you can have coronary obstruction even with basilica. And then you must do either snorkel or try to implant orthotopically a stent by crossing in the coronaries through the gap that the basilica has offered. So the basilica is not a panacea in case of coronary, when you want to protect the coronaries. This is a more elegant technique that is evolving. This is a dedicated splitting device which is called shortcut. It is a device that needs 16 French access in order to do what is necessary. Here it is an example with a previous TAVI valve that failed. There is a stabilization arm and a splitting element, and it can create elegantly the splitting that was initially the way that for which the initial way was the basilica. But it needs also very good imaging and very, very skillful operators. In the PCR that follows, there is a promise that they will show good results regarding this device. And there is a more brutal way to get rid of a menacing leaflet, which is called unicorn, which is like a balloon-assisted basilica, and you cross the menacing leaflet, you pre-dilate it with a coronary balloon, then with a peripheral balloon, and then you implant a valve inside, totally destroying it. So there's no problem. I think that this technique creates a great risk for a stroke. But it is described in the literature with good results for a few patients. And the more awe-provoking technique is the cathedral, where it is on top of basilica. There is another lasso which is advanced over through a 20 French sheath, which is just over the annulus. And with the lasso, you cause electrocautery, and you withdraw everything, and the leaflet comes out. This is a technique that has been described in 2022. I don't know if there is a large series of cases with this technique, but it is something that can be done, that has been done. So we have, in order to protect the coronaries in such cases, either leaflet splitting or snorkel stenting. The advantages of leaflet splitting techniques is that the coronaries are reaccessible and there is no risk of stent failure. The disadvantages are that if the valve has been a TAVI valve which was not commissurally aligned, there is no sense. And it is technically more challenging with 3 or 4 operators needed and much fluoroscopy procedure time and cost. On the other side, the snorkel stent is more friendly for standard skills, and it's a good bailout high-risk strategy. The disadvantages are the coronary access that we have mentioned and the possibility of late stent failure. In our case, we did a CT scan for follow-up at 18 months, which showed that the result at 18 months remains acceptable. The stent seems well opened without distortion. The patient goes well. There are no symptoms. The valve is above the level of the left main, as it is shown on the right. And anyway, we are satisfied with the result so far. It is a 75-year-old lady. The expected lifetime for this kind of patient, for a woman of her age in our country, should be around 83, 84. We should continue to follow her up closely. So to conclude, this is the last slide. One should know in his institution what is the skill set, the toolbox, and the strategy. And one should be bold, but with intelligence. And there are cases that cannot be done with TAVI, as in this example, where the risk, the surgical risk is high, but the anatomy is impossible, because it is like the previous one, but there are no coronary sinuses. If you see the diameters, the coronary sinus diameter is around 21. There is not possible good result with TAVI for this case. So despite the high surgical risk, we did not attempt TAVI for this case. The patient was operated and she went well, despite the high surgical risk. So to conclude, the risk of coronary obstruction at TAVI can be predicted. Standardized criteria based on CD imaging exist and are well known. Preventing strategies include snorkel stenting and leaflet splitting techniques. Basilica is well standardized but complex and requires specific training. Other leaflet splitting techniques and dedicated leaflet splitting devices are proposed and promised and hold promise. All techniques are promising but have strong and weak points. They all require further evaluation. And we should not forget that if the anatomy is impossible, surgery might be reconsidered. I thank you.
Hey, great. It was a great overview of all these complex techniques. And anyone who has a question, go to the microphone. Anyone in the chat, please send us a question. I can read them here, and we can address those. There's one more technique. It is the snorkel after recrossing. Because if you saw in your CAT scan, you had the stent, the coronary stent, was released, and then you place a valve. So you crush that stent, or whatever, the entry to the stent is crushed beyond the valve. So if you want to complicate things a bit further, you can have the system there, exactly how it is. And then you release the valve, and you have the coronary guide exactly where you have it. And then you take a second guide and cross back inside from the inside of the valve. And if it works, your snorkel comes now into the main lumen of the valve. And if it doesn't work, you just deploy this one. So if you can make it happen, so that answers the question of Dr. Trikas, what about the reaccess? Because if you crush the stent on this behind the valve, I think reaccess will be nearly impossible. You have to go through the strut of the stent and destroy it and all that. But if you get lucky, and in the other one, you can, because the stent comes into the main lumen of the aorta, you can find it a little bit and try with a guideliner to access. I mean, nobody really plans to do those things, and it's actually highly unlikely, in my view, to require them. Because as you saw, these coronaries, they don't really have disease. So, and we're really talking about a very big vessel, the left main and the access towards the aorta. So it's highly unlikely, unless somehow it ends up in the circumflex or the LAD and it's oversized and you end up with a dissection acutely. Yeah, that could be a problem. But if it doesn't, unlikely that this person is going to have a left main restenosis, let's say, or something like that, because they really don't have atherosclerosis of that degree.
I think for this case, since the valve was above the level of the left main, it would not be possible to have an orthotopic stent through the struts of the valve. So that was the only solution. I agree that
talking in general. I'm just talking in general. In the in the overview slide, there is the addition snorkel plus.
Can I ask something?
Yeah, go ahead.
Congratulations, very good.
Dr. Dardas, yes, very well.
Very good and elegant case. I want to ask you, did you deploy the stent before deploying the valve? I didn't get it right.
Yes, I showed it. Yes.
So you first deployed the stent, and then you deployed the valve.
Yes, because we would not have to face the situation where the patient would be hemodynamically unstable, because it was certain that the left main would be obstructed. So if we implanted the valve and then consider if we implant the stent, then we would have a patient hemodynamically unstable. I
agree with that, but there is always an issue of compressing the stent when you deploy the valve. So in these cases, what is our usual practice? Because I saw your guide cath was quite high, so if you wanted to go down again, you may, you possibly wouldn't be able to go down and post-dilate the stent. So in these cases, what we do, we leave an extension catheter just near the ostium of the left main. And the extension catheter is more easily maneuverable. So we post-dilate the stent after deploying the valve, so we make sure that the stent is properly deployed.
So congratulations for this case, nicely performed and presented. So I think all looked unfavorable to begin with. Valve-in-valve procedure, valve with external mounted cusps, narrow sinus of Valsalva, short distance between the annulus and the orifice of the coronary arteries. So I think in this case, considering that the internal diameter of your first valve was only 19, the choice of putting a valve with a supra-annular opening was quite reasonable to decrease the possibility of residual gradient. However, what I would like to ask, do you think that, did you consider putting a balloon expandable valve? Of course, this would perhaps leave you with a higher residual gradient, but do you think that a balloon expandable valve would kind of decrease your risk of coronary occlusion? And a second short comment, as Dr. Trika said, these procedures are related to a higher risk of stroke, so using cerebral protection like the Sentinel would be a reasonable option. However, I realize that you run out of arterial accesses. You put one access for the TAVI procedure, pigtail, 2 guide catheters, so perhaps it was not reasonable to do that.
It could be done if for the cerebral protection. I start from the second question. If we opted to use the secondary axis, the secondary femoral axis, with a larger sheath, so we could have 2 guiding catheters through a 12 French sheath, for example, and close with 2 proglides, because we knew that we had relatively good puncture points, and we had no difficulty puncturing echo-guided. So if we wanted to do this, yes, but it would add to the complexity of the procedure. In this way, the procedure was smooth. And the first question was if we would select the balloon expandable valve. It was, the internal diameter was 18, not 19, from the CT. So we thought that it would be not a good option, and since the leaflets of the bioprosthetic valve would anyway go up and close the coronary, even in this, with this choice, we did not do that. We opted for this solution and hope for better hemodynamics for a small annulus. She goes well. At 18 months, she's well.
Okay. We have to stop here. Thank you very much, Dr. Triantafylou, for excellent presentation. We have to move on to Thessaloniki. Dr. Dradas.
Hello.
Your case. A case of severe aortic stenosis and severe heavily calcified superdominant RCA disease. We lost
Hello from Thessaloniki and from St. Luke's Hospital. First of all, I would like to thank Kostas Sparias for this very kind invitation, and Dr. Patakos as well. I'm terribly sorry that I'm not there. Actually, I had my tickets ready, but something went quite wrong with, I had a serious family issue, so I had to stay here. Anyway, what I'm going to present as a team from St. Luke's Hospital, we were asked to create a video from our cath lab, and this is what we're going to show to you. And we've chosen a quite interesting case. I think it raises a few various issues regarding the combination of severe aortic stenosis and severe coronary artery disease, what to do first, and how to some tricks how to access the coronaries after you implant the valve. So we'll go ahead and we'll watch the video from our cath lab, and then in the end we can discuss.
Another talk or what? Oh, okay.
Sorry?
Are you okay? Is it all right? Are you all set? Είσαι εντάξει με την παρουσίαση?
Ναι, δεν τη βλέπετε?
Τη βλέπουμε, ναι. Απλώς επειδή φαίνεται από το κομπιούτερ. Εντάξει, είμαστε ok. Αν είσαι ok, είμαστε ok εδώ, ναι.
Ναι.
Τώρα καλύτερα. Τώρα τη βλέπουμε. Προηγουμένως δεν τη βλέπαμε. Έγινε.
Τώρα τη βλέπετε?
Όχι, προηγουμένως, το προηγούμενο.
Οκ.
Ωραία, προχώρησε. Εντάξει, πάμε καλά. Τη βλέπουμε. Εντάξει.
Ωραία, ευχαριστούμε.
Λες και τι βλέπουμε, ώστε να παρακολουθούμε.
Αυτό είναι το CT που βλέπουμε. Και εδώ είναι η αγγιογραφία του ασθενούς.
Ωραία, βλέπουμε τη βλάβη. We can see the RCA bifurcation lesion essentially, very, very big, very calcific lesion right before the bifurcation. Both branches very big.
Can you hear now the video?
No, we only hear you. We see the video,
sorry.
but we hear you.
Yeah, I'm sorry. I've had to go through because I don't know why there is voice from the video, but I don't know why you cannot hear it.
That's all right. We just you just help us yourself while we watch the video. That's fine.
Okay, I'm just explaining all the characteristics of the patient. Now, the idea is to perform the TAVI first, and then to perform the angioplasty through the structure of the valve, because the patient had an episode of loss of consciousness, and this is the main issue is the aortic stenosis, but also the episode of consciousness, loss of consciousness, was preceded by chest pain. So we're going to do both of them, and I'm just presenting the team there. I'm sorry that you cannot hear the voice. I can hear the voice from here. I'm sorry you cannot hear the voice from the video, but I'm going to explain I'm just introducing the team. So we cross the valve here. We perform the balloon. There is severe LVOT calcification, so we started the pre-dilatation with a smaller balloon. Okay. So this is the balloon dilatation. He went quite ischemic during the after the balloon dilatation, so we had to go. He was also hemodynamically unstable. His pressure was quite low, so we had to move quite quickly and put the Evolut Pro Plus. Our intention was, this was 29 Evolut Pro Plus. Our intention was to do a proper commissural alignment in order to be able to access the vessel after that. So we position the valve in the cusp overlap view, and at this time his blood pressure was quite low, so we had to be quite quick in blunting the valve. The patient became quite unstable hemodynamically. we tried, the first attempt was, the valve was quite low, so we had to reposition it. And we had to deploy it for the second time, and on pacing, we paced at 140. So this is the time of deployment. Okay. At this time, the blood pressure starts recovering, and it seems that in this bicusp overlap view, that the position at the non-coronary cusp is quite good. So we're doing an injection in order to assess the position at the non-coronary cusp. The position is quite good. So we're quite satisfied with the position as regards the non-coronary cusp. Then we went to the coplanar view, and we assessed the left coronary, the left sinus, sorry. So we were quite happy with the height, and we decided to fully deploy the valve. We just removed the pigtail, and we deploy the valve under pacing, 140 beats per minute, in order to stabilize the whole system. The other thing is that we release the valve very slowly in order to avoid any mislodgement. So the valve is deployed. The blood pressure at this time started recovering gradually. There is aortic regurgitation, as you can see, and we expected that because there is a lot of calcium, and there is a lot of calcium in the LVOT, but the position looks quite good. You can see that there is proper alignment of the valve. This is quite significant. So we're happy with the depth. We checked in the RAO projection, and you can see that the valve is not fully deployed. We always have to check into projections. So we're going to post-dilate the valve. We did a post-dilatation. And this is a post-dilatation. We used the 22 balloon. We're a bit conservative because of the LVOT calcification. We didn't want to create any annular rupture, and but this worked, and actually the final injection shows only mild aortic regurgitation that was confirmed by an echocardiogram that we did at this time. So at this time we finished with the valve. The patient started recovering hemodynamically. And then together with me is Dr. Tsikaderis and Dr. Mezilis, with the team, the structural team at St. Luke's Hospital. And this is Dr. Mazilis took over now to go ahead with the angioplasty. You see how we access the ostium. Actually, to access the ostium of the right coronary artery, we have to go quite steep LAO. So steep LAO in order to have better access to the right coronary artery. And for the left coronary artery, it's LAO cranial view. We cross with the wire. You can see that there's a chunk of calcium, heavily calcified RCA. It's a super dominant RCA. So we start with a small balloon to see if this can create any space. And this is Dr. Mazilis. We selected a 7 French guide catheter because sometimes we may need to put a guide extension, 7 French, and do the rotablation through the guide extension. But we had a very good positioning of the guide cath, so we didn't need a guide extension. We tried to put a second wire in the PDA because the first wire was on the LV. There was a lot of difficulty in getting the second wire. We exchanged the wires and then we managed to have both wires in PDA and PL. And then we tried the small balloon, the smallest balloon, just to create some space, but the balloon couldn't cross. Even the smallest of the balloon couldn't cross. You'll see that in a minute. At this very moment, the patient went into fast AF and he had severe ischemia, and also the blood pressure started dropping. And after crossing, as I said here, the patient went quite ischemic, even just crossing with a wire. So you can imagine if we hadn't do the TAVI first, that
I don't know if you hear us, but we have a frozen image and no voice here. Any questions from the audience thus far? Any questions, anyone? Dr. Kilic, yes. Go ahead. Let's have some discussion time while he's reconnected.
This case is a very good example to do coronary PCI before TAVI or after TAVI. Actually, the operator decision is good because I always afraid of this kind of right coronary arteries. Before TAVI, if any occlusion occurs, the patient had a severe aortic stenosis and patient can go to the cardiogenic shock. But there is a lot of discussion about this point, when to do PCI or TAVI, and we can discuss this, maybe. What is your opinion?
Yeah, well, everybody's going to give an opinion, and go ahead, come here also. We can all hear you because of the web. Let's see. We have first opinion. There are going to be many opinions. First opinion.
This is
also, Costa, you have an radiation.
That's what I'm going to say.
And also a contrast medium, an amount of contrast medium. Talk about also this.
For this kind of cases, one must have in mind that if you do two procedures in one sitting, you have much more contrast, and this kind of patients, 1 in 2 times, have renal failure. Okay, so it's a good thing to have in mind that if you have corrected the aortic stenosis, then it's less probable that you will have a problem with the coronaries. But for this kind of lesion, I think it is a predictable lesion, and that could be treated before TAVI. I mean, you can see that there is a chunk of calcium, and if you plan a PCI beforehand, and okay, it's not a proximal lesion, which according to the recommendations now you should treat before TAVI, okay? But it's a distal lesion before the bifurcation of a superdominant right coronary artery. And it's simple to treat if you decide that you have the armamentarium needed. So you can go elegantly, use a few contrasts, decide from the beginning that you will use the rotablator, rotablate the lesion, put a stent, and several days later, 1 week later, come back and do the TAVI. I mean, I see the difficulties now, and maybe somebody can say that I am the wise man after the problem, but our strategy in our center is that this kind of situations, even ostial calcified RCAs, we treat them beforehand. And even if you decide to do it in the same procedure, you can do it. You can do the coronary first. You have the valve available, and you can treat without having the problem to access the coronaries after you have implanted the valve. And anyway, you will have a permanent temporary pacemaker. Anyway, you have a temporary pacemaker for the procedure. So
yeah,
that's my
opinion. Temporary pacemaker, the least of the problem. You can always put one. Both the coronary and the valve needs it. We don't seem to have a connection yet, doctors. Now, really, what would you favor?
I would personally feel more comfortable to treat the coronary first. I appreciate that doing the...
Και κάνω share, έτσι.
Dr. Dardas, here? Do you hear?
I can hear you.
Okay.
I'm terribly sorry about that.
I don't have image.
Okay, can you hear me?
Yes.
Yeah, but we have no image. We hear your voice. So we continue the... Oh, there you go. You back up. Go ahead.
Yeah. So sorry about that. I had a sudden problem with my internet, my connection. Now we're at the moment that we cannot... Can you hear me now? Can you see the
yes,
picture?
Yes.
Okay. Thank you very much. Oh, sorry. What happened? Sorry. This is the 1.5 rotablation. Okay, you can hear me now. Okay.
Yeah, go
Dr.
ahead.
Dangas,
Yeah, go ahead. Go ahead. Yeah, we see the rotablator 1.5. What's next?
Okay, this is 1.5. It crossed with a lot of difficulty, actually. It took some time to cross. It crossed in the end. So we did a policing, final policing with the rotablation. So you can see that it's quite straightforward to rotablate through the valve. There is no problem as we do our usual angioplasty. After that, we put the 1.5 modified the plug, but we put a 3.0 balloon, but the 3.0 balloon actually didn't.
The 3-0 balloon doesn't seem to make the turn.
Yeah, it was difficult to make the turn. Even the balloon, you see there's a lot of calcium there. So we went with a non-compliant balloon there, and we inflated at high atmospheres. And then we took a 3-0 balloon. It crossed relatively easy, but it didn't open the valve, the stenosis. So it was even at high atmospheres. You can see that the balloon is under deployed. So at this moment, we decided to go ahead with the IVL subwave and to do what we call rotatripsy. You can see at high atmospheres how the balloon is underexpanded.
Yes, we see that.
Okay. And then we put 22 atmospheres and the balloon doesn't open. And every time that we inflated the balloon, the patient went very ischemic. So again, this is to emphasize that the decision to perform the TAVI first in a patient with a gradient of 90 was the best decision. Okay. So this is a 3.5 IVL balloon. And we did perform about 7 or 8, if I remember well, inflations with a shock wave, and you can see that the balloon expanded well. Okay, you can see that we had a quite good result, and. After that, we put a stent. This is after the shock wave. And we put a 3.5 stent. We post-dilated with a 4-0 balloon.
Well, it's already a great result, and I'm sure you optimize it a little bit more. I think this is great.
This is the final result, actually.
Yeah, amazing. The final result is great, and thank you for this great presentation. And you can see now, we can see very clearly that there was an intermediate lesion at the bend, exactly where there was problem delivering.
But we didn't do anything to this lesion.
No.
Actually, the patient had a very good outcome, and he was discharged a few days later. And this is a case actually that we wanted to emphasize when we have critical aortic stenosis and critical coronary artery disease, where you have to use rotablation or shock wave, and then possibly it's better first to fix the aortic valve and then go and fix the coronary. And there are some tips and tricks how to go through the struts of the evolute valve. We had to use an evolute here because of the LVOT heavy calcium. We had to use a balloon expander, self-expandable, not a balloon expandable valve. So these were the main. I'll stop the video. These were the main messages of our case. That when you have critical aortic stenosis, critical coronary artery disease, it's better first to consider fixing the aortic stenosis. And then it's not difficult to do the standing, the PCI after the TAVI, following some rules how to approach the vessel. So thank you very much.
All right, great. In continuation, there's a great presentation, and we thank Dr. Dardas, a very complex case to recanalize the evolute study, the rotablator, a great case. There's also, as we said, it's possible to perform before, maybe more less complex case. There's also possibility to perform high-risk cases before TAVI, facilitated by a balloon, a small balloon valvuloplasty, like an 18 or a 20 right before the coronary, in order to facilitate the coronary procedure, and then stage a TAVI. All these are possible. We saw a great example. I think we'll conclude the session.
I just had to say here that we thought to do a valvuloplasty, but after the 20 millimeter balloon, the patient went very, very ischemic and hemodynamically compromised. So we had to finish with the valve. Yeah, good point. Good point. Absolutely. Good to be prepared for the valve. Excellent. I think we conclude this great session. Thank Dr. Trikas, Dr. Asnauridis, and move on right away to the all-star next session. We invite the legends of structural heart disease, two surgeons from Texas, Dr. Mack and Dr. Reardon. They're going to Dr. Reardon, Michael Reardon, was the pioneers of TAVI, particularly with the self-expandable strategies, and Dr. Mack, a pioneer in the from Dallas and Houston, so to speak. Next session, please join up here, and Dr. Granada will, from Cardiovascular Research Foundation, will follow after Dr. Reardon's initial talk. He will connect through New York and be available for the discussion. Dr. Mack is assuming the microphone here.
Immediately, and I'd like to reintroduce my close friend and colleague, Mike Reardon, who's going to discuss why surgeons are ideally poised to perform TAVI.
Actually, I'm not going to talk about that, Michael. My agenda I was sent was an old agenda. The good news is Mike Borger has already talked about that, so I'm going to talk about how confident is the TAVI guideline shift from operator risk to age alone. So these are some of my TAVI conflict of interest. The good news is I'm pretty much spread with my conflict, and I consult for all these companies. But my other conflict is I'm a cardiac surgeon, and that's what I spent my life doing, is cardiac valve disease. So we've already talked about the U.S. guidelines. The U.S. guidelines say that if you're over 80, you're going to live 10 years or less, you get TAVI. If you're 60, you're going to live 20 years or more, you get surgery, and in between, it's the physiologic risk of surgery, the anatomic risk of TAVR, and what the patients want, and of course, all the patients want TAVI. The European guidelines are a little bit different in that they talk about age and risk, but not life expectancy, and draw the line at 75. Less than 75 and low risk, which is a Euro score of less than 4, then you should still have surgery. Higher risk or over 75, you should have TAVI. So this is what's going on in the U.S. right now. You've all seen this slide. This is updated to 2022. Of course, the red line that's going down a little bit is isolated aortic valve replacement. The blue line is all aortic valve procedures. And that orange line going up is TAVI. So in 2022, we did 98,504 commercial TAVRs. In 2023, we did over 100,000. I just haven't updated to that. Of interest, if you look at the red line and the blue line, isolated AVR and overall AVRs, in 2020, after low risk got approved, we're actually seeing an uptick in surgery, probably because people are now coming into the valve clinics and people that are following the guidelines are operating on these people. But you've also seen this slide. This is the Vizient database, which covers 95% of the academic centers in the US. And what they did is divide up their isolated aortic valves into less than 65, 65 to 80, and over 80. And right now in the Vizient database, which is the northern Atlantic part of the US, almost half the people by 2021 were getting TAVRs that were 65 or less. This has been repeated in California and several other places, and the data looks the same in multiple locations in the US. So the real question is, well, what is the risk of surgery if we're going to operate on these people? How long is the patient likely to live? do we have data durability that will help us make a decision? And what are the options and risk if we do SAVR or TAVR and one of them fails? What can we do to rescue our patient? So what is the risk of surgery? Well, if we look at surgery and we compare it against TAVR, because if we just look at surgery alone, there was a recent article that Mike Borger showed you from the Annals of Thoracic Surgery where they looked at low-risk isolated aortic valve replacement in the STS, and they showed that they had a mortality for 74-year-olds at 8 years of about 12.7%. The problem is, if you look at the consort diagram, when they went down there, they lost 1/3 of their patients they couldn't match to the death index, and so they just kind of ignored those. And when you ignore the people you lose to follow-up, those are the people that have more deaths in them. It's hard to judge that, so we go back to the randomized trials, and there are 2 randomized low-risk trials. There's the PARTNER 3 trial and the Evolute low-risk trial, and what you see is that it's non-inferior in both of those. They kind of cross in PARTNER 3, but they're still non-inferior. They're on top of each other, and then they're splaying, but they're still non-inferior in Evolute 3. I hope to present the 5-year data next year at ACC, and we'll see what's going on at Evolute at 5 years, where these are starting to flatten out or they continue to diverge. And this is the recent Dedicate randomized trial from Germany, looking at lower risk patients. And what you see is that TAVI did much better for a cumulative incidence of stroke or death of any cause than did surgery. But when you read this study, the mortality in the surgical group was about 6.5%, much higher than you'd really expect for this group of patients. So we know that TAVI has pretty good early data. We know that TAVI does okay to about 5 years, and we know that the NOTION data looked okay to about 10 years. But how long are these patients likely to live? Well, if you look at the randomized trials, these are the high-risk randomized trials, the intermediate-risk randomized trials, and the low-risk randomized trials. And if you look at the mortality for the randomized surgical arms, the straight red line and the dotted red lines are PARTNER high risk and intermediate risk, and the dotted line at the bottom is a PARTNER low risk. Of course, if you go to higher and higher risk, your individual risk of mortality in any single day is higher, so that your cumulative mortality at 5 years is higher. And you go through the blue lines, and that's high-risk core valve, intermediate-risk core valve, and low-risk core valves. And of course, it all has to do with the risk of the population that you do the procedure on. And the same thing looks good for the TAVR arms. In the TAVR arms, they basically look exactly the same. Why? Because it's the risk. Once you survive your procedure and get rid of your aortic stenosis, your long-term survival is going to be based on your individual risk and the performance of the valve you got, whether it be TAVI or surgery. So we know that if you had a high risk, your mortality at 5 years is 50% or higher. Well, that's why people that are above 80 really can get TAVR. They're not going to live long enough for their valves to wear out. I really think some of the best data, though, comes out of Sweden. In Sweden, every aortic valve procedure is data-based by law. Every death is reported by law. And so they know what happens to every isolated aortic valve, and they have every death that's accounted for. So what they looked at is they looked at patients that are over 60 with aortic stenosis who underwent an isolated surgical aortic valve replacement with a bioprosthesis, over 8,000 patients. Then they risk stratified them into what were low, intermediate, and high-risk cases, and then they divided them by age in 5-year increments. And this is what happens if you look at the low risk, the blue line, the intermediate risk, the dotted line, and the high risk, the black dotted line, over 15 years. And it's exactly what you'd expect. The higher the risk, the higher your cumulative mortality is at any point in time. So then they divided it up by 5-year age groups, 60 to 64, 65 to 69, going up from the bottom up. And you see as you get older, you're going to live less long. Your survival is based on how old you are and how sick you are at any given time. So then they could take these and they could do mean survivals. The high risk is the black line you see going through the green at the bottom. The intermediate is the red line. And then the blue line going up there at the top is what happens in low risk. And I think we have durability data based on what we've done already to about 10 years. And you notice the high risk and the intermediate risk, the mean survival barely hits 10 years in intermediate risk. But once you get to low risk, it actually doesn't get down to the green bar until you're about 76 years old. So do we have the durability data that would then let us move on and do these things? Because we now know what the survival is. Well, this is Philip Peeberow's work from PARTNER 2A, which was the intermediate risk, where we randomized XT, which is a previous generation of the balloon expandable valve, against surgery. And if you looked at the biologic valve failure, there was more in XT than there was in surgery. It wasn't a surprise. It was an early generation valve, and I don't think many of us were very happy with XT as a valve. And then they took the non-randomized continued access S3 arm and they propensity matched it. And what they showed is that the failure rate for S3 was about 3.9, for surgery about 3.5. Statistically, that was exactly the same. So this was considered a win for TAVR, that the durability at 5 years in this intermediate risk group appeared to be as good as surgery. However, if you go back into the supplement and look at the last table in the supplement, they actually did an inverse probability treatment weighting analysis of this, which is another statistical way of looking at this, and it allows you to create a better, more accurate pseudopopulation by kind of cutting off the tails of the curve. And if you do that, you actually see in years 4 and 5, S3 had statistically more valve failure than surgery. A little bit concerning. I did this with the core valve high and intermediate risk. What we did is we took the randomized arm of the high risk core valve and the intermediate risk core valve, over 2,000 patients, and used these randomized patients to look at the incidence of moderate or greater structural valve deterioration. And we use a subset of the VARC3 analysis defined as an increase in your mean gradient of 10 millimeters mercury or more, and a final mean gradient of 20 or more, or new or worsening intraprosthetic AR to moderate or greater. And what we found is that by 5 years, the rate in surgery was 4.38, TAVR 2.20, for a p-value of 0.004. So when I presented at ACC, this actually got a lot of buzz because at the time, surgeons would always say, well, listen, you got to use surgical valves because we have the valve stability data out here. And here's the first time it looked like maybe TAVR had less structural valve deterioration than surgery. Then we took the non-randomized continued access arm of both those trials, which got us up to over 4,700 patients, and used that larger number to look at the clinical associations if you had moderate or greater structural valve deterioration. And what we found is whether you had TAVI or surgery, if you developed moderate or greater structural valve deterioration by the definition that we're using, it doubled your all-cause mortality, it doubled your cardiovascular mortality, it doubled your risk of being hospitalized for heart failure or aortic valve reintervention. So when we write these definitions, such as PPM or structural valve deterioration, we write them to correlate them with clinical outcomes. And this is one of the first times we really strongly correlated something with clinical outcomes. Steve Yakubov then went back and said, let's look at overall valve dysfunction. Overall valve dysfunction includes structural valve dysfunction, non-structural thrombosis, and endocarditis. And what Steve showed is, again, using the same randomized data and then the association, there was more biologic valve dysfunction in surgery than there was in TAVR. And if you had biologic valve dysfunction, again, it was a marker for increased mortality and increased rehospitalization. Now, the opposite of valve dysfunction is valve performance. What this tells you is that TAVR in this randomized trial had better valve performance than did the surgical arm of the trial. And this is, of course, the NOTION data. We've seen the NOTION data. This is now out to 10 years. Remember, it's a Nordic country, Norway, Sweden, Finland, and Belgium, with first-generation core valve against surgery. Mean age was 79, mean STS was 2.9, a little bit different than that. But what they saw is that 10 years, there's no difference in the mortality. And yet, using a similar definition of ours to moderate or greater structural valve deterioration, again, they showed at 10 years more in surgery than there was in TAVR. Now, I've done a lot of surgical valves, as has my friend Dr. Mack, and all of us have seen valves that failed early. I wrote my first paper on trifecta failure in 2017. The people who owned it then was St. Jude. They came to my office and said, please don't publish this paper. I said, no, we're going to publish the paper. And there was an editorial written to it, was this the canary in the coal mine? It turned out it was. Cleveland Clinic did a larger series. University of Michigan did a larger series. And this valve fails early. It's off the market. I put in several hundred Toronto stentless valves. They looked great to year 7, and then they started falling apart. So what I want you to think about is structural valve deterioration is not a class effect. It depends on valve design and tissue science. And each surgical valve is going to be different, and each TAVR valve is going to be different. So it's really not a class effect. So what are the options and risk if surgery or TAVR fail? Well, this is from University of Michigan. What they've shown is one of the fastest growing operations they have is TAVR explant, or TAVR or explant after a surgical valve and a TAVR inside that. And if you had a TAVR explant in the University of Michigan, a really good valve-centric place, versus a redo aortic valve, it doubled your mortality. And what Gilbert Tang has shown us with the TAVR explant, it went somewhere between 2 and 3 times the hazard ratio for mortality. So these are not simple things. I think surgeons can learn to do them better. I did my last one on Wednesday before I came here on a 152 kilogram woman who had a valve put in that had become infected. We're getting better at these things, but there are tips and tricks. And just like it was hard for surgeons when they did their first redo aortic valve, once they've done 100, it's easier. I think this will get easier, but they still are complex operations. And doing over 100,000 in the US with many younger patients, for my younger colleagues, this is going to be one of their busiest operations going forward. And this is the data from both Boppot and from Gilbert Tang, showing that the mortality can be up to 10 to 13%, much higher than we would really expect. So how confident is the TAVR guideline shift from operator risk to age? Well, this is again what you saw. This is from the Sweetheart database. Again, the black line is high risk, the red line is intermediate risk, the blue line is low risk with median survival time in years. There's our line for 10 years. I think we have 10-year data. I think if we're talking about high risk or intermediate risk, that's pretty reasonable to do TAVR. There's where we don't have the data yet. And if you're low risk and below 76, you fall into this red zone. Here's the US guidelines, and here's the European guidelines. I think there's still a big area between European and US that's red that we need to work out, and there's a whole lot below the 65 that's red in US that we really have no data on whatsoever. So how confident is the TAVR guideline shift from operator risk to age? It really depends on the age you choose. If you choose the right age, I think Europe has got it, clearly works out well in Europe. And I think there's still some questions. I'm very comfortable in 70 or above. I'm 71. I don't really want to be operated on. I think I probably survive long enough. But when you get down less than 65, I do think that we're doing some disservice to some of our patients. Thank you very much.
If you would join us up here, Juan Granada is waiting for us in New York. And is on a tight schedule, so we're going to go directly to Dr. Granada right now, and we'll save questions for after his talk.
Hi, my name is Juan Granada. I'm the President and CEO of the Cardiovascular Research Foundation from New York. Thank you again for the kind invitation to the Transcatheter heart valve meeting in Greece this year. Unfortunately, I'm not going to be able to be there in person. So thank you again for, inviting me to present virtually. My talk is about TAVR 2024 and to discuss the current state and future directions. What I decided to do is, instead of dumping a whole bunch of clinical data, I decided to talk about where the potential challenges and opportunities are, and what are the potential hot areas in TAVR innovation today. So maybe that way would be more refreshing and actually less data driven. I think that right now we all agree that TAVR has a proven performance and a good tracking record against medical therapy and surgery. There has been a very nice academic evolution of data generation and validation that it started with, prohibitive risk patients. And right now, I think it is fair to say that we have very good data, in all different patient subsets and risk profiles, even going down to low risk patients. And I think it's fair to say that is a very good alternative in the great majority of patients to conventional aortic valve, surgery. So TAVR innovation right now is moving into a different direction. And, traditionally in all type of patients that actually are, high risk and the conventional type of patient, the focus of procedural success is being on mortality, stroke, quality of life, and the need of a pacemaker or not. When we move into actually a lower risk population that actually are younger with more bicuspid incidence and actually higher longevity, the management metrics actually change. And the needs are actually more regarding hemodynamics, life expectancy and durability of the implant, and the possibility of reintervention. So I think that innovation metrics or innovation requirements are moving more from the implant itself and being able to implant it and actually have a successful implant into the durability of the implant and ability to retreat and do reintervention in the future. Right now, if you see the innovation trends in TAVR are actually more focused on durability in the low-risk patient, ability to treat bicuspid disease, ability to treat different type of populations, especially when the orifice is narrow, naturally or actually reintervention, the ability to treat patients that are asymptomatic with moderate state of aortic stenosis or other variations of aortic disease, such as aortic regurgitation. One of the big targets right now is bicuspid aortic disease. And even though we are actually treating, this disease with the conventional TAVR devices we have right now, I would even say that it is a time that actually we rethink the strategy and essentially start, thinking about potential ways to prepare the valve and actually have dedicated, device for this type of condition. Not only the aortic valve morphology is different, but the compromise of the aortic wall also is different compared to the conventional aortic stenosis. And the main challenges is not only the degree of calcification, but actually also the distribution of the calcification and the impact that actually these may have in frame expansion and adaptability to the aortic root. So even though, again, we're using conventional devices to treat bicuspid disease, right now there are discussions and actually new technologies that are trying to develop dedicated devices to treat these specific disease condition. Another area of intense investigation in which we already have dedicated devices is aortic regurgitation. The anatomical challenges is that the aortic sinuses and the annuli are larger. There is actually also concomitant aortic dilatation and insufficient anchoring because of the lack of calcium. And this is why, dedicated systems right now are under development and validated in clinical trials to treat this condition. One company that is making a lot of, headway is the J-valve, and right now we're doing, EFS investigations with this device. That is a dedicated device that essentially clips the leaflets to keep the valve in place. But the best, known device that already has, randomized control data is the JenaValve trilogy system that actually allows the perfect coaptation of the valve, and actually by clipping the leaflets, by actually putting these anchors in the coronary sinus, and allows for the perfect alignment of the device in patients with different type of anatomies. And this is perhaps the device that actually has the most precise data on aortic insufficiency, and actually aims to bring this device for these patients for this particular pathological condition. Another important subpopulation in which a lot of innovation will happen in the future is the small annulus, not only for actually women, but actually also for patients that already had an implant. So the small annulus, or the small orifice, aortic orifice, is an important patient population that will be, debated for the years to come, because the important unmet need that these patients actually have. The SMART trial essentially showed that there is an apparent benefit of devices that actually have a supraannular, leaflet attachment, but the word is still out in terms of what is the best system, device configuration, and innovation needs for this particular type of patients. Also, innovation is moving into what is actually so-called upstream approach, which is being able to treat patients they get very advanced in the disease stage. For this, we need actually improved diagnostic biomarkers, better access to care, and actually also technologies that actually can potentially delay the progression of disease. One thing that is very clear from large databases and actually global databases is that there is the great majority of patients with aortic stenosis are not properly treated. And this actually converts this into an opportunity for innovation, not only for screening, but for treatment, as well. That's why there is an aggressive push for, reclassify these patients with early stage aortic stenosis, and being able to essentially look not only at the degree of stenosis, but also to the degree of myocardial damage or cardiac damage, to be able to stratify the patient and define which of these patients could potentially benefit from preemptive therapy. The problem is we can create all these classifications based on clinical profile, hemodynamics profile, and cardiac damage, but the amount of variables are actually significant and very difficult to put together. That's the reason why there is a big push for the use of artificial intelligence and deep learning based on actually large databases to be able to create algorithms that allow us to be able to define which is the patient population that could potentially benefit from preemptive therapy, despite the fact the aortic stenosis is not severe. And I really think a lot of work in the future, will be derived from large database work to be able to screen, diagnose, and stratify risk to treat actually patients before the aortic stenosis becomes, severe. But one thing that is important is that we talk about durability before we go into lower risk population, because and I am actually a believer of this. Until we actually have really long-term, data, not only clinical but actually also hemodynamic data, that really these devices are actually safe and durable, is going to be very difficult to advocate to treat patients with less than actually severe aortic stenosis. It is important to acknowledge that now with the new generation trials, we're also getting great durability data on the surgical side of things. So still, the data is not perfect, but I really think that very soon we're going to be able to have a very good, clear idea, not only on the surgical side, but actually also on the TAVR side, of what is the real 10-year comparative data, so we can start talking about going earlier in the disease stage in patients with aortic stenosis. Another thing is when we talk about bioprosthetic durability, there are a lot of definitions that actually are used. And even though the reported durability data is very good, we have to be careful, as the durability data that is presented highly depends on the definitions that are used. So these comparative trials and randomized data and long-term follow-ups of this study is going to be essential to be able to allow us to go into early stage of disease stage. Right now, I think it's difficult to really talk about going earlier until we actually have this data in our hands. But no question that leaflets technologies, are essentially evolving very quickly. We're now going into different way to process tissue, using the same tissue we have right now, but a different way to process, to cut, and to attach the tissue to the leaflets, and moving all the way to a wide variety of tissue-based biomaterials and synthetic and polymeric-based biomaterials that can really help us to achieve not only durability, but also reproducibility during manufacturing, and possibly decrease cost by essentially streamlining the way the tissue is processed and manufactured as well. And these technology advancements are already in our hands. Examples that we have, for example, Anteris, that has a new way, an innovative way to cut the tissue, to attach the tissue, to provide better hemodynamics. The Edwards Resilia tissue, that is actually another important step forward, or Foldax, that is bringing fully polymeric, leaflets that are, cut using robotic manufacturing processes, which is standardized and increases the precision of manufacturing, decreasing the possibility for failures related to lack of precision in the manufacturing process. Another important innovation area is going to be coronary access, and I call it the upcoming epidemic, because with the large amount of TAVR devices and surgical devices that actually will fail within the next 10 years, we're going to actually have, to have more tools and more technologies that allows to actually get access into the coronary territory. And you will see variations in frame design, but actually also, ancillary tools that already are developed and very advanced validation phases to be able to allow us to get access to the coronaries by cutting, scoring, and modifying the frames and so forth. So a lot of technologies will come that are going to actually help us to get better access to the coronaries in these patients. So just to wrap it up, and a tribute to our good friend Alain Cribier, that was a true pioneer in this field. One of the things that, he always actually said, looking for now, what is the next thing? So my friend Marty Leon essentially keeps saying, well, there is still a lot more to do in this field, which will continue to evolve, bring great innovation, bring great new alternatives to continue treating patients with aortic stenosis in the future. Again, my friends, thank you again for allowing me the opportunity to present, even if it's actually a virtual presentation. And I'm really looking forward to seeing you soon. And hopefully I will be in Greece, I promise, next year. Thank you.
Thank Dr. Granata, this is Greg Patakos. Thanks so much for a fantastic talk. Really, you covered a lot of ground. Our apologies about the time issues here in Greece. Time and scheduling is not our forte. We have a lot of other fortes. You'll come and see them in person when you visit. I'm going to open it up to questions from the audience. Is there somebody from the audience who would like to ask something for Dr. Granata? Otherwise, I have with me Mike Mack and Mike Reardon, who are both sitting here where you will be sitting next year, as you said. So we look forward to having you with us in person. Dr. Mack, you want to say something?
So let me ask everybody, but start with Juan. We only really have significant durability data at 5 years. Anything more than that is small numbers. What's your guess? Is there going to be any difference in durability between TAVR valves and surgical valves? What's your prediction, Juan?
So,
this
first
being
of all,
recorded.
it's great to see you. It's great to see you, from here. There is one thing that people don't realize when we compare surgical valves with percutaneous valves. And it's the fact that frame deformation affects the hemodynamic impact of lethal deterioration compared to a frame that actually remains intact and stable. That's why circularity and stability of the frame is very important. I don't really think that I can really predict which one is going to be better, is going to be worse. But one of the things that I can say is that surgically placed valves have the advantage of maintaining the benchtop characteristics that are reported in the literature. The valves that actually are implanted and actually tested in vitro, like percutaneous valves, are actually tested assuming circularity and the perfect hemodynamic performance. So I don't like to bet, but if you actually want me to bet, actually I would say that you could potentially see differences in leaflet deterioration when you compared deformed frames in not all the conditions, but actually in the conditions in which frame circularity has not been achieved versus the ones that actually have been circumferentially placed.
So, Mike, I know you said that this is not a class effect, it's valve specific, but
Yes.
in general, what do you think?
Well, in general, this is like somebody asking me in public which of my daughters is prettier.
Yeah.
There is no answer I can give that is not going to get me in trouble with somebody at some time, somewhere. And you really do have to say which TAVR valve and which surgical valve. What's really interesting to me is, first of all, I agree with you, Mike. Until you get to 7 years, you have zero idea. Until you get to 10 years, you're really kind of whistling in the dark. But we don't normally see it to start to fail till at least 7 years. And we're talking about 5-year data and low risk. And so we're going to need to get longer data. But then you look in the surgical world, and we have 2 new pericardial valves in Spirus and Avalus. Inspiris in the COMMENCE trial reported their 7-year data a year ago at AATS, and Paragon just has its 7-year data out, and yet we never ask how long are these valves going to last, because, quote, they're like surgical valves. Well, they're new valves, and new valves are going to behave differently. So I don't know what the answer is. If I had to guess, I would say the valves that, as Juan said, can maintain their shape and start with the biggest EOA are going to last a long time.
Exactly.
Greg?
I think that's a very good point. I think if I had to bet, I would tell you this, and this is kind of a win-win for surgeons and cardiologists. I think most TAVR valves under most situations are going to fare worse, but the difference is not going to be significant enough to convince somebody to get even a mini sternotomy or a right anterior thoracotomy. So I think there will be differences there, but I don't think it's going to be to the point that that's really what's going to change the evolution of valve operations.
Well, that was exactly where I was going with the next question. Let's just say we know absolutely for sure that TAVR valves last 10 years and surgical valves last 15 years. Is it going to make any difference?
Yeah.
And the comparison I'd say is, what's the best thing you can do for a Prox LAD lesion? Put a lima on it. It's the only thing that prolongs survival.
Right.
Yet, what does everybody
Mike,
get first? A stent. So
But I think it depends on the age of the patient, right?
Yeah, well, the older you are, the less years you have to save. I mean, it's
Yeah.
like by the time you're 80, doing a mitral repair doesn't make any difference because you're going to die
Exactly. Exactly.
I want some audience input on this. Everybody's been listening to us. Somebody's going to be bold enough. I see Dr. Kilitz there. We need input from the audience here to do a tiebreaker here about what's going on. Who has convinced who, and what are the conclusions that the audience is reaching? Dr. Kilitz, can we turn on his microphone, please? Can we have his microphone?
Actually, it was a very great presentation. And also in the presentation, we saw some of the new valves with the new tissue technologies, especially with the novel valves like Duravir and also polymeric valves. And polymeric valves, I think, will have a great contribution to the TAVI area, especially about the durability. And what's your opinion about this point also?
Dr. Granada, do you want to take this
That
question?
is being, polymeric leaflet technologies has been a dream for many people for decades. I mean, it's not really something
since
new.
Mike Mack and I were young, it's been a dream.
Exactly. And they failed miserably in the past. But one of the things that actually people don't realize is that leaflet deterioration, is not only dependent on what we just discussed, frame, circumferentiality and all that stuff. It a lot depends on how the tissue is processed. It depends a lot in how the tissue is actually sutured, to the frame. It has to do a lot with how the tissue is essentially prepared, sterilized, and so forth, and blah, blah, blah. Polymeric actually valves have a big advantage that the process can be standardized. That using actually robotics, every single piece of leaflet can be done the same way, can be attached the same way, and by adding a standardization in process, there is a potential that actually also, durability, improves. And also polymer science has improved significantly. And actually right now there are a lot of good data on a highly compatible biopolymers. So I really think that if somebody can really crack the code and actually make it work, and I presented a couple of examples of companies that are already doing that, I really believe this could potentially revolutionize, percutaneous valves technologies.
Juan, it reminds me of the quote that Norman Shumway made about xenotransplantation. It has a great future and always will. So, we've been waiting forever for polymer valves.
So there's good data. There's good emerging data that actually will be presented in neural valves, and I think is actually taking a second, wave of enthusiasm and excitement.
Well, I think they're getting smarter too, Juan, because right now if you just put it in 65, 70-year-old people, you have to wait 10 years to get any kind of answer. Now they're going over to India and they're finding these young women with rheumatic disease who need a biologic valve so they can have children.
Yeah.
As a stopgap.
They're going to see what's happening.
You put a 25-year-old woman, this Foldex valve in the mitral position. If it's working in 5 years, That's like 10 years of normal
It's a good
data.
bet. Yeah.
So
Exactly.
So we're going to see some accelerated answers on some of this now.
So
exactly.
I think Dr. Granata, you raise a very good point. I don't know if we took a poll of the audience, of the non-surgeons, how many people would realize that cardiothoracic surgical valves are still to this day hand sewn, right? It's 2024, and I visited the factory of one of the name brand companies, and you see people hand sewing thousands of sutures by hand for these valves that we're implanting. And so, if we're operating with robots, why aren't we creating the valves with robots? You raise a very good point about quality control, standardization, and all the manufacturing details that go into this. Dr. Mack, you were going to say something.
Yeah, I'll make two comments and ask anybody to expand on either one. The first is I see all these administrative claims series coming out that says there's an equal number of patients under 65 being treated with TAVR as there is with surgery. And I'm a skeptic. I'm not sure I believe it. It's not our experience.
Not my place.
Yeah, and if they are being under 65, they've got a decreased life expectancy for some reason. They're on dialysis or, something. And I know there's a couple of series out there now that say this, but I'm a skeptic about it. And my second comment is regarding treating earlier patients. I am very concerned about that. I view that like heart transplantation. You aren't curing a disease, you're trading one disease for an iatrogenic disease, and you don't want to start that clock until you have to. We aren't curing anybody with aortic stenosis unless you have a Ross procedure. You're trading for a biologic valve that we know is going to fail. And why would you want to start that clock until you absolutely have to? So Juan or Mike, do you want to respond to either of those?
Well, Mike, this is what we've always been told. Any valve is a disease in and of itself. It's just a lesser disease. And even a Ross doesn't cure you. It gets as closest as we can get you to a normal valve and normal survival.
Right. So today I just saw a patient who has a 5.3 centimeter ascending aorta, and he has a bicuspid aortic valve with 1+ AI. So this started a long conversation. What are you going to do with this guy? Am I just going to do the aneurysm? The new guidelines are up 5 centimeters, low risk, et cetera. Am I just going to do the aneurysm? Am I going to replace his bicuspid valve? Are we going to try and repair a bicuspid valve? Do we start, like Dr. Mack was saying, do I start the clock ticking earlier? Or do I say you've got 1+ AI or trivial to 1+, we'll see what the TEE says intra-op? Do we replace that valve? In the olden days, I think a lot of people said, hey, it's bicuspid, it's abnormal, replace it. I think nowadays there's good literature out there. If you have a bicuspid valve and it's functioning properly, I'm opening a whole new conversation here, but these are the conversations we have with our patients. When do you replace it? What's the benefit? And what's the clock that's ticking, as Dr. Mack said?
And the older you are, the slower the clock ticks. So the younger you are, the faster it ticks.
This is a 50-year-old guy, so.
It's ticking pretty fast for him.
Yeah.
So Juan, final comments?
No, listen, I completely agree with you. Look, I'm an innovator. I like new things. I like trends and all these things. But one of the things is when it comes down to taking care of patients, we have to be very thoughtful. And for me, actually, the comparison between durability, possibility of intervention, and longevity is the most important discussion to have. And I think that when you have somebody that has a life expectancy, we believe is going to be more than 10 years, I think at the present time, I find it very challenging to actually go straight and say we have the right solution with a transcatheter solution. So I think we have to be very careful and thoughtful, as you just said.
Thank you very much, Dr. Granata. It was a pleasure and an honor having you here. Dr. Mack, Dr. Reardon is phenomenal. Thank you so much for your contributions to this session. We're a couple minutes over, so we'll let you proceed with your day. Thank you so much. We look forward to having you in Greece next year.
All right. See you guys.
Bye-bye. And we have the next session coming up now, the Young Interventionalists and Fellows course with a focus on TAVI. Dr. Kanakakis and Dr. Sparias is out with some back pain, so I don't know if you'll be able to connect online. Otherwise, we have here Dr. Kanakakis, who is the former head of the Hellenic Society of Cardiology, who is honoring us with his presence today. Dr. Kanakakis, thank you very much for being here.
Colleagues, we have a very interesting session which refers to young interventionalist fellows course and focus on TAVI. My co-chairperson was Dr. Stathogiannis, which we can start with the first speaker.
Thank you very much. Thank you very much for coming to our meeting. Just to remind you, outside there's the training pavilion, so you can have some hands-on training. So we really do believe in training, especially the young generation. So without further ado, Dr. Kromidas, and he'll talk to us about echocardiographic assessment. Thank you.
Okay. Hello, everybody. First of all, I want to thank the organizing committee for the kind invitation. So we had a very interesting session about the durability of the valves. So it's very important to assess correctly the severity of the aortic stenosis. So our topic today is about echocardiographic assessments on TAVI procedures. There are no conflict of interest. So when we perform an echo, the first thing we look at is the aortic valve morphology. We try to identify the number of the cusps, because it's very important for the intervention, the presence and the degree of possible aortic regurgitation, the size, location, the amount, the extent of calcification, the annular size and shape, especially using 3D software, and possible subaortic membrane or anatomic structures like a sigmoid structure. And reminding the crown-shaped aortic valve anatomy, we try to measure the virtual ring, which is formed by the basal attachment of the aortic leaflets, and its correlation with the mitral valve. It's anterior to the mitral valve, and in between is the aortomitral curtain, and also the conduction system that it's in the membranous septum in the non-coronary sinus, important in case of the interventions. Common errors in their measurements when we use a 2D imaging and try to measure the annulus of the mitral of the aortic valve. This is on the left image. You can see the reason why we have most of the times underestimation of the area of the valve because we don't exactly measure the correct diameter. If we use 3D software, we have better accurate measurements, so it's good to measure that. See, here are some types of bicuspid valves that we may encounter and may have importance for the procedure, for the TAVI. And here are some examples, as you can see, bicuspid and tricuspid aortic valves. So we do a 3D zoomed image of the aortic valve. First of all, we want to measure the area, to do planimetry. We take two orthogonal planes, align them, and measure the cross-sectional area. And we can get good results with that, pretty accurate. Of course, there are automated software that can do that for us. The technology always helps us. And continuing with the aortic valve morphology, we measure the diameter of the sinus of Valsalva, the ST junction diameter, and the distance from the ostia. This is mainly done with CT, of course, but we can do that pretty good with 3D echo as well. We cannot report an aortic valve stenosis, the severity, we cannot grade it without measuring the dynamics, the hemodynamics of the valve, the velocities, the mean gradients, the effective orifice area by the continuity equation, the DVI, the dimensional velocity index, which is independent of flow, and of course the stroke volume, the transaortic flow. Of course, we look at the mitral valve. Is there any mitral regurgitation? What's the severity? What's the mechanism? Is there any mitral stenosis? Is there any calcification of the anterior leaflet? We look at the left ventricle, the size, the function. Are there any wall motion abnormalities? What's the ejection fraction? Any thrombus? Again, the stroke volume of the cardiac output. And we look at the right heart as well. As said, and I'll show in a slide later on, is correlated with the stage and the grading of the cardiac damage, the size and the function of the right ventricle, if there is any pulmonary hypertension, if there's any pericardial effusion. And summarized here on the right-hand side, if you can see on the slide, the imaging evaluation using the echo, as we said. Now, the straightforward scenario, the majority of the cases, we have velocities more than 4, mean gradients more than 40, and the area less than 1. That's the straightforward. We know it's severe aortic stenosis. But there are some cases where there are low flow, low gradient AS with less than 1 centimeter, less than 40 gradients, less than 40 velocities, with a stroke volume index less than 35. And normally concerns patients with ejection fraction less than 50, less than 40%. What do we do then? Then we normally perform a low-dose debutamine stress echo in order to increase the stroke volume, and then we calculate the projected area, so what the area of the valve would be if the flow was normal. So we need to assess the transaortic flow, and if it's less than 1, then it's a truly severe aortic stenosis. If we are not able, for whatever reason, to increase the stroke volume with a stress echo, we perform a CT and we measure the calcium score. And here's an example with the low velocities at rest. You can see heart rate 62 and then heart rate 77. So just a small increase in heart rate is a safe procedure. It's a severe stenosis. Another category is the paradoxical low flow aortic stenosis, similar to the previous one, but it involves ventricles with preserved ejection fraction. And it's more frequent in females and in older patients. There are conflicting data regarding the severity of the aortic stenosis, but generally speaking, the outcome is poor. It's important to exclude measurement errors. I'll show you an example of what we mean with that. And if there are inconclusive data, then again, we perform a CT calcium score. So on the left-hand side, we have a 3.9 meters per second with a 5-chamber view, but if we turn the patient on the right, we get a 4.9. So this is not a paradoxical low flow, it was a severe aortic stenosis. We just had to take a better alignment of the velocities. Another scenario is a normal flow low gradient AS, generally concerning patients with an area around 1 centimeter and mid gradients like 30 to 35. Most of the times it's a non-severe AS, and it's actually concerns patients with small body size, arrhythmia, or prolonged ejection time. And generally speaking, has better prognosis. And again, this is summarized on this slide. When we have a low flow, low gradient aortic stenosis, look at the ventricle, the ejection fraction, perform a low dose debutamine stress echo or a cardiac CT or both. The staging of the aortic, the grading of the aortic stenosis correlated with the cardiac damage. As you can see in stage 4, the right ventricle is damaged and there is pulmonary hypertension. So in terms of complication, if there is any severe aortic regurgitation, any severe mitral regurgitation, any pericardial effusion, any wall motion abnormalities, obstruction of the coronaries, or rupture or dissection. And mainly the aortic, what concerns us is the aortic regurgitations, which is not very easy to assess. So we tend to measure the area of the jet circumferentially or take the diastolic flow, reversal flow, as you can see here. So we planimetry with the flex slice, and you can see some examples of mild regurgitation using 3D as well. And this is actually the scheme of grading the severity. I'm zooming on the circumflation area. It's more than 30. With the color Doppler, it's considered to be significant. Continuing with the complication with generally major bleeding, we can see the left ventricle hypercontracting, any thrombus of the catheters, malpositioning of the valve, any fistula perforation. And post-TAVI, of course, we perform an echo before discharge, 1, 6, and 12 months afterwards, unless there is a new murmur or heart failure symptoms. And it's also we have to assess whether any patient mismatch. Also, we look at the valve anatomy and if there's any stenosis or regurgitation after the TAVI, if there's any thrombosis or endocarditis. And this is summarized here on the decision pathway outline on the right side with the heart team decision. Then we're assessing the paravalvular leak, procedural complications, and after TAVI, again, the valve function, the left ventricle, and the systolic pressures. A small vegetation in TAVI. And we can use advanced echocardiographic software with GLS and myocardial index to assess the prognosis as well. And sometimes in valve-in-valve complex interventions, the interventionalist may ask us to, there is suspicion of obstruction of the left main stem, so he may ask us to perform an adenosine stress echo in order to assess the flow and the flow result in the left main and the LAD, which we can do relatively easy. So in conclusion, proper patient and prosthesis selection for procedural surveillance and follow-up are paramount in importance of TAVI success. Echocardiography and multimodality imaging are important in all of the steps. Advanced imaging modalities and technical improvements with automated software, 3D TOE, 3D transthoracic echo, and GLS have increased procedural success rates. Transthoracic echo remains the mainstay modality for the assessment of prosthetic valve durability and detection of prosthetic valve thrombosis and endocarditis. And I'm closing with Professor Chambers, who was a giant in cardiography at St. Thomas's Hospital. Unfortunately, he passed away a few days ago. Thank you very much.
Thank you very much, Dr. Komidas. Just one question, and then we can get other questions as well. As we're learning now, DVI, do you also measure it before the TAVI? I've heard some, sometimes there's some echocardiographers that they tend to measure it.
Yes, DVI I consider to be as a very important measurement because it's independent of flow, so it reduces measurement errors, and also it's good to correlate it before the procedure and after the procedure and to see the change. It's a good relation to have in order to have proper assessment of the severity of the aortic stenosis. So I agree, yeah.
Is there any questions or someone else would like to make an input?
So congratulations also from me, Dr. Kromidas, for the nice presentation. One question from me would be, is there any place nowadays for TE or 3D TE periprocedurally? Do we obtain any important information during the procedure that we could not obtain with simpler orthography?
It's a very good question. In the beginning of TAVI, this was an important step of the procedure, but afterwards, because of the planning of the TAVIs, the good imaging for the CT, so they get all the measurements and the data from there, and most of the times they have all they want for the procedure. Of course, there are always some cases that they may ask us urgently to assess a complication during the cath lab, any pericardial effusion, any rupture, but most of the times it's not needed. We as echocardiographers always want to help and get a vision of the valve, but most of the times it's not needed.
The next presenter is Dr. Benetos, who is going to talk about preoperative CT assessment. Dr. Benetos.
Thank you very much for the kind invitation. I would say, to be honest, I don't feel very, very comfortable to be an imager between so many interventional cardiologists and cardiac surgeons. I will try to give some data regarding the preoperative CT assessment before TAVI. Some technical aspects. When we talk about CT acquisition for TAVI, we have two steps actually. The first step is the gated acquisition at the level of aortic annulus, and the second step is for the access, the non-gated helical acquisition of the arterial system. Both of them, of course, require contrast agent. This is the outline of my presentation. Some aspects regarding the role of CT in the diagnostic workup have already been mentioned by the previous speaker. I would like to emphasize the role of calcium score in cases of aortic stenosis that were not sure for the severity. And these are the cases, as already mentioned, with low flow, low gradient with normal ejection fraction, or with reduced ejection fraction but without stroke flow, stroke volume reserve in stress echo. We have two thresholds, more than 2,000 in men and more than 1,200 in women. Most of the times it's regarded as severe aortic stenosis, and this helps us to continue on with these difficult cases. At this moment, I would like to say that we have to pay attention in our measurements, even if it seems so simple in calcium score to measure it. We have to pay attention in motion artifacts, the so-called banana artifacts, because each calcification could be measured twice. In case there are pacemaker leads, we have to pay attention not to include LVOT calcification or mitral annulus calcification. Sometimes in the mitral annular aortomitral junction, it's difficult to recognize which belongs to the aortic valve and which belongs to the mitral annulus, and of course we should not include aortic wall calcifications. Going on to the main part of my talk regarding the pre-TAVI planning. The most important, of course, measurement in pre-TAVI planning is the annulus measurements, which is a plane at the base of 3 Hitch points. We put 3 Hitch points at the base of the aortic cusps, and we can measure the aortic annulus using different tools, freehand tool, polygon, or spline. We are cared for both area and perimeter and minimal and maximal diameter of the aortic annulus. Area mostly for Edwards, perimeter mostly for evolute R, in order to decide which size fits best for our patient. These are some errors that we can perhaps undergo when we measure aortic annulus. We should include the calcifications in the annulus measurements. After we measure the annulus, then we have the annulus dependent aortic measurements, which are of course the left and right coronary heights, which we are interested that they are more than 10 millimeters in order to be safe and exclude any coronary obstruction. The sinotubular junction height, in this case we measure also the height of the sinuses, we are interested that there are more than 20 in order to be safe for our TAVI implantation. Sinovalsalva diameter, sinotubular diameter, and ascending aorta diameter. It's very important that we mention in our report the degree of LVOT calcification in case there is one, because it's very important for the interventional cardiologist to know that there is excess of LVOT calcification, which can lead to potential complications, including PVL or even aortic rupture. We describe it with semi-quantitative measurements, including mild, moderate, or severe. Another measurement that we mentioned in our report is the fluoroscopic ankle. Actually, we delineate with the commissure of the left on the non-coronary cusp in order to bring at the same level the 3 coronary cusps and guide the interventional cardiologist which is the best fluoroscopic angulation. At this moment, I would like to say that there are, of course, advances in pre-TAVI measurements. This is a study design where they use the data acquired from the CT, they upload them to specific software which is called Mimics in order to make three-dimensional models of the whole aortic annulus and ascending aorta, and then they use other software which is called Phelps Heart Guide. They try to simulate the TAVI implantation in order to measure the risk for PVL before, of course, PVL or either pacemaker implantation before, of course, the operation. Other important measurements, which I will not go further, are for the access. As mentioned before, we perform also a non-helical, helical, and non-gated whole arterial system CT in order to measure our arterial system from the femoral axis up to the aorta. Going beyond to some more specific data regarding the RCT, since 2021 there is a new classification of bicuspid aortic valve according to CT data. So we say either there is that our bicuspid valve is tricommissural, or which is the functional bicuspid, as we said before, or bicommissural with rough type, or bicommissural non-rough type. Bicommissural rough type is a Sievers 1, and bicommissural non-rough type is old Sievers 0. You know better than me the procedural implications in case of BAV. We may have dilated or horizontal aorta, long raphe, low coronaries, dense leaflet calcium at the coronary ostium and near the commissure, and of course, which is very important, a calcified raphe or also a calcified LVOT. In case we have a bicuspid aortic valve without raphe, but with two commissures but without raphe, then the definition of the three-dimensional structure, we don't have three hinge points, we have actually two hinge points, so we have to be very careful in our measurements of our annulus plane. In bicommissural rough type or in tricommissural BAV, we have actually three hinge points, so we may proceed with our annulus measurements like in tricuspid aortic valve. It's suggested not only to calculate the virtual basal ring in bicuspid aortic valve, but also the virtual raphe ring, and also it's suggested that we have to measure the length of the raphe, and it's more than 50% of the diameter, or the volume of the calcium is more than 300 square meters, then we have to expect perhaps a transcatheter under expansion. Now some data regarding the valve-in-valve, what we have to pay attention to. There's of course a higher risk with valve-in-valve for coronary obstruction. The most important risk factors is the virtual to coronary distance less than 4 millimeters, and it will have a very narrow sinotubular junction. Virtual to sinotubular junction distance less than 2.5. There are some papers that they give some guidance regarding what we have to pay attention to when we have a valve-in-valve. So if our previous prosthetic valve extends below the coronary ostiums, then we don't have any problem, we proceed with the valve-in-valve. If the leaflets, or the posts actually, and we suppose the leaflets, extend above the coronary ostium and the sinotubular junction, then, and the sinotubular junction is very narrow, then it's the highest risk for coronary obstruction. And then we have to consider either other procedures more complicated, either basilica, for which we can't give guidance, or even for chimney procedure. In case there is a mitral prosthesis, mitral metallic prosthesis, we have to measure the distance of the annulus from the mitral valve. In case it's less than 4 millimeters, then there is a high risk for interactions. And closing to the end of my talk, the TAVI, the CT is very important also for recognition of post-TAVI complications, and one of these is subclinical leaflet thrombosis, which is called HALT, hypertension leaflet thickening. In order to see how often it is, we have to do studies. So we have to make routine to do CTs after TAVI, which is not a routine still. There are some studies which we try to perform in First Department of Cardiology in Athens in order to see how often is the halt 3 months after TAVI and if there is a correlation with peri-procedural complications. This is an example of an acute thrombosis, CT post-TAVI, where we see the hypertenuated masses in the aortic valve. And this is a case from my personal archive, recent with the post-TAVI CT in a case where a chimney procedure was performed, where we can see the stent extending from the left main towards the ascending aorta between the struts and the wall of the ascending aorta. In conclusion, dear colleagues, cardiac CT guidance is critical in TAVI planning. Good knowledge of anatomy allows accurate pre-procedural planning, especially in complex cases. Thank you very much for your attention.
Thank you, Dr. Benetos. Excellent presentation. Are there any questions from the panelists or any comment?
No, thank you, George. Great talk. A lot of things you mentioned. I'm wondering about you show us multiple ways of measuring the annulus. You said, I think, 3 or 4 methods of measuring the annulus, and I'm wondering if this is the reason, because sometimes it has happened to me to receive reports from different sites, from the same patient, and get different numbers. So I don't know if the way of measuring the annulus leads to different measurements. And the other point is that you show us computer models simulating the valve, and I don't know if you can simulate the valve-in-valve, a TAV in a bioprosthetic valve before the implantation, so in order to check and make sure that you won't obstruct the coronaries after the implantation.
Thank you for the questions. Great questions both. Regarding the first question, if there are differences in measurements between 2 readers, then most of the times it has to do that they define different plane, and not because the one uses polygon or the other uses freehand contour. So if you have exactly the same plane in both readers, then either the polygon is suggested to use, but whatever method you use, it's going to give similar results. Regarding the second question, perhaps I forgot to mention it, but in order to examine exactly what's the danger, what's the risk of coronary obstruction, you have to do a virtual implantation of the valve. That makes the software, so either with the shape of Evolut or Edwards, or either a ring is virtually implanted inside your annulus, and then you can measure the virtual coronary, valve to coronary distance. So the virtual distance, the distance that will come if you implant this specific size of valve in this specific annulus.
Okay, Dr. Zanis.
Yes, congratulations for the presentation. I would like also to ask, when we have compelling data from the echocardiography about the severity of the aortic stenosis, is CT pre-procedural planning accurate to guide what we're going to do if the aortic stenosis is severe? I mean, the CT calcium score or other parameters for the CT scan. Are these parameters accurate for decision making to do the procedure or not? I mean, if the aortic stenosis is severe or not.
I wouldn't depend on the CT. If we are sure from the echo or that the aortic stenosis is severe, then I wouldn't deny an operation to a patient according to CT measurements. Sometimes we do a planimeter CT and it doesn't seem so severe, the stenosis, but the echo report says it is severe. That most of the times has to do that in CT you measure anatomical structures, but in echocardiography you perform also functional studies. So it's different.
Sorry, but I mean also the opposite. If the echocardiography is not sure if the aortic stenosis is severe, I mean,
sure.
say in patients with let's say paradoxically low flow, low gradient AS, or other compelling cardiographic studies, then can we base our decision on the CT scan? If the calcium score is very high, if the movement of the...
In extreme cases, for example, calcium score more than 3,000, then I'm sure that's severe stenosis. In other, I have cases that the calcium score is 100, so I'm sure that it's not a severe stenosis.
I would like to ask how accurate is the measurement of the calcium in outflow tract in order to avoid some ruptures?
In calcium score scanning, it's sometimes difficult to distinguish between outflow tract calcium and aortic valve calcium. So sometimes you cannot exactly, because these are in continuum actually, these masses are connected, so it's difficult to delineate where it stops the aortic valve and starts the outflow tract.
Any questions? Dr. Pilates?
In cases with bicuspid aortic valve, which measurements do you give for valve sizing from annulus or for intercommissural distance, or the Casper method or Lira method? Which one do you use? And which one do you use do you give to the interventional cardiology in order to decide which valve and what size valve to use?
In clinical practice, if I have a bicuspid but tricommissural, I give the virtual basal ring as in tricuspid. If I have a bicuspid with RAF, the same, but also I give some more information regarding the LVOT calcification or the RAF calcification. Most of the times in bicuspid, these bicuspid valves with RAF, there is extended LVOT calcification, which I also measure, which I also mention. The problem is in cases of C versus 0, so bicuspid, bicommissural without a RAF. Then I give the virtual to basal ring, and if it's asked, then I also give the measurement at the RAF level.
Thank you very much.
Thank you, Dr. Benektos. Next speaker would be Dr. Mastrokostropoulos from the Naval Hospital. He'll talk about valve selection for a successful implantation.
Thank you very much. I would like to extend my gratitude to Dr. Spargia and Patakos for their kind invitation and to talk about a subject that is really interesting in my views. So when we're talking about successful implantation, what are we really talking about? Because if we see from the VARC3 criteria, if we say that we're going to talk about technical success, so it's just to implant one valve, the valve will work properly, and we will have no freedom from surgery or intervention related to the device. But if we're going to talk about lifetime management, then we have to consider all these different aspects, because in my view, this is a successful implantation. It's just not placing a valve correctly, but also to have no PVL, to have low rates of permanent pacemaker. So this is something that we must talk regarding a successful implantation. So this is where it all started in Rouen in 2002. And just for the history, they had only one valve, one available size, and only one valve available for this procedure. So what we have learned from 2002 is that we have a lot of data. We have many clinical trials. We have a lot of patients that have received this kind of therapy. And this has led to the revision of the guidelines 3 times in the last years. So now we are talking about the age of the patients, that above 75, we should have a TAVI and not surgery. And we have left behind us the surgical risk. But what we have in this, all of these years is that we have the available devices, they are evolving, and we have now the 4th or 5th generation in some kind of devices. But what we don't have all these years are head-to-head comparisons between the different devices. So if you're trying to say which device is better and which valve I should choose for my patient, we do not have head-to-head comparison. There are only 7. The last one is the landmark that we will see the results in the following week in EuroPCR. But we have seen from these studies that in some cases we had non-inferiority reached, but in some cases we did not. What is very interesting for me is that if we take the scope 1 did not meet the non-inferiority, so the valve was inferior regarding the SAPIEN, is that when they published the 3 years result, we saw that they had not any clinical significance. So the initial results in the 3 years, we did not have any difference between the people that received those two valves. So what we have known so far is that if we're going to consider lifetime management, we have to talk about PVL, about AV conduction disturbances, and coronary access. And what we don't know, because all these factors were not included in the randomized controlled trials, that we did not have enough data for bicuspid, we do not have enough data for multivalve disease, for severe CAD. So this we do not know. So if we're talking about some patients that actually have this, my answer, which is the proper valve, is we actually do not know what to do in this kind of cases. So all existing valve designs, they have strengths and weakness, and let's try to explore. What is very important, and I think that is the most important thing concerning when implanting a TAVI valve, is that the first valve matters. Because if we're thinking about lifetime management, you have to put a valve that will work properly for, let's say, 10 years, but then you will be able to implant a second valve if needed. So the first valve matters. And if we're talking about durability, from the US we have data, and they suggest that if there is a 62-year-old person that has to have a valve procedure, the valve must last for 20 years. So we do not have data for this, but the Americans say that if you're going to implant a valve at a 77-year-old patient, the valve should last 10 years. So this is something that we really must take into consideration, choosing the valve we're thinking. And why do we do this? Because we have now known that the age of patients receiving TAVI devices are getting lower. So in the US, there are people 65 years of age that have a TAVI procedure. So for these patients, we should be very careful about lifetime management. And what do we know? The notion, the 10 years trial, is that the difference between the surgical and the TAVI devices, they were similar. I would like to be honest with the cardiothoracic surgeons, because they are part of the heart team, that if someone looks at this study, they have to say that, okay, but you are actually comparing a TAVI device with surgical valves, but there are some valves that were implanted in these patients, the trifecta and the mitral flow, that are not in use now. So you're actually comparing something that we saw that it doesn't work. So if we're going to be honest, it's not our fault, because at that time the mitral flow and the trifecta were very good valves, but this is what we're comparing to them, with two devices that are not now in the market. But if we're going to pass this and see that despite this, if we're just considering the structural valve deterioration, in 10 years, the valve, the TAVI valve, works. So if we're not going to compare with something that it doesn't work, our valve, the TAVI valve, actually works, and the hemodynamics are very good. So what do we know is that if we're going for lower patients, we have data that the TAVI valves are compared to surgical valves in 3 years, they actually work. And what we're now thinking, and I'm going to skip this, is that there are some particular conditions that we must take into consideration. The first is the small annulus, because in the small annulus, you have to choose between a self-expanding valve and a balloon expanding valve. And the data so far suggests that when you go small, you must choose a self-expandable valve, because you have better hemodynamics after the implantation. And comparing the 4 valves, SAPIEN 3, Accurate Neo, Evolut R, and Evolut Pro, you can see that regarding paravalvular regurgitation, the balloon expandable valves are better, but if you're going to see the hemodynamics, and regarding the small and the large annulus, the self-expanding valve and the Evolut platform is better than the balloon expandable valve. And we also have data from this TAVI Small 2 registry that we know that with the paravalvular leak, the balloon expandable is better, but concerning hemodynamics, self-expandable, and especially the Evolut platform is better. These are also studies that shows us this. I'm going to move on, and I'm going just to see about this concerning small annuli, that you see that actually the mean gradient is better with the Evolut system. And sometimes you have to refer the patient to the cardiothoracic surgeon. This is a patient from our hospital. So she was a very small woman, 78 years of age. And when we did the CT, we saw that the annulus was 16.2 and the LVOT was 15.4. So we had a heart team discussion. We also included in the family of the patient and said that if we're going to do this, we can implant a valve, a self-expandable valve, but the hemodynamics, because they were going to be very small, wouldn't be good. And if she required the second valve, then it will be difficult for her patient. So we referred her to a cardiothoracic surgeon. She performed an aortic root enlargement, and the patient now is doing well with this. So not all patients, and if we're thinking about selecting the proper valve for the successful implantations, some people should not get a TAVI platform. So this is the study that was published recently concerning small aortic annulus. So because it was small aortic annulus, 77% were female, and what this showed us is that hemodynamically, and I'm going to this, the hemodynamics in the self-expanding, it was better than for the balloon expandable. So these are concerning all the SAPIEN, SAPIEN XT, SAPIEN 3 core valve and Evolut system, that hemodynamics really are good in both, but in the self-expanding are better. The paravalvular regurgitation has gone down going through the ages, but the balloon expandable devices are better. And if we're going to summarize this, if we have an LVT calcification, if we have eccentric calcified annulus, the risk of rupture with the balloon expandable valves is bigger than the self. If we have small annulus size, we can go with self-expanding. And for life expectancy, we have the notion that's the self-expandable valve, but for the balloon, we do not have data for 10 years. For permanent pacemakers, we know from the beginning that with the Evolut platform, the rates had 2 digits, about 20, but now they are moving on with the different techniques that we have implemented. CASP overlap, the digits now are 1-digit permanent pacemaker rate. So this is something that we should be considered regarding if the patient has a pacemaker, it makes our life much more simpler. I'm finishing. So the last thing and most important is coronary access after TAVI. If we're going to do a TAVI in a 75-year-old patient, we must be able to recanalize the coronary ostia. So this is the different frames that are available in the Greek market concerning with the aortic root. So we must know all these characteristics because, as Dr. Benetos explained in the CT, with the CT we can see this. We can see the different frames and how they work. I will show you 3 cases from our cath lab because we are trying to cannulate the coronary ostia just to have some expertise if needed. So I will go on, and this is very important and we must also take into consideration. The different frames, they are different. Some are more convenient in order to recannulize. If we're talking about balloon expandable valves, the majority, the coronary ostia will be up, so it's doing a normal coronary angiography. If you have a very tall frame, then you should consider, according to the anatomy, which device is suitable for your patient. So you must also know about the ceiling skirt height, because if you know about the coronary ostia, you will be able to see which, I'm finished, sorry. So these are the 3 cases from our lab. It's the different. The first one is it was a surgical valve. We implanted a core valve, and this is the result we were able to cannulate. The second is a Navitor. The third is Allegra. You can cannulate the coronary ostia. There are some techniques, and this is an Edwards in a TAVI procedure. We were not able to fully cannulate, but you can see that the coronary arteries are patent. We must do this, and we must cannulate the coronary ostia, because in year 7 after TAVI, about 17% of our patients will require some kind of cannulation. There is data, but we have problems, and we have problems with the self-expanding platforms. So this is, I will go on quickly, you have more door-to-balloon time, more contrast, more fluoroscopy time, and about 8% of the patients we cannot recannulate. So these are 3 studies, ReAccess, Align, and CAVIT. You can see that with the Evolut system, there is a problem. With the balloon expandable devices, there isn't such problems. These are all studies that are from Tarantini. I will move on to my last slides. I'm sorry for this. So we have patient-related and TAVI-related if we're going to re-access the coronaries after TAVI procedure. And finally, because the first valve matters, think if you have a low frame, you can put a second low frame, but if you have a high frame, consider having to cannulate this coronary ostia between 2 high frames. This is very difficult. And they have, each valve has based on Crohn, there are some kinds. What will help us is 3D printing. FEOPS, Dr. Beneto's already talked about this. There's also DASI. It's a similar algorithm that allows you to see exactly how your valve will function and if you have any problems. And finally, for me, each candidate for SAVR or TAVI should have a CT scan, because the patients already having a surgical aortic valve, we have to know the CT if we're going to do a second operation on them. The choice of the valve should be the heart team decision. First valve matters. When implanting the first valve, keep in mind the second, and a TAVI program should be familiar with at least 2 different devices. Thank you very much.
Very detailed analysis. Thank you very much. Indeed, we're very fortunate to have many valves, but we're still unfortunate we don't have many years of follow-up. Any comments from the panel?
Congratulations, Adonis. Just a short comment. I think if I'm trying to do a guess, in 10 or 20 years, I think the major valves will look very similar to each other, because they all try to combine the advantages that we are looking for. So at the end, I can hardly find a way that it will not look similar to each other, the future valves.
For me, the thing is that regarding coronary access is that balloon expandable valves have a certain pro against the self-expanding valve. It's not very easy. Sometimes it's impossible. The studies have shown about 8% we cannot cannulate the coronary ostia. So 8% is, for me, is very high, because if we're talking about an 85, 89-year-old patient, he may probably never need a coronary angiography after a TAVI procedure. But a 75-year-old, and he has a STEMI, and we say to him, okay, you had a TAVI procedure, but now for the STEMI, I don't know which is the culprit lesion and what should I do. So this is certainly a problem.
So the first valve matters when you have to do with a 70-year-old patient. When you have to do with a 92 lady, maybe
it's different. It's different. But regarding the coronary ostia, balloon expandable valves have a certain advantage. This is for sure.
As we know, the paravalvular link is less now. In a case of a small annulus, it's better to choose self-expandable in order to...
Yes, in small annulus, we have the study now that shows us that the self-expandable platforms are better in small annuli. You have better hemodynamics, and this maybe in the future will translate in better lifetime management. So we do not know this for sure. We are thinking that if we have better hemodynamics in 5-10 years, we will not have a structural valve deterioration. So the valve will function more properly. So this is because if you have a small annuli, the valve may not be fully deployed, so this creates any problem because it depends on how the leaflets are actually opening. So if you have a valve that has not fully deployed, the leaflets might have a small, let's say, overhanging between them because the valve is not fully deployed. So this may cause any problems, but we will know this in 5 to 7 years.
In this case, if we have a high grade of calcium, in this case, it's better to use balloon expandable.
Yes, but it depends how much calcium, because the possibility of rupture in the annulus is bigger with the balloon expandable device. So it's pros and cons. The CT will guide us through this.
Any question from the audience? No? Thank you very much.
Thank you.
The next speaker is Dr. Koliviras. He's going to talk about large bore vascular access. Dr. Koliviras.
Thank you very much for this kind invitation. Vascular access is a very important thing during TAVI procedure. As we know, transfemoral TAVI is the most commonly used approach. There is no need for surgical preparation. We can perform this procedure under local anesthesia. And in this session, we will highlight the importance of optimal vascular access and closure in TAVI patients. First of all, as we said, CT assessment gives us all the important information regarding vessel size and diameter, tortuosity of the vessel, common femoral artery and the iliac arteries, the degree and the location of calcification, and the bifurcation height. We have to examine each vessel, the right and the left side, separately in order to decide for the best access. And some possible problems could be the small diameter of the vessels, less than 5 millimeters, circular calcification, especially in the anterior wall of the vessel, and if we have a tortuosity plus calcification. How we can solve these problems? In case of a small diameter, less than 5 millimeters, we can proceed for a POBA, for a balloon angioplasty, or to use intravascular lithotripsy. If we have a severe tortuosity, we can handle this problem with stiffer guide wires like Landerquist or a backup Meyer. But if we have an extreme calcification, it's better to consider for a surgical repair or for another access. In order to make the perfect puncture, a good choice is to use either a fluoroscopy or a roadmap or an echo-guided puncture. Let's start with the echo-guided access. First of all, we have to distinguish the artery from the vein. Okay. By compression the probe, veins we know that are more compressible and pulseless vessels. We go down with the probe to determine the profunda and the superficial artery in order to locate the exact bifurcation of the common femoral artery. We turn the probe in the longitudinal view, as you can see down, and we search for the perfect target zone. And the perfect puncture should be at the superficial side of the vessel, and we have to avoid the zone that the vessel dives into the body. So let's see a video. We start in the longitudinal axis. We rotate the probe to the short axis view. Here we can see better the anterior wall of the artery. And just a small tip is to make the local anesthesia under fluoroscopy, under echo guidance, and to reach the adventitia of the artery, because in this way we have more effective anesthesia. The patient is more comfortable, especially if we use only under local anesthesia. And after local anesthesia, we go for the puncture in this view, in the short axis view. Another advice is to use the Pythagorean approach. We have to avoid to start our puncture too close to the probe and keep the same distance as the distance of the depth in the 45 degrees. If we use the fluoro, let's say that we start our puncture in the right side, we have to place a guide DIMA catheter in the contralateral artery. We advance a Grand Slam guide wire 3 meters or an Ironman. This is our safety guide wire, and it serves as a marker. And we make our puncture using this fluoro, targeting the mid-femoral head, and the marker, and we mark the guide wire that we have placed before. Our advice is to make all the puncture under echo, because using echo we have less vascular complications. To move on closure devices, there are different ways to achieve hemostasis to the vessel. We use ProGlide or Manta in daily practice. And few words for these closure devices. ProGlide can close arteriotomies up to 21 French, but we have to use it in 2 steps. At the beginning of the procedure to make the pre-close technique, and at the end of the procedure to make the management of the sutures. This is a suture-based technique with the ProGlide. Otherwise, the Manta can close arteriotomies up to 22 French, and we use it at the end of the procedure. And it's a collagen-based device. Few words about the ProGlide. Step 1 is to open the foot into the vessel. Step 2, we bring down the needles. Step 3, we deploy the suture. And step 4, we close the foot and we bring back the device. Just a video. This is the beginning of our procedure. We pull back the guide wire. We keep the 45 degrees and we advance the ProGlide. Is very simple, the technique. When the bleed, when we have back bleed, we rotate the lever, we pull back the device, we break down the suture, and we cut it, as you can see here. We close the foot inside the vessel and we bring back the device. Afterwards, we pull back and we take these 2 sutures ends. It is 1 suture with 2 sutures ends. We bring them together with a clamp, and we can continue with a second ProGlide. This technique is at the beginning of our procedure, and if we use a rotation of the ProGlide at 10 o'clock and at 2 o'clock, we end up with a crossed suture, as you can see in the right side of the picture. But our recommendation is to make a parallel suture technique. We don't have to rotate the ProGlides at the beginning. And with the parallel suture technique, we have less number of vascular complications. At the end of the procedure, we have to manage the sutures. As you can see, we recommend to do this with 2 operators. The one operator manages the suture, and the second operator pull back the large bore sheath. And using a device, the knot pusher, we push down the knot in order to close the arteriotomy, and we repeat this several times with the one suture and the other. We keep the guide wire for safety reasons at the first, and if hemostasis is achieved, we pull back the guide wire, we repeat this procedure, and we cut the suture, as you can see here. If ProGlide device fails, we have some steps to make. We can use an angioseal or a Manta device. If this fails, we have to proceed with a balloon inflation and manual compression, or to use a cover stent and Armanda, or to go for a surgical repair. Manta device is another technique, a collagen-based technique. It's very simple. We use the Manta at the end of the procedure. We remove the large bore sheath. We introduce the Manta sheath. We remove the introducer. We keep the guide wire always in place. It's like to use a big angioseal, and we proceed with the Manta device. Here we listen the first click, and you can see that we pull back the whole device. We have calculated the deployment depth at the beginning, and we rotate the blue lever. And in this way, we release the anchor inside the vessel. We pull back. There is a green and white, green and yellow indicator, and pulling back the closure device, we release the collagen. And in this way, the arteriotomy is closed. And there is a tool that we advance it to lock the collagen in the outer wall of the vessel. If Manta fails, we don't have many things to do. Bailout strategies is balloon inflation, manual compression, covered stent, or surgical repair. Choice closure study showed that MANTA was associated with higher rate of vascular complications such as hematoma, pseudoaneurysm, but we had a shorter time to hemostasis compared to ProGlide. ProGlide had many devices failures. And which technique is better, ProGlide or MANTA? At Eurointervention, a multi-close algorithm was published recently, which says that we have to start always with one ProGlide. At the end of our procedure, we remove the large bore introducer and we insert a 6 or 8 French sheath in order to make a small contrast with 5 ml of contrast, and we check it. If there is no extravasation, we can close the arteriotomy with one per close device or to use an angiosyl. If we have a mild or moderate extravasation, we can use a second ProGlide, but if there is a severe extravasation, it's better to use a MANTA. Using this algorithm, major vascular complications were less than 1%. In conclusion, I have to say that, as we said before, CT is very useful and a fundamental tool for planning TAVI procedure, especially the vascular access. We have to use echo for having less vascular complications. We have to know to manage vascular complications, and closure devices are essential for hemostasis and TAVI excellent outcomes. Thank you very much.
Thank you, Dr. Koliviras. Very nice presentation and very informative. Any comments or questions from the panelists or from the audience? Some interventionalists use it for the beginning to ProGlide and one angiosyl. Do you have any comments about any experience for this?
Yes, but as we showed in the...
Not as a bailout. Mm-hmm. For the beginning, use two ProGlide and one angiosyl.
I think that using the multi-close algorithm, we are safe, because if we use two ProGlides and one angiosyl, I don't know if we make a damage into the vessel or a vessel dissection or an occlusion. We don't have to be, how we say?
So aggressive.
So aggressive, yes, in arteriotomy, and to check everything at the beginning.
Any comment? Please.
Thank you very much for the excellent presentation. Did you try one ProGlide approach without any calcification?
Yes, we have tried, but I don't think that is a safe procedure to use only one ProGlide.
Yes, but it works, to be honestly.
It depends on the large bore sheath. If we use a 14 sheath, yes, but we can close with one ProGlide, yes. But if you use bigger sheaths, yes. 18 French,
for the 14 French sheath, for the transcatheter aortic valves, you know, many of them are working on 14 French sheath. One ProGlide approach is working.
It's safe.
Working, but if there is calcification, posterior or medial or lateral, and the angles of the ProGlide change when you use two ProGlide approach. This is very well published by Gilbert Tank. One is, for example, if the the place of the calcification is very, very important on CT. Sometimes posterior and medial calcification. Then you put the one ProGlide at 11 o'clock and 2 o'clock. And if the lateral calcification, 1 to 3 o'clock, 1 to the opposite side of the 3 o'clock. This is a new concept for two ProGlide approach, but your parallel technique is also very, very important. But in our experience, really, nowadays, in 14 French sheet, a lot of people, operators also in Turkey, are using one ProGlide approach.
With one single arterial access or with
one 14 French sheet, one ProGlide at 12 o'clock position.
Okay.
Okay, thank you. Thank you very much. Yes. Dr. Triantafylou. Micrófono. Aquí.
Just a short comment. Congratulations for the presentation. It was complete. For the algorithm with the MANTA, in order to if you arrive at the final salvage by MANTA, you must have not forgotten to store the image of the puncture, because you will be based on that. So, okay, you do the echo-guided puncture, but you must store the image of the needle at the point of puncture, because then you must advance 2 centimeters.
This is a very good comment.
Okay.
In our daily practice,
do not forget that.
Yes, we do the same. We use
can
fluoro
save the
and
day.
echo.
It can save the day. And beware of arteries, common femorals, with diameter less than 6 millimeters, because the anchor of the MANTA can cause obstruction. Okay.
Okay.
Just.
Thank you. Thank you very much. Thank you.
Thank you very much. So for the last speaker, we have a recorded case from Dr. Chris Cook. He's a consultant structural interventionalist from the Essex Cardiothoracic Centre from the UK. And he'll talk about how to perform finally this procedure.
Hello, I'm Chris Cook, an interventional cardiologist from the Essex Cardiothoracic Centre in the UK. Apologies, I'm unable to join you in person for the Young Interventionalist section of Transcatheter Heart Valves Greece 2024. But here I've recorded for you a case of minimalist transfemoral TAVI with a balloon expandable valve, and I've intentionally provided extended teaching on vascular access and closure, which remain the most important skills to develop as a young TAVI operator. Okay, enough from me. I hope you enjoy the next 10 minutes and hope to see you in person next year.
And what we're trying to do is find the femoral head. So you see that's just there coming in at the bottom of your ultrasound image. And I'm just going more medial very slowly. And you can see that you've got the artery there in the longitudinal form. I know from the CT scan that this is a low bifurcation, but I'm just gently coming down to try and appreciate that. Sometimes it's a bit tricky, particularly in tortuous arteries, but you see there's a nice bifurcation there. Then go slightly higher up again, perhaps a fleck of calcium. And then what we can do is just rotate 90 degrees, and now we've brought that vessel into the short axis, and it looks like a nice anterior wall. So I'm just now going to keep my left hand nice and planted, and you can see it's approximately a centimetre deep there. So that means I'm going to come about a centimetre away from the probe in order to do a 45-degree entry point. So I'm just going to give some anaesthetic to the surface of the skin. So I can do that blindly, really. I'm not looking at the ultrasound. I'm just giving some anaesthetic to the patient there. And then what I want to do is keep, as I say, my hand nice and planted with the left side. And then what I'm going to do now is concentrate and get slightly more onto the artery itself. So now I am looking at the ultrasound, and I'm just bouncing around to make sure I get the right trajectory. And I want to see my needle tip, there we go, just on the vessel. So I'm going to go either side of this and give anaesthetic to the adventitia. You can see my needle tip. I'm sort of calibrated my movements now. And again, just small amounts around the vessel to get a nice anaesthetic effect. And again, keeping my hand nice and planted, I'm now going to come away with the anaesthetic. I now have my micropuncture needle. I'm going to go in through the same access site, really. And then what we're trying to do now is just to get that needle tip right on the top of the vessel. So you can see just there, we're coming in at 12 o'clock, and I'm happy there. So I'm going to pop through the artery. I keep my left hand still there. And then what I try and do is just wire directly like this, and there's no resistance. At that stage, I'll stop and we'll move on to screening. First, we can see where the needle entry point is. So you can see that's right on the top of the prosthesis, which I'm happy with. And then here comes the ProGlide. Now I tend to have a wet swab here so that it just makes it nice and lubricious. I'm going into the artery, and then at about this stage, I then transition to hold the device like a pen, and then go into so, and then my second operator will kindly pull back the wire. I still control the artery proximally, just to make sure it doesn't prolapse at all. And you can see there's good flow. I don't go any further. I come to 10 o'clock. Number 1, lift the foot plate. I then go slightly vertical. 2, fire the suture. 3, harvest, cut. And then you must remember stage 4, which is to drop. I then come out, and then I push in slightly. and that brings both the sutures towards me. My practice is then to slightly pre-tighten. Thank you. And then I'll just go back to control this. We'll bring it out to the white marker, and then we'll rewire. So what I'm wanting to do is just put this at the base of the non, which I think is there. And then we're going to do an injection. Are you ready, Rajesh? Thank you. So this is Edwards up. This is the new sheath. I tend to go into the artery just to plug any bleeding. And then what we do is find the ring and just slowly going up. We'll try and go either side of where, so that's into the non, and I'm just rotating this catheter and progressively seeing if I can get into the left cusp as well. Sometimes a bit tricky in these tortuous cases, and also where there is horizontal. So I can put the catheter into what I think is going to lead me onto that left side, and perhaps as I come back it may cross. So I'm just making small movements, starting as I go, trying to time it with the heartbeat somewhat. So I can go on either side there. So I think it's somewhere in this region. And it was across there. There you go. So it's across. So I've just stopped everything. And you can see that the wire is now across the valve. What I then do is fix this wire. And I bring the catheter over it. I don't want it to go too far into the LV, but I want to have enough support. I come back with the wire. And now I'm just going to prolapse this catheter down to the apex, like so. Thank you very much. In goes the safari wire with the introducer. And this is sort of push me, pull me technique. So as the wire goes in, you see the catheter just taking an even nicer shape with the tip facing away. And I'm going to push on the wire as I come out of the catheter, like so. And I fix the wire now, and I'm just walking back the catheter. I keep an eye on pacing just to make sure that I haven't caused any high degree block at this stage, which I haven't. And so now I'm just going to walk out this catheter. It's exactly as I'd anticipate it in a horizontal anatomy. And we'll just bring this valve around the arch to a vertical portion. Okay, so next we're going to bring the balloon into the actual valve itself. So the way to do this is we unlock, and then I just bring this in like so until the white marker is shown on the delivery system. I relock. And then now what I'm doing is, you can see on the screen, is bringing this balloon in. Now what I'm going to ask my radiographer to do now is to go more cranial, please, with the image intensifier. And what we're trying to do is square off the top of the valve. Very good, you can stop there, thank you. And I'm just going to bring it in, maybe 1 or 2 more millimeters. Okay, so we're going to bring this around the arch. Excellent. And then now we're going to get ourselves in position to cross the valve and then ultimately deploy it. So if we can just sort out our view, if we can see more of the left ventricle, please. We're less concerned about around the arch now, Tony. So what I'm going to do is going to cross, and I'm going to keep some of this flex on as I go because of the bicuspid nature. And just push that wire on a touch more for me, Rajesh, thank you. So here we go. We're going to cross this valve now. The nose cone is already across, like so. And then I'm going to bring back the pusher now. So if you drop the magnification, what you'll see is as I pull this back, you'll see that the pusher there is coming back, and I tend to bring that like so, and then I relock. That's very good. And then, Rajesh, if you won't mind just testing for me. Excellent. Okay, so we can mag to 22. It's a little deep for my liking. So the first thing is just to make sure the wire is truly at the apex, which it is. And then I tend to use this fine adjustment wheel. So I'm going to rotate this fine adjustment wheel, and you can see it's actually bringing that valve up in a controlled way. So a little test for me. That looks quite good to me there, Rajesh. Make sure my pigtail is indeed at the apex. And you can see because of the tension in the system, the actual pusher has come forward. So it's really important to always double check that. So I'm going to unlock, and I'm actually going to bring that pusher slightly back again. It can always catch you out slightly. And again, a little test for me, Rajesh. It looks very favourable to me, actually. Okay, so what we're going to do is clear communication here. So we'll have rapid pacing on, 180 beats per minute. Pacing on, please. 180 coming in now. And take an image. That's good, Rajesh. And you can start inflating there for me, please. So it's a nice and slow inflation. That's very good. Keep going for me, Rajesh. I'll bring the pigtail back and commit to it. Thank you very much. Save image. And pacing off, please. And Rajesh is back on the wire. And what I do is I just bring the balloon out, taking off the flex as I come. Looks like it's gone in nice and coaxial. And so you've got a mean gradient there of 5 or so. So that's very satisfactory echo-based result on the table. Thank you, Joel. It's a very nice result, I agree. So you've got a nice coaxial deployment. Things to look at immediately at this stage is, firstly, to look for coronary fillings. I can clearly see that on the left-hand side and also on the right. I can't see any significant aortic regurgitation or paravalvular leak that needs any clinical input here. So from my point of view, this is a very satisfactory result from valve deployment. Okay, Rajesh, so I'm going to introduce this, and it's a sort of, again, push me, pull me, out I come, keeping the wire in as I exit the vessel with the sheath, like so. Thank you. Make sure the wire position is stable. And then you're always working on the longer of the two. And I tend to clip on here so that I don't get too confused. Quite superficial arteries, these. So not a huge amount of travel on that first one. That's to be expected. And then now we switch over to this side. Again, I clip that there to not get confused. Wind this around my finger like so. On with the ProGlide and try and get that suture down onto the artery. Good. So as you can see, we've got good flow. There's no obvious bleeding, and you're also looking out for any dissections, but this is very reassuring indeed.
I think Dr. Cook is not available for discussion. Any comments from the panel or the audience? No. Thank you very much. Hope you enjoyed these ABCs on the Young Interventional session.
we are almost at the end of the day. This is the last session of this interesting meeting, and we have 7 very interesting cases. I think we should start. What do you think, Nick? With Dr. Kurkovelli.
Okay. Okay. So, hello. Thank you for all being here today up to this hour. So, in the next few minutes, I'm going to present you valve-in-valve implantation with the Allegro device. I have nothing to declare. So, the patient is an 84-year-old male who has worsening shortness of breath and fatigue the last 6 months. He has a history of surgical aortic valve replacement back in 2017 with a mitral flow of 23 millimeters. And he had a net rate repair of his mitral valve with a Pascal device in 2018. He also has Waldenstrom macroglobulinemia and hypertension. So his transthoracic echo, I will show you some images later on, showed the maximum velocity of the aortic valve to 4.1 and a mean gradient of 40 millimeters of mercury, and an estimated AVA of 0.9. His ejection fraction was good, and he had a mild residual mitral regurgitation. Euroscore was 5.1, and STS score 5.78. So he was on toracimide, olmesartan amlodipine for his hypertension, cilospir, and pantoprazole. This is his coronary angiogram. You can see his coronary arteries have no stenosis. And this is the echo showing the good LV function and the aortic stenosis with the mean gradient of 35 millimeters of mercury. With these views, you can appreciate the good movement and location of the Pascal device with the mild residual pulmonary regurgitation. So this is the CT angio. You can see that the peripheral vessels are very good with very mild atheromatosis. And on the left side, you can see the position of the Pascal device and the mitral flow. So more measurements in the CT. So we have the diameter and the perimeter of the valve. We have the height of the coronaries. More measurements just to make sure. And then we have this. We have our patient with the valve 23 millimeters, which is a fractural valve. And based on the application, we have different options, self-expandable and balloon expandable, just to choose. So we went with the Allegro device. The Allegro device is a superannual valve who received the CE mark for TAVI back in 2017, and then for a valve-in-valve in 2020. So one of the basic characteristics of this valve is that it has a squeeze release mechanism. So this is the orange button you can see, and in a position with the other valves that have to twist to release, and the implantation goes through 3 steps. The permaflow, the inflow release, where at that point you can receive the valve for repositioning, and the final detachment of the valve. This valve is from bovine pericardium, and as I already told you, is a supraannular valve. So this is the aortography, where you can see the aorta and the Pascal device. And on the right slide, you can see the pigtail in the left ventricle. The invasive hemodynamics, you can see that the mean gradient was 52, severe stenosis. And this is the Allegro device. And you can see the markers in the middle of